No, no history of melena, sir.
So what happens, what comes first, passage of high colored urine or discoloration of eyes?
Always is the first, the passage of urine is the first, and followed by the.
The sequence in which you
Yes, sir.
get.
Yes.
What are the causes of? One common paper I asked you, the causes don't call it clay colored stools because clay is present in different colors. It may
Yes,
be
sir.
a good idea to call it pale stools.
Pale stools.
What are the causes of painless progressive jaundice?
Painless progressive jaundice. Malignant causes might be C head of pancreas, periampullary carcinoma, or lower cholangiocarcinoma.
I think in terms of progressive and painless jaundice, you're keeping a malignant.
Malignant.
In mind. Right. Can there be a reason for a benign cause for painless progressive jaundice also?
There's a stitcher formation in the CBD, unlike this. No, sir, there is no history of any pain or any fever, any patient, sir.
The history, what you feel like, what the patient have, is how you're going to differentiate it. You get a patient with a jaundice, how you're going to differentiate that patient have a, can say, surgical jaundice or a medical jaundice.
Patients come with a no, sir, itching, severe itching is there, and passage of pale stools is this, which is suggestive of obstructive surgical jaundice. Sir.
Why you say passage of both means yellowish discoloration of eyes and urine? Can it be separate? Means it can it be a related one? Means there may be a yellowish discoloration of eyes without having a yellowish discoloration of urine.
So, in cases of excessive keratin intakes, first the
Eyes.
don't know. Hemolytic anemia.
This is your normal.
Yes.
What is the importance of asking for past history of pain in such patients?
If the patient has a history of pain, it might be suggestive of any gallstone disease, might be gallstone slipping into the CBD, might be possibility.
What is the importance of asking for any bowel complaints in the patient with obstructive? The causes of obstructive jaundice could be extramural, so additional involves 6 years after.
Yes.
And what do you think? She's talking later to you have yellow discoloration of sclera and urine. Is it a progressive jaundice or as you said?
It was progressive. There was no course of normal in between. So,
It's progressive.
One
single clinical criteria always tells you that it is a progressive jaundice.
Itching has been color of the stools is maintained in the constant.
So definitely. And it's usually safer to say the color is changed or it's lighter. Because there's hardly any, the clay they talk about when they mention in the books is the clay by the side of Thames River, which they used to collect for making the, which you have in other, in our country. So it's not clay color, it's lack of color.
Yes.
And as rightly said, absence of it is indicative of some obstruction. Now, besides what you possibly had in mind, it's a surgical jaundice, that's what you thought. Is there any relevance of finding out any prodromal symptoms?
Yes, sir. There is no history of arthralgia or malice. We have to rule out the viral hepatitis any cause. It is also in the stasis phase of it causes jaundice.
Would you like to specify the site of itching? Or
Generalized itching, but it is more pronounced over the trunks. It's the nerve endings increase. So,
Anything specific about the scratch marks that is
most of that Most of the times the scratch marks are with bleeding most of the times.
Let's move into examination.
Yes. General examination, my patient was examined in a well-lit room after taking informed consent with adequate exposure in the presence of female chaperone. Patient was cooperative, well-oriented to time, place, and person. Patient was afebrile, pulse 68, regular, normal volumic in the right radial artery. Blood pressure was 114 upon 76 millimeter mercury in the right arm in the supine position. Respiratory rate of 16 per minute. Patient's BMI is 19.1. Patient was well hydrated and with a Karnofsky performance score of EIT. On exam, icterus was present. There was no pallor, no clubbing, cyanosis, pedal edema, no generalized lymphadenopathy. Scratch marks were present more over the chest wall. No signs of liver failure. On inspection, abdomen is normal in counter. Umbilicus is centrally placed in the midline and inverted. A horizontal scar of 1 centimeter was present just below the umbilicus. All quadrants were moving proportionately with respiration. There was no visible lump, pulsation, dilated veins. Hernial site were intact and renal angles were free. On palpation, abdomen is soft, no tenderness. A gallbladder of 5 cross 4 centimeters is palpable in the right hypochondrium, extending into the right lumbar region with smooth surfaces and regular water. No splenomegaly, no renal angle tenderness. External genitalia is normal. On percussion, liver dullness was started in the fifth intercostal space and is continuous with the dull node over the lump. Liver span was 12 centimeters and no clinical evidence of free fluid. On auscultation, normal bowel sounds were heard with no bruit audible. Parietal examination was normal except for the clay color or pale fecal staining was present over the gloves. And systemic examination, cardiovascular, respiratory, and neural examinations were within normal limit. Summary is a 55-year-old lady with a painless, progressive, yellowish discoloration of eyes and urine for 5 months with passage of clay color stools and generalized itching for 4 months with a history of loss of weight and no history of fever melena. On examination, icterus was present with a palpable gallbladder of 5 cross 4 centimeter with smooth surface in the right hypochondrium extending to the right lumbar region. My provisional diagnosis is case of obstructive jaundice, most likely due to malignant etiology. Keeping in mind, first diagnosis was carcinoma head of pancreas.
You see, most students opted for obstructive jaundice to present. We had yesterday, today, tomorrow. And they usually prefer it because it's by and large straightforward and most of the examination goes in discussion about obstructive jaundice, preparing the patient for surgery, so they find it very comfortable. Therefore, make it a point to speak about your clinical findings very, very clearly, right? And you cannot say there was a gallbladder of hypertension. There was a lump, probably a gallbladder, which was this. All gallbladder is fractured. Usually, I just observed it before I pass it.
In your diagnosis, as you rightly said, obstructive jaundice, most likely malignant etiology, see a head of pancreas, you must, just for your memory, you should make an anatomical, a physiological, and a pathological part of your diagnosis in your mind. So anatomically, we have only one thing which we see, that is a palpable lump in the right upper maybe a gallbladder. And this obstructive jaundice is there, and then you come to what exactly it is. You think first thing is a malignant etiology, probably head of pancreas. So it would be a nice thing to include that as a part of your diagnosis. That is a palpable lump or palpable problem.
Why have not kept carcinoma gallbladder as a first diagnosis? Because when we talked about the incidence is more common in our setting.
In the carcinoma gallbladder, the patient will complain clinically about a pain in the past. There will be history of pain, sir, due to the gallstone presence of most of the times carcinoma gallbladder is associated 90% with the gallstone disease, sir.
We have said the carcinoma gallbladder with the carcinoma in the neck of
the
so that may be the first diagnosis, maybe the first diagnosis, rather than being a carcinoma head, which is a way is comparatively uncommon in comparison to carcinoma.
Usually, though most of the gallbladder cancers, when you make a diagnosis of CA gallbladder, ideally it should be a palpable mass, gallbladder mass. Though large number of CA gallbladders don't have a palpable mass. But still, for all examination purposes, we should make a diagnosis of CA gallbladder. Sir, Dr. Preoperative said, less common hai, but in this scenario, there is a palpable gallbladder. It is not a mass, gallbladder mass. So let us keep perioperative as well, and we will see it in the other section.
And secondly, if I may, they both have spoken the right thing in the same thing. Divide your answer into points in history and points in examination, because you are otherwise getting lost with only one point, pain or no pain. But pain may be there, may not be there, they may have asymptomatic, 90% association is there, but may not be polycystitis. But by and large, you will be. Number two, is jaundice early or it's late to gallbladder cancer? Yes.
Patient with a gallbladder cancer,
Early,
it is a late presentation.
not so
Not
late that it's terribly late, but it is not the first presentation. Okay? And as both of them was mentioning very clearly, with a lump palpable, they're on examination. What happens to the gallbladder when it is a diseased gallbladder, except
Surface.
It'll be a mass, we wouldn't have the defined territory.
Irregular
It
portals.
contains characteristics anatomically, right? That's why it's a good idea to divide it into the anatomy of it, physiology, pathology of it. Therefore, answer by saying, in history and on examination, it becomes easier. Even in your mind, it gets done.
What is good voices?
In a patient with obstructive jaundice, if a gallbladder is palpable, it is seldom due to gallstone disease. It might be due to malignancies.
Is the history of fever important in your patients?
Yes, ma'am. Fever is very important because if there is a fever, it is suggestive of any cholangitis or
This is polyneuropathy.
patient will have fever, tachycardia, patient sepsis. No, yes. Fever may be intermittent fever might be there.
Subsequent fever is associated with chills and
Rigors,
and there will be aggravation of jaundice also with
fever episodes.
episodes of fever.
What is the cause of jaundice in the patient with carcinoma of gallbladder? Because when we talk about carcinoma of gallbladder, pathology is there and what we said there in the. So what is the cause of jaundice here in this patient?
The neck might be compressing the CBD or direct involvement of the CBD can be done.
Sorry, but where is CBD? After
Cystic duct.
So you should be saying hepatic duct. or
Hepatic
block.
duct.
No, that's
Yes,
what
sir.
you're saying. You should pressure on the CBD. There can be a direct pressure on it. But what he's asking is the usual cause. I was only correcting you because we tend to say everywhere it's a CBD. CBD starts after the cystic duct.
Yes, sir.
Yes, sir.
What is the cause of jaundice in the carcinoma of gallbladder?
It might be due to pressure on direct porta.
There is no direct pressure there in the porta. There is a lymph node which is involved there in the porta, which compresses.
Sir, sorry to interrupt. We are unable to hear, sir.
Oh, Harsh. The fellow who fix her because there are more people outside than inside. Just please hold on. We're getting it fixed.
Yes, sir.
Yeah, the commonest cause of jaundice in the patient with carcinoma of gallbladder is the lymph nodal
Lymph node.
involvement there in the porta, which compresses the bile duct there in the porta, because that is the fixed point. And therefore, any enlargement or any means lymph nodal enlargement in that area lead to a compression of the bile ducts. That is the hepatic ducts leading to a jaundice. That is the commonest cause. And second is, since it is the region which is present there in the neck of the gallbladder, there may be a direct infiltration there of the CBG. What are the other causes apart from that? The other rare causes like
Metastasis to the liver, and because
as we have said, there may be a gallstones, there may be a concomitant stone there in the CBG. So, okay, and then of course there may be a metastasis there, but that may be the cause.
Why is it late? Why is the jaundice late? And it's called that. The one I think I'm repeating, all those who didn't hear it before, we have discussed so far. What is the cause of obstructive jaundice in patients with cancer gallbladder and why is it late? These are 2 points we are discussing for the online people. And the first one has been already answered, that the usual reason for obstructive jaundice in cancer gallbladder is obstruction at porta. Second is direct infiltration of the common bile duct, which also makes one of the The second one resectable, first one non-resectable for reasons we will be getting a margin or not. So jaundice doesn't make it non-resectable, but in that acceptable case. Why is it late? It's a question. You would either know or you would know.
No.
It's okay. It's same on that, right? Anything to do with the lymphatic drainage of gallbladder?
So gallbladder has a retrograde lymphatics. First it goes to celiac, then it comes back to the
Yes,
hilum.
you know, if you look at the embryology development, basically the peritoneal deflection decides. So it goes down first and then it will ascend up. So that's a little delayed. That's why even yesterday when you saw the video of radical coding, the first thing we do is photo cable
lymph node
corrosion to see that it's not involved. If that is involved, it's an M1.
M1.
So therefore, please be clear on that. One reason is this. Any other? Which is the most common site for carcinoma gallbladder in the gallbladder?
Fundus is the most
So
common.
it's not really directly involved, which is rare. That's why you put neck involved,
Yes.
right? So these are the two reasons for delayed jaundice presentation. But that delay should not be long. I don't think it is going to be eternally far away. Okay? So what that can help you make a decision. Yes, doctor.
If you find free fluids on clinical examination in such patients, is it suggestive of metastatic, is it a disseminated disease? Suppose
No.
in clinical examination we found free fluids.
No, ma'am. Most of the time.
Why is it not?
In the patient with jaundice, most of the time there is a third space loss is there. Most of them collection is there. Yes.
But keep in mind, though we have periambulary CA as the last differential diagnosis, but a large number of periambulary carcinomas do not present with fluctuation of jaundice.
Yeah, sorry, I think I mentioned that, Dr. Manoj mentioned that before also. Why did you say head of NPS per se? Is there some specific reason? You kept periambulary at the end.
So there is no history of any melena or there is no course of action.
What's periambulary?
It is the involvement of the preampular is involvement of the structures within 2 centimeters of the ampulla that might be, yes,
What all does it involve?
distal CBD of 2 centimeters, pancreatic duct of 2 centimeters, and the 2 centimeters around the duodenal margin.
Ampullary variety,
Duodenal variety,
head
head
pancreas, and distal cholangio.
Yes.
Right?
Yes.
Which of these will produce the intermittent and fluctuating jaundice? Only one type, no? Which one?
Ampullary variant will
So you can't
produce
say periambulary, you have to have that.
ampullary variant.
Melena actually
Yes.
covering it.
Yes.
That's what Dr. Manoj is trying to ask you.
Why at all they have melena?
Melena, because the tumor sloughs off in between intermittent. It
Can
causes
you speak loudly because
the tumor.
People online are not able to hear you.
The tumor sloughs off. The center part is less vascular. So many times it sloughs off. It produces bleeding. It causes melena. Oh, thanks.
So the necrosed part.
Necrosed.
So it tends to
Slough off.
And the duodenal variety, how would it present?
Most of the times it presents with a gastric outlet obstruction.
Good. And which one is got the best prognosis?
Duodenal variety.
Very amusing every time you end up there. I got the same answer. You just see.
Common bad luck.
Ask you
CBD
again.
variants.
Yeah. Okay. So what would you do? And would you like to revisit your differentials now? We have given you a lot of wisdom. Knowledge is a problem sometimes. Wisdom is more important, right? So how do you realign it?
I would go
So
with the carcinoma gallbladder neck
what is
involving
the
the first.
It's a lady, no?
As a lady.
55 ladies with presenting with obstructive jaundice, probably due to a malignant etiology, likely to be. Is it periambulary that will put up now or head?
I will put up
What are the features of a head pancreas? How would there be a past history or associated history?
association.
Can you
Yes,
speak
sir.
the mic loudly, don't muffle, no? Sounds right. There is a wrong answer, there is a problem. You come here to learn, no?
Yes.
If you knew it all, why don't you come here? Okay.
But keep still carcinoma ahead of pancreas.
They usually would have some history of pain, back
Pain,
pain.
like
Features
radiating.
that indicate posterior, the splenic nerve getting involved. So it is usually it is safer to be if there is no palpable lump, which is relatively. And she asked about Coverge's law. What is it? A law or a hypothesis?
It is hypothesis.
Why is it so?
From Chinese liver fluke disease, Mersey's disease sometimes.
This is okay, but importantly, primary
Prime bile duct stone.
the form there, then gallbladder is got nothing wrong with it. It's, the patient will have Coverge's law suggestive or positive in these things.
Most up to 30% of the patients.
It's 30% is too low. It may not be present, as Dr. Puneet mentioned, you may have stones slipping down and you may have coincidental stones producing the jaundice. Now, I think we move on. The question is how we proceed.
Oh, I would like to
Is it clear? So distant metastasis as such is not being used. It is a non-contiguous liver disease mostly being used there.
No, that's about liver only, Dr. Kuni. That's not what ascites.
Yeah.
And so the term they often confuse is even in breast yesterday they were discussing. No metastasis. Lymph node metastasis is not distant metastasis. It should be clear. As long as it is within the resectable plane of liver, it is taken as a part of the disease, which you can possibly take out. But if it is away from it, you will take it as distant. And one needs distant metastasis. You get the point? So it is basically ultrasound to a lot of people. Pancreas is also quite well seen, as Dr. Rahul was mentioning, if you have an expert and a trained radiologist. But by and large, for your answering, it stops here. As long as you can exclude all those conditions, you need to proceed further. Correct? So what would you do next? How do we proceed?
Stage the disease, I would like to do a CT with a pancreatic protocol.
Now, when you talk of pancreatic protocol, is it specific to pancreas or it is relevant to liver or hepatobiliary system?
It is relevant to hepatobiliary system also.
So what are the components of this protocol?
Protocol has total 3 phases. First is the late arterial phase, photovenous phase, and the delayed washout phase is the hepatovenous phase.
Okay.
Is there any difference in the way you do a CT, other than normal CT and
Very good, very
important. Like the 3 phases, very important, venous phase, arterial phase. Any difference in the way or technique that CT is done? Because you will have to tell your radiology friends what to do, what they want from.
You don't know, so you
don't.
First, you have to decide to see there on ultrasound where is the site of the lesion. That decides the investigation you are going to plan. If you are suspecting it is a distal cholangiocarcinoma, you will be doing a MRCT rather than being a CCT. So similarly, if it is a carcinoma gallbladder, pancreatic protocol won't be helpful to you. So what I mean to say that you can plan your investigation based on the ultrasound. Therefore, ultrasound is going to help you out exactly what you are dealing with. Is it clear? And accordingly, you can advise the investigation. Of course, carcinoma head of the pancreas, if it is there, then you can do it with a pancreatic protocol. So, okay. So how the means CA head pancreas look like there on CCT?
In the delayed phase, it will be shining on the head of the tumor will shine.
Please, make it a habit, speak clearly and loudly with the mic. You're doing well, but you're not heard. And we have a problem with the online people watching.
See, first you have to talk about the arterial phase, how the carcinoma head of the pancreas looks like. Can you give a histological diagnosis based on the CCT? Most of the time, the CCT done with a pancreatic protocol can give you a histological diagnosis event, I can tell you. How it can do so? Most of the carcinoma of the head of the pancreas, they are whether they are hyperdense, hypodense, isodense. Hypodense lesion, hypodense lesion. At the same time, the neuroendocrine tumors, they are hyperdense lesion. So you can have a diagnosis whether you are dealing with adenocarcinoma or it is a neuroendocrine tumors that can very much be differentiated based on the CCT. CCT can most of the time, I won't say all the time, but most of the time can give you even the histological diagnosis. Are you dealing a case of adenocarcinoma of the pancreas or you're dealing with the neuroendocrine tumors of the pancreas?
Any role of side viewing endoscopy?
We'll finish with the imaging first, no? The invasive later. Anything more in the imaging? That's not done. He asked you a question which I think is very important. What instructions do you pass on to the radiologist? So you need to know where the lesion is, and accordingly the investigation might change. Endoscopic ultrasound comes in for a separate lesion, for a particular lesion. All three phases you should know. And when is the neuroendocrine tumor going to light up? In which phase is it?
In the arterial phase, hypertension.
So that these things should be clear. And many a times you are able to make understand the histology of the tumor by looking at the CT. Correct?
Yes.
So don't just say pancreatic protocol, which we hear very frequently. Everywhere pancreatic protocol won't work. Carcinoma valve, of course, we are not talking about.
Yeah. Now suppose your first diagnosis is head of pancreas. You have done asked your radiology friends to do a CECT. And as Dr. Puneet rightly pointed out, most of the adenos CAs are hypodense. So you see a hypodense lesion. Now what further?
Next.
Information.
Now we move on to, we moved on from imaging, we have to move on. Yes.
In
Now-
imaging
now-
only.
Pancreatic protocol, what tells you about pancreatic protocol? What does it tell you now?
What other findings?
Other findings.
Other findings you are interested in seeing the CCT. We have done a CCT.
Whether the tumor is resectable or not, I have to see for involvement of the artery and the veins. Involvement of the artery
Keep
and.
going, nobody's stopping you. Okay. So the second thing is, yes or no?
Yes, sir.
What else? Dr. Ratna, you're asking about imaging something more.
As far as resectability is concerned, what exactly would be the finding in an unresectable tumor?
You were asking.
Yes, you can complete answering that.
Suprasensitive artery, make it unresectable.
No, one, be clear on it. There are borderline, there are resectable.
Resectable, borderline and non-resectable.
If you know about borderline, you obviously know about both sides. So what are borderline?
Borderline, if there is an encasement of the portal vein, it is considered borderline.
Anything to do with abutment versus,
Abutment.
the term is now not used, but abutment versus involvement.
Abutment is involvement less than 180 degrees and encasement is more than 180 degrees.
How would you know it is infiltrated? Would there be something inside the vessel that you would see? What would, if I get a report, the tumor thrombus or something inside, would that be different from just the abutment? Dr. Ratna?
This is exactly what I was coming to, that you also have to look for intraluminal part of the vessels. Besides only tumor thrombus being present there, you also need to see if there is any evidence of portal venous thrombus sitting there or not, because it will change the prognosis of the patient. And secondly, to be able to say, how do you say whether the vessel is infiltrated or not? So you need to look for the
Little
back
fat
planes
pain
of-
loss. Yes. Yes.
Okay.
Here comes the role of this pancreatic protocol CT, vascular involvement, encasement, abutment, all these things. Otherwise, simple CT abdomen will definitely tell you about red of pancreas growth, mass, hypodense, hypodense.
Since we have four cases relating to the same, is there something more you would like to ask him, Dr. Puneet? Dr. Ratna? Dr.
You can answer if there are any abnormalous vessels that you may specifically look for. Is there any role of looking for anomalous vascularity?
We need, that's why I asked you that in the CT. This is important to know, so it's got a relevance.
Well,
So they add something more to it. At least at the new place where I've come, they do CT angio on their own. They ask, why is it important? Which anomaly she's talking about? It makes a difference when you're operating. You're doing a full surgery, this is often discussed. Maybe that question will be to the next candidate. Otherwise, we'll not be asking anything, so it'll keep on getting repeated. You've done if it is borderline resectable, what do you do?
I will confirm. I will prepare the patient before preparing the patient. I will see the operability on that.
Or non-resectable tumor, or you can operate it later on. How you going to proceed further?
If the patient, if there's a time to prepare the patient,
You know or you don't know?
no, sir.
So then say, you know, why are you wasting your time? When it's borderline, that's when you need to bring in more people, and therefore don't say I will do anything. You'll discuss this case in an MDT tumor board. Individually, don't take all decisions. And these are candidates for sometimes neoadjuvant chemotherapies. And that's why you need to have a tissue diagnosis for sure. So what is it that you can do? And it is usually a part of the algorithm now. What do you do in addition to what all you've done? Imaging is over.
Biliary drainage is important before doing your joint.
Hello? What
So,
do you do?
CBD. So drainage of bile. Sir. biliary drainage.
No, biliary
For
drainage,
new
nobody is
chemotherapy,
asking
if we
that.
are.
You're answering the next question. The question we asked you was the role of getting a diagnosis.
USG guide, US guided biopsy is taken to confirm the
So endoscopic.
endoscopic
This is
data.
what Dr. Ratna was asking you earlier. Which type of endoscope is used? I just
Side
told
view
you.
endoscopy.
Side view, in other words, you can't say. So biopsy should be attempted. You may get it in some, you may not get it in others, but US FNA. Anything else that US can guide you in?
If there are small tumors and lymph node status can be known in the site.
Why are you apologetic about it? Speak loudly, you are correct, you are answering well. No? Speak loudly,
Yes, sir.
turn into the mic, okay? Burning questions, Q&A.
So US have got an advantage that what you have diagnosed there on CT, you can confirm the findings there on US when you are doing it, because you have made a diagnosis that it is a borderline risk. It can be better assessed in the US. So first, when you're doing the US, see exactly, is it the borderline susceptible, because that can give you an idea about the encasement of the vessels better than the US than being in CT. And the next, then if you feel like it is a US.
Very useful. And is it mandatory to have a tissue diagnosis before you proceed? Suppose the report comes as equivocal, can you proceed or you stop?
Equal,
So the answer is if
proceed.
you're going for a new adjuvant chemotherapy, report is mandatory.
Mandatory.
They won't give it.
Yes.
But otherwise, you may, based on imaging, it is acceptable to proceed.
Probably FNA and biopsy would probably have more relevance if we on CT consider it to be an unresectable disease. I mean, before you send the patient away for some palliative treatment.
Yes.
Then
But it's a part of your algorithm. That's why we asked you. Upper GI endoscopy, side view endoscopy. So the last question.
Is side viewing endoscopy synonymous with ERCP?
Yeah, if
It is not.
No.
ERCP means that you have to do cholangiography and pancreatography, which you will not do in all cases. So when you need to talk about diagnostic methodology, you will talk about side viewing endoscopy, because it will also help you take a biopsy if you find that.
We request Dr. Seema to join us in the dance. We announced it came, but. So it reflects all of you say ERCP, that's the problem. And that can, in a static system, can precipitate pancreatitis, which is not a good idea. So that is what they're trying to say. Now, can we proceed? Now, if it is resectable, what are you going to do? Quickly tell us.
I will prepare my patient for the surgery by correcting the hydration, by correcting the coagulopathy, by giving vitamin K, and build up the nutritional status. If patient is taking orally, allowing otherwise, put the patient on total parenteral nutrition.
Right? You're okay with that?
giving vitamin D.
Vitamin K.
Yes. Vitamin K.
Yes.
And what else? Anything else in preoperative? Any role of
And
antibiotics?
if a patient is in cholangitis, if the features are there, then there's a role of
So
antibiotics.
nutrition, infection, coagulation, and hydration. Okay. Otherwise, you're okay.
What you have said is the parenteral nutrition that will only be recommended if the patient is
Not taking orally, yes.
Otherwise, you will give a enteral nutrition first there.
Mostly, right? Why enteral preferred over parenteral? In all
Normal.
situations, enteral is better than parenteral. Why?
So normal physiological
Physiological, next.
thing.
Something
Gut
extreme,
flow.
right? Yeah.
Integrity is
Mucosal integrity, villus atrophy prevented, transgut migration taken care of, and peripatetic circulation.
Circulation is
Bile duct, with the movements of the bile duct could stop, no? Polyposis can be avoided. So enteral is always better, exactly.
But and less complication, no complication.
Lastly, you have questions, anything you like to ask? So we will discuss variants of impulse later. We will do the question yesterday. Do you have a question? Have you assisted in the impulse?
Yes, recently in the 2 cases.
2 cases, very good, very rich. So what was done before you started? Please tell us.
Diagnostic laparoscopy
So,
will
we're
be
waiting for that to happen. Diagnostic laparoscopy is done in benign
Benign
conditions.
conditions.
Here it is staging.
staging
So put in a
laparoscopy.
scope. Why is it important?
If there are mets, omental mets which cannot be seen in the CT scan, which are less than 5 mm,
What
so we
size is
can
critical
up to 1 centimeter,
cutoff for what cannot be seen on CT and can be seen?
up to 5 mm, 5 mm to 1 centimeter is the
Absolutely. So
What I want to emphasize, it is not only the omental metastasis. So
Peritoneal
the
cirrhosis.
peritoneal deposits and the liver metastasis, those who are small, cannot be picked up there on CT, can be picked up there on.
absolutely.
laparoscopy.
And actually you can pick up resectability also to a degree. It's clever. And that can save a proper laparotomy in these cases. And you can get away with something less. So it's important because R1 resection in pancreatic, in periampullary or these cancers is worse than non-operative. It's important to understand resectability. Borderline resectable cases need to be discussed in MDT. All cases need to be discussed in MDT. Borderline would need some kind of a neoadjuvant therapy. You mentioned about decompression. Where would you go for it? Since you mentioned, we don't take it to the next candidate therefore.
In
Where
the-
is it indicated?
In the patient of the borderline, if we are planning for surgery,
Borderline, going for
if the patient is in, if the patient is in sepsis, cholangitis, if the patient is, patient has severe itching, intractable itching,
These are terms. That's why I'm repeating it for you.
and poor
Low performance, which means less than 60 per nostril or because 3 on this. So you won't be able to take out instant surgery. Any other indication? Rarely, if you follow the Japanese protocol, higher speed of bill, but nobody knows the cutoff. So 18 something, 20, so your answer is that. And if you need to build up the patient, delay surgery, putting on chemotherapy protocol, you need to have a really decompression, not as a routine. Right? You made an excellent presentation, don't worry about it, but learn to speak more clearly. As we say, Lima Charlie, loud and clear. If you don't speak what you've got in your mind, I would not know what is in your mind. And things not spoken are not heard, and things spoken are not necessarily understood. And what you believe I know, from what you spoke, may not be right all the time. It is the bottom line in itself. Speak out loudly and clearly. I know there are some challenges, but that's your problem. You need to get it. All right? Well done. That's a problem. And actually, sadly, there are just too many questions. You know, the whole idea about enteral versus parental, pancreatic protocol, building up a patient, optimizing a patient, following up, it all started with pancreas. That's why they Atlanta put about the Atlanta is the wing. If you go there in the pancreatic wing, they're just doing research on it. So this is one area where there is so much of theory to do. Therefore, be careful. Everybody opted, there are 6 people opted, with conversation. Because everybody wants to talk about optimizing a patient, following up, easier option. Gradually becoming a difficult option because you need jaundice. What's the next presentation by Terry Matthews? Big round of applause, ladies and gentlemen. He did a very good presentation. The next presentation is Shiva Ram Gauri. He was presenting case of obstructive jaundice. What's the next presentation by Come in front before your presentation.
नहीं ना ऐसे जा रही टूटी फूटी हम मैंने उससे डायरेक्ट दिए अब मैंने जैक से डायरेक्ट दे दिया यहाँ से ऐसे टूटी फूटी आवाज आ रही है
After 1 month, patient developed pain in upper abdomen with the incidence onset, non-relative, non-relative, relief or technical anesthesia. Patient developed patient also developed loss of appetite, ulnar appetite. There is no actual benefit of internal pain after 1 month.
Distant metastasis, no history suggestive of liver failure. Patient is not a known case of any chronic illness. Past history, no history of similar illness in the past, no previous history of any hepatobiliary surgery, no history of blood transfusion. Personal history, mixed diet, normal bowel habit, no history of alcohol intake. Patient has history of smoking for past 20 years, smoking index was 20, and history of tobacco chew for past 10 years. Sleep pattern is also disturbed. Family history, no history of any malignancy or chronic illness in the family. Can I summarize? To summarize my from the history, a 72-year gentleman presented with history of progressive yellowish coloration of eyes and skin since 2 months, which was associated with clay color stools and high color urine without any prodromal symptoms. The jaundice was progressive without any history of waxing and warning type. He also gives history of pain abdomen, which was insidious onset, dull aching pain since 1 month and generalized itching since 15 days, and with significant weight loss and decreased appetite. So from history, my provisional diagnosis is surgical obstetric jaundice, most probably due to malignant etiology.
One thing, Sivaram, what do you mean when you ask that no history suggestive of metastatic disease? What history do you expect?
Sir, I will ask the patient about any history of breathlessness or hemoptysis and any history of seizure and headache.
What prodromal symptoms do you expect in the patient?
Ma'am, fever, myalgia, arthralgia, and nausea to rule out hepatitis, viral hepatitis.
Loss of hepatitis? Loss of appetite?
Yes.
Right, that's a
Yes, ma'am. Yes.
Given this history, the patient started with jaundice and now has pain.
Yes,
Pain
ma'am.
abdomen has developed later with this tension.
Yes, ma'am.
What is your interpretation from this?
Ma'am, pain is because of there is a hydrohepatosis lead to hepatomegaly, hepatitis, and due to ductal dilatation of the main pancreatic.
History when you said fullness of abdomen is
Yes.
present. So you need to say rise in intrahepatic biliary pressures will lead to fullness of abdomen.
No, ma'am, because of stretching of the.
After taking food, how do you interpret a patient had jaundice and now after 1 month of
Yes.
obstructive jaundice is complaining of fullness after meals.
Maybe due to any obstruction in the duodenum or.
What is your interpretation? Do you mean to say there are two separate pathologies, one in the duodenum and
No,
one in the hepatobiliary tract?
no, ma'am, because patient did not have any vomiting to
So
vomiting.
what I would want to share with you is that means initially there was a biliary pathology
Yes,
or a
ma'am.
hepatobiliopancreatic pathology.
Yes,
And now it is progressing and is probably involving the GI tract. also.
yes.
If it were reversed, the patient had GI symptoms earlier, followed by jaundice, we would have
Then-
thought the other way around.
Yes.
Two things I would add it on what you have presented, like a distinct metastasis. I think there's no need to say that the patient have a distinct metastasis. Other, what you have shown is the tobacco intake. In
Yes.
which one the tobacco was intake was given
By the
by the
intake of gutka, oral intake.
Right.
Tobacco.
You must know exactly what are the different form of intake of tobacco, whether it is form of a vodka or it is in the form of quid. He must be taking quid. Quid, do you know what is quid? It is a tobacco mixed with slackline. That is known as quid. So you should be very specific in your presentation that the patient is taking quid or it is a tobacco with pan, tobacco with gutta. It is important to know about that.
Yes.
I think it's.
You know what is good? Usually the website will line and keep it.
Side.
Circus.
Quid is, Quid is the same canning. So the typical Indian oral cancer that we discussed yesterday, where
Yes.
you get lateral sulcus cancers. But when they swallow, they get a different cancer. And that's
Yes.
why the point is so valid. What is the mode? Tobacco does contribute to some GI cancers also, but that is this one.
Yes.
Can we move? Let's move to, most points were covered in the previous case also. And I agree that, you gave a good history and you summarized it well. Let's move to examination. Just 1 minute.
Yes.
Online, if somebody could, Harsh, could you confirm that they are able to hear clearly now?
Patient is examined in a well-lit room after taking due consent. Patient was conscious, oriented to time, place, and person, thin-willed and well-hydrated. My BMI of patient is 20. Vital signs: BP, blood pressure was 136 by 82 millimeter of mercury, right arm. Pulse rate was 64 per minute, normal volume and normal rhythm. Respiratory rate was 12 per minute, and temperature is febrile. Patient ecteric, pallor could not be elicited. No significant lymphadenopathy, pedal edema, cyanosis, and clubbing. No signs of liver failure. ECG score was 1, and the coronary performance status was 80. An inspection: abdomen non-distended with epigastric fullness, umbilicus centrally placed and flat, all quadrant moving equally with respiration, multiple visible scar mark over the abdomen, no visible lump or swelling, no visible scar mark, pulsation, peristalsis, or dilated vein. All hernian sites are free, no flap fullness or renal angle fullness. On palpation, inspiratory findings are confirmed. On superficial palpation, no local rise of temperature, abdomen soft, non-tender, no guarding, no rigidity. On deep palpation, liver enlarged, palpable 3 cm below costal margin in mid-clavicular line, which is non-tender, smooth surface, and well-defined margin. GB lump of size approximately 5 into 4 cm in right hypochondrium, extended into the right lumbar region, non-tender, globular in shape, firm in consistency, smooth surface, ill-defined margin. Lower border, medial border, and lateral border of the lump is palpable. Upper border of the lump is merged with liver. No other lump or organomegaly palpable. On percussion, liver span is 15 cm in mid-clavicular line, download over the liver and lump. No evidence of any septic dullness. On auscultation, normal bowel sound are here. DRE within normal limit. Left supraclavicular region, no lymph node palpable. Rest of the all respiratory, cardiovascular system and CNS examination are within normal limit. Can I summarize, sir? To summarize from history and clinical examination, a 72-year gentleman presented with history of progressive yellowish discoloration of eyes and skins since 2 months, which was associated with clay color stools and high color urine without any pro-abdominal symptom. The jaundice was progressive without any history of waxing and waning time. He also gives history of pain abdomen, which was insidious onset, dull-lacking pain since 1 month, and generalized itching since 15 days, with significant weight loss and decreased appetite. On examination, patient was ecteric with epigastric fullness. Gallbladder is palpable with non-tender hepatomegaly. So from history and clinical examination, my provisional diagnosis is a 72-year gentleman with surgical obstetric jaundice of malignant etiology, most likely due to periampullary carcinoma. And my differential diagnosis is carcinoma head of pancreas and
Vaccine.
On the presentation till now, one question, you said that there is a gallbladder lump.
yes,
And you said the liver span was, I think, 15.
15
So the gallbladder lump is continuous with the
liver.
liver dullness. So how do you measure the liver span then? Where do you find the lower border of the liver span or the liver in a case where there's a gallbladder lump in continuation with the liver dullness?
Ma'am, liver is palpated from the second intercostal space towards the lateral side. Towards the lateral side in the mid
The gallbladder lump will come there. So then you not get an erroneous result. Your liver dullness will continue with the gallbladder lump dullness. So is there any other way we can check for the liver dullness?
we can
Span, how do you normally do?
From
assessment of liver span.
from
We have a video today on but you can.
from second intercostal space towards the in the mid clavicle line towards the lateral side. I will workup anterior.
We will move towards the
Anterior.
usually also we should not go straight down because the costal cartilage is
Costal.
coming there. So you will get a miss.
See, another mistake you have committed is a grave mistake, I would say. You have committed that there is a gallbladder lump. Fine,
Yes.
either you should have said a palpable gallbladder, but.
Summary.
This thing.
Yes. Yes.
So it's a good, very important observation, and we saw that correction in Dr. Ratna
Yes.
so they all see it. So basically, keep it to palpable gallbladder.
Yes.
Now define it, rather than giving it a name or, these things don't really matter. The palpable gallbladder can be due to various reasons. It is not that you won't get a smooth gallbladder, never in cancer gallbladder. That's not true. But by and large, and the clinical story is about probabilities, not possibilities. Possibilities are immense. You may have neck, you may have duct, you may have proximal part of the, the infundibular part. You may have many ways of gallbladder becoming palpable. So keep it palpable gallbladder.
Just enumerate in your points in history and examination why you have made perimplicity clear.
How is perimplicity?
First time.
Because the jaundice was progressive in nature and age of the patient is 72 years.
Dr. Ratna asked you a question. Presented with jaundice first and then came pain?
Yes. And age of the patient is 72 years and progressive jaundice and patient associated with weight loss, significant weight loss and loss of appetite.
No confusion.
Yes, sir.
It's the organ that they are talking about. Nobody's upset with your.
See, aren't these points you are enumerating just now goes in favor of CA head of pancreas?
Sir, it is difficult to differentiate between
Okay.
periampullary carcinoma.
Fair point.
Yes.
I think before we proceed further, I need to mention there in the examination what we have discussed, like abdomen is non-distended. You have to come out with a positive finding rather than being a negative finding. Means you have to say whether the abdomen is flat, distended, or it is scaphoid. Is it clear? So only three dimensions mostly be mentioned. Therefore, don't say that it is non-distended. Second point, what I want to mention here is like what you have said, abdomen is moving equally with respiration. It just never happens that all abdomen move equally with respiration. They move proportionately with respiration rather than being equally with respiration. Is it clear?
Yes.
The two corrections are there. Third thing, what I want to say there in the summary, what we have included, once you have said it is a progressive jaundice, then there's no need to mention there is a waxing and waning character is present. That is means contradictory things should not be there. So if it is a progressive jaundice, there won't be any waxing and waning character of jaundice. Second thing, when you are discussing or summarizing any patient with an obstructive jaundice, you must include the history of melena. Which
Yes,
melena in the last summary.
No, sir.
The last summary it was not there.
Ah.
Which summary?
The last summary. What
No, not saying.
Sir,
It is there.
no, sir. I added in the.
It is not there. It's okay.
So
Yes.
that's why
Yes.
you are writing. So you should include that.
So history of melena is very, very important.
Yes, sir.
That is always to be mentioned because that can give you a clue to a diagnosis. If it is not there, it is good. I think.
That's right. So abdomen. There are various ways of approaching it, right?
Yes, sir.
What is the scaphoid abdomen? I thought this will help. It's very important.
Scaphoid abdomen is will be just
See, these terms are very semantic, but they are used, no? So that's why it's important as well.
Is it a normal shape abdomen?
Is it normal? Scaphoid is normal?
not sir, not normal,
Something boat shape.
not normal.
And you don't see it all.
Yes.
And how do you know it's a scaphoid abdomen on clinical examination?
From laterally, I will see
No.
the
You put ruler, scale from
Yes.
GP sternum to
pelvic symphysis.
and the distance between the anti-abdominal wall and this ruler should be at least 2.5 centimeters. That's a copybook definition. You don't get to see unless the patient is very close.
Yes.
Okay? And you have epigastric fullness, that takes care of it. You don't need to bother about anything because it cannot be, there is some distension there. Okay?
Yes.
But you have that general distension and then you talk about it. Stay corrected as was highlighted. But epigastric fullness makes us care of.
Yes.
Correct? And this local rise of temperature, moving on respiration, these are all very relative terms. Upper part would move more, lower part doesn't have any business to move that much. So care much about this.
Yes.
Yes, Dr. Lata.
I want to take you back to the clinical examination that you've done. You've talked of epigastric fullness, but you have not justified it on clinical. You mean to say gallbladder was lying in the epigastric?
No, ma'am.
Then what was the reason for epigastric fullness?
Because of
You have a picture
after-
of the patient,
Yes.
because that may help you.
ma'am, after taking
Most likely it will be the left lobe that must be enlarged, which is given. Now, the only finding that you've told us about the liver, you've taken the liver very casually. You just said that it is enlarged 3 centimeters below the subcostal margin, and that was the be all and end all of the liver. Everything went to gallbladder.
Or, so
thereafter.
describe liver.
Describe liver.
Can you describe it now?
yes, sir. The liver was non-tender,
First of
smooth
all,
surface.
You start with,
Yes.
then you come to it.
Liver is palpable 3 centimeter below the mid clavicular line,
First of all,
costal from
the
costal
mid.
margin. Yes,
next.
mid clavicular line, which is which is non-tender, the smooth surface and regular margin without any nodule.
The consistency of the liver also, whether it is
Soft,
soft or hard.
soft in.
Smooth surface is good enough. You must specifically talk about, though it's a negative finding, that you could not palpate any liver. What is the normal edge of the liver like? How do you
Normal.
say whether the liver is normal or pathological?
If the liver is lifespan is 9 to 12 centimeters.
Besides all those factors, besides
And-
you have to very carefully palpate the edge of the liver.
Edge,
Normal liver will have a sharp edge.
edge and
If the edge is not sharp, it is pathological
Pathological.
liver. Then you look again for nodularity.
You
or
don't want to make careful.
What you have said, liver
Make careful.
span, there is the mid clavicular line. Mid clavicular line, there already the lump is there.
yes,
Is it okay? So you always palpate it there on the lateral.
lateral surface.
More laterally rather than being there in the mid.
Mid
Clear now? And even the span, you measure that, because you can't do it.
Yes,
In the case there is a lump. But if there was no lump, you can get away by saying it, but otherwise you would have a false result, as Dr. Sima mentioned, is not fully reinforced. And I don't think this is an abdomen the way you describe it. It looks, I mean, protuberant in any case. It is very, is it a standing position examination?
no, sir. Lying.
Okay. And the umbilical looks transversely stretched.
Yes,
Transversely stretched, and you can see the skin has some changes. So these probably are scratch.
stretch mark.
And we can move. Let's move. How do you go for back to your diagnosis? Last slide, that is.
Yes.
So would you like to revise it or you're happy? Carcinoma head of pancreas is covered in periampulary, but only a little part.
Yes.
So you wanted to put it down with more emphasis. And carcinoma gallbladder with metastasis.
Metastasis.
Why metastasis?
Because, sir, in carcinoma gallbladder mostly present in the fundus and body region, which presented with late onset of jaundice. And
So if
in
you had said carcinoma gallbladder only, would that be okay?
yes,
And then you can discuss it,
yes,
right?
yes,
So it is easier. Don't get into trouble.
yes.
And you can. If you ask them, you can ask them.
I was thinking that this fullness that you have shown, it is so grossly distended there. Beneath the liver, there could be an underlying mass as well. I keep looking at the image that he's saying.
So
and
actually, I was asking, is it standing, umbilicus is transversely stretched? I hope you're not just a fluid in the abdomen. There are many things. So you have the advantage of having examined. We are only speculating. So that's why we are asking. Did you purchase? Yeah.
Yes, upper lump, down not. Yes, sir. Tympanic.
Okay, it's a protuberant abdomen in
Protuberant.
that case. Sometimes when you make them stand, you'll see they have a bulge because of the weakness of the muscles. But then be clear about it. That's why they're all asking you repeatedly. It's not that they're asking for nothing.
Yes,
If there is, you mention epigastric fullness, then you better justify in your examination why is it there.
Yes.
Or if it is not there, then clarify. We are moving on with periampulary as your first differential, which you need to justify. We may agree, we may not agree, that is our problem, but you have to justify, okay? Why did malignancy? Quickly, points in history, points in examination.
so point in history, the patient is 72 years old and progressive jaundice, and associated with significant weight loss.
Painless progressive jaundice.
Yes,
Significant
pain.
weight loss.
Yes.
And on examination,
On examination, the GB was palpable,
palpable GB, palpable gallbladder.
palpable gallbladder,
And,
and non-tender hepatomegaly.
and this abdomen needs to be examined again. Go back and
Yes.
examine it. Don't, there's no shame in it.
Yes.
And no abdominal examination to my mind is complete unless you talk about spine and the workup.
Spine and
lymph node.
yes.
Both should have been mentioned. They
I-
are mentioned.
Yes.
Examination of abdomen is incomplete without it.
One thing probably you have not mentioned is digital rectal examination.
Yes, sir, I mentioned.
He mentioned.
Any finding?
No, sir, no.
And don't call it PR, that term is outdated now. It's called
Digital
rectal
rectal.
examination. And describe everything about it, like the previous candidate did.
Yes.
So, how do you proceed?
Sir, I would like to investigate the patient to confirm my diagnosis, to stage my disease, to support my disease, and to stage my disease, and to
Support your diagnosis. You
Yes.
don't support your disease.
Support-
To support the disease, you add it.
support
To
of
confirm the diagnosis,
to
to
support
support the
the
diagnosis,
diagnosis,
to
to
state
stage the
disease,
disease, and to
treat the patient.
patient.
How do you confirm it? You just rattle it out because you already discussed. We give you 1 minute so that you can take your wind out.
Yes, sir. I will like to do ultrasound of whole abdomen to with a complete LFT, including PTINR and serum albumin and protein. And in ultrasound, I look for look for the status of the gallbladder, liver, and CBD, and look for any free fluid in the peritoneum or any lymph node present in the peritoneum. Then, if there is any lymph node present in the ultrasound, I will do with triple phase CT or CCT, continuous CT with the pancreatic protocol. Then
There's no history of hepatobiliary surgery in this patient. Why have you included hepatobiliary?
sir, if the previous surgery of any cholecystectomy, there is clip in the CBD, it will also produce obstructive jaundice, and if it is lead to stricture in the CBD, it will lead to obstructive jaundice.
Timing of this surgery, recent, say 20 years back, we gave history that he has
No, sir.
undergone lap cholecystectomy or something like that. So,
Why I have asked is all because of the reason it is not the hepatobiliary surgery which can lead to a minor stricture or injury. It may be any surgery there in the upper abdomen. There may be a gastrectomy leading to a stricture there of a bile duct. So don't be very much, you can say, particular that it is only the hepatobiliary surgery which can lead to a bile duct
Yes.
stricture or injury.
Yes.
Yeah.
So you've done an ultrasound,
Yes, ma'am.
and ultrasound says that there is dilatation of intrahepatic biliary channels, and there is dilatation to the level of mid common bile duct.
Yes, ma'am.
They can see a hypoechoic lesion in the head of pancreas, and there are enlarged peripancreatic lymph nodes and distended stomach.
Then I will go for MRCP, magnetic resonance cholangiography.
What are you thinking when you want an MRCP? What is coming to your mind?
Ma'am, it may be in the hilar region, it may be any hilar cholangiocarcinoma, hilar region of the CVD, common bile duct.
It's a hypoechoic mass lesion
In the
head of
pancreas.
And there is dilatation only till the mid CBD, and there are enlarged peripancreatic lymph nodes, and stomach is also distended.
To look for
So if I were you, I would think in terms of probably a
malignant
mass lesion
in the pancreas.
and enlarged lymph nodes could be causing extrinsic compression on the stomach, and probably there would be either infiltration or compression of the middle part of the common bile duct. That's why you would want to evaluate further by going for
MRCP.
okay, even if you are suspecting a SOL, space occupying lesion in the biliary tree.
Yes.
Biliary tree. Is MRCP or a CT a better investigation to evaluate?
Yes, that's a question for him.
Yes, definitely we'll do MRCP, we'll do CT. Which one would be better for evaluating that lesion?
Side view endoscopy. Well, out of MRCP, MRCP will be better. So,
Because CT is always better. MRCP will define the ducts.
Ducts,
the
yes.
diameter of the duct, up to which place they are dilated, where they are collapsed duct and all these things.
Yes.
But evaluation of a SOL is always better than by a
That's
CT.
CT.
So you have both investigations go hand in hand.
So if I would say you need both the investigations, no?
Yes.
You need to know about the lesion. You also need to know about the
Duct status.
biliary channels in the pancreatic duct. So invariably in such cases, CT is also done, and plus MRI and MRCP are done, not only MRCP. CT and MRCP or MRI plus MRCP. Do you agree with me, sir?
So you heard about the nuances of minor things. There is a finding that if you do ultrasound, you find doubtful lesions in the liver. And they're about 1.5 centimeter, 2 centimeter individually, and it's in both the lobes of liver. And there is suspicious fluid in the, like I saw, myositis. How do you proceed in this case? You've done ultrasound.
Yes, sir. I will do triple phase CT with pancreatic protocol.
Why do you need a triple phase CT now?
Sir, I would like to confirm the SOL is of any malignant.
Multiple.
Multiple, yes. Yeah, it is of metastasis or any metastasis.
Well, they look like a metastatic liver lesions on the IV contrast CT. How
Hypoechoic.
do you differentiate it from non-malignant lesions of liver, maybe multiple liver abscesses?
In the liver, it will show hyper intense because of.
Just some time back, sir had discussed when would you not want to do CT. He's
Sir,
giving you a clinical picture in which you're finding multiple.
It is a.
Do you think
No,
this
sir.
patient is going to have multiple liver abscesses?
No, ma'am.
You have a
It may be
master in the time
advanced-
and plus the evaluation.
advanced cancer.
And also
Advanced cancer.
To proceed with all those, that battery or laundry list.
Yes.
It is not that you read it in the books. What you practice is what everybody practices, what you have seen and correct. To try to be a common sense surgeon.
What is the ultrasound description of metastatic liver lesions?
How do they look on ultrasound?
Hypoechoic lesions of non-contiguous with multiple hypoechoic non-contiguous structures.
All right, we are tying on time, so we will move to, I've given you a different scenario so that we move away from the ripples. Have you prepared a patient for ripples ever?
Yes, sir.
So actually, what did you do?
Sir, I would like to hydrate the patient, then
So
give
what does this mean? Hydration means.
hydration, give plenty of oral fluids, and if patient is not taking orally, I will give taking orally, sir.
Taking orally?
Yes, sir.
No, not throwing back, not
No,
vomiting?
sir. No, sir.
Okay.
And I will like to nutrition the patient by the help of high calorie, and I will correct the coagulopathy of the patient. And
Have you corrected the coagulopathy?
Yes, sir.
In your ward?
Yes, sir.
So what did you do?
Sir, I will first give injection vitamin K 10 milligram subcutaneous for 3 to 5
Which
days.
is the most sensitive LFT in these patients?
Sir, INR is the most sensitive.
What is the role? Why do you give vitamin K?
Because
INR
if
is
direct,
INR is free. You correctly said you would correct problems. Why do you give vitamin K? How does it help?
sir, vitamin K helps in the formation of vitamin A, D, K,
Very?
coagulation pathway, and forms the coagulation factor. And if the liver is dysfunctional, the vitamin K will not act, and so in that case, I will give fresh frozen plasma to correct the coagulopathy.
Coagulopathy is what you are correcting. What do you do? They talk of antibiotic prophylaxis.
Yes, sir.
What antibiotic is it?
Broad spectrum antibiotic to cover
Broad spectrum means what?
gram negative
Why do you
third
give
generation.
antibiotics? This patient doesn't seem to be having cholangitis or anything. Why do you still want to give antibiotics?
To prevent cholangitis. And
Not there. Why should it happen? I mean, what is the role of antibiotics? That is what I
Role of antibiotic to prevent
And why do you want to hydrate this patient?
Because,
Two is intramuscular, one is why?
because in this case there is third space loss, and the bilirubin pigment will deposit in the kidney, leads to hepatorenal syndrome. That
Reason could be that to prevent renal damage
yes, sir.
in the form of decreased renal perfusion because of hypovolemia, vomiting, or other losses.
Yes,
Number two, endotoxemia due to the bacteria.
bacteria.
That again damage the kidneys. So you want to give antibiotic.
Yes.
And the third thing is, anything else?
Third
Already I
thing,
talked about that. Nutrition is important.
nutrition. Yes, high carbohydrate nutrition.
I think that we have covered
Yes.
nutrition and antibiotic prophylaxis.
Yes, prophylaxis.
And most antibiotic prophylaxis are based on what you're expecting in this patient. In usual practice, most, the guidelines is they set is of the second generation, not third,
Yes,
and not first. Third is the risk of resistance, first one doesn't cover adequately, so second generation.
yes.
And you should be adding anaerobic cover in the patients, suppose because you're anticipating doing that kind of surgery. And as rightly said,
Giving diuretics.
we're coming to that, hepatorenal will shut down that.
Yes. So we'll give diuretics if the urine output is decreased.
Did you understand the question?
Role of
Preoperative preparation is going on.
We are still working. The role of diuresis or diuretics, people used to give mannitol regularly in these patients earlier to prevent what is called hepatorenal shutdown. You heard about it?
yes, sir,
What
hepatorenal.
is it? You have to save on time also.
Because of dehydration and deposition of bilirubin pigment in the
Various theories of pre-renal is what is most common.
Yeah.
That's what you're saying.
yes.
So you need to adequately hydrate.
Hydrate.
Any role of diuretics?
If the urea create is deranged and matlab
You can't correct urea creatinine by giving diuretics. No?
to
Any role? Present guideline? Yes. Amandeep.
Prevent pre-renal, you need to give more of the
No, hydration is okay, but diuresis is done now.
person regularly. In the past, no more recommended nowadays. But what I want to correct you now is like what you have said is the vitamin K is being given subcutaneous. Most of the time it is iron. Which is
sorry, I am.
Right?
Yes.
So if it was metastatic disease, what do you do? Because this would be the second scenario.
Sir, I will like to get I would like to get FNAC by the help of endoscopic ultrasound guided FNAC or side view endoscopy guided BROS or any FNAC.
You need a diagnosis.
Tissue diagnosis. Yes, sir.
Anything to palliate these patients?
Yeah.
Jaundice?
Yes, sir. For palliation, if the patient have any obstetric features, I will first give neoadjuvant therapy.
See, what do you want to palliate? There are only three things which need to be palliated. One is pain, other is
Pain,
itching, and
yes,
third
sir.
is vomiting or
For-
gastritis.
For
So this patient has itching
itching,
and pain.
so I will
So
give
how do you palliate these two things?
for itching. I will give cholestyramine, and for pain, I will give analgesis. If
See, the question is correct. He is giving you a hint also. What is the basis to all these problems?
to decrease the
No, sir. What is the basis to all these happening?
increased bilirubin, will
Yes.
cause yes.
So
I will,
basically you are doing palliation of symptoms.
Yes, sir.
Symptoms are palliated. Itching,
Yes, sir.
even jaundice is a symptom, mind you.
Yes, sir.
It's not a sign. No? Interest is.
I will.
So you want to relieve the patient.
I will
of-
do biliary drainage.
So that's what
Yes,
directly
yes.
asked. And in addition, you can use cholestyramine. which may
Cholestyramine.
work. You can also use antihistamines, which
Yes.
also can work. When do you decide of a surgical intervention and not for cure purposes, for palliation? I'm asking about triple bypass.
Yes, sir. Triple bypass will lead to hepatico-jejunostomy and gastro-jejunostomy and jejunostomy.
When do you plan it? That's the question.
So if the patient have increased bilirubin and lead to severe pruritus and
I am a medical gastroenterologist. I say that I can do
After-
all these things endoscopy.
after yes,
So
sir.
why should I do a surgery? I can do endoscopic stenting, biliary tree.
Yes, sir. First I will do ERCP guided.
Okay. Sir, asking, when do you think of doing it surgically?
If sir, if the FNAC is positive, the tissue diagnosis is positive for any malignant lesion, then I will go for.
The question is very specific, no? You have either an endoscopic method to bypass problems
Yes, sir.
or a surgical method to bypass them. In the past, we were doing surgical bypasses, which you mentioned. Today, we can do endoscopic palliation by putting a stent across, dilating, and nutrition can be taken care of by some method. So you need to do it in only select group of patients. Or you went with an intent to operate and your patient is on the table. You have to come out of the situation. Still endoscopy is a good idea, but you can do a surgical bypass if the expectancy, life expectancy is at least 6 months. You should be doing it in patients who are not likely to survive that long. It should be able to give that kind of a benefit. It is not very popular now. Triple bypass was something that was even compared to Ripples at one time, but not done. And you can do hepatogenoscopy or cholecystogenoscopy, gastrogenoscopy, and duodenoscopy. It's the same can be done now, endoscopic retrieval and putting a stent across, and they are happy. Or if the patient has features of obstruction or anticipated obstruction, because this may happen, but patient has to live long enough to get that obstruction at the outlet. So it is done in a very specific scenario. So we have taken care of the palliation part of it also.
Yes.
Correct?
Yes.
Any idea about any role of doing PET scan in these patients when they are very young?
Sir, if the in CCT, if you will suspect there is metastasis which can't be picked up by CCT, distance metastasis, then we will.
How avid are these malignancies? Are they PET avid or they are not?
Not abated, sir, because of increased proliferation and increased intake of
If there is
deoxy.
increased proliferation, they should be avid.
Increased proliferation, and in case of any pancreatitis, chronic pancreatitis, it will.
You don't do a PET CT as a routine in such patients.
Yes.
These are questions that were not covered in the previous case, so I'm bringing them up. So PET is not a standard of care, it's not an algorithmic approach. Except in neuroendocrine tumors, and when you've got some findings in CT where you need to go for it. It doesn't work as well as it does in other places. And then also if you're doing it, it's PET CT. It's an institution that I've come to now, they do PET CT in most cases, where the CT part is more used.
Yes.
You getting the point? So by and large, you should be clear. Any last couple of questions before we wind up? Yeah.
What are the challenges that you would face in resuscitating a patient of obstructive jaundice and shock? Any challenges different from a routine patient in
Dr.
shock?
Ratna, can you be specific?
Yeah.
Challenges are many. There will be 100.
Resuscitation?
Fluid resuscitation.
Resuscitation of patient of obstructive jaundice. So these patients respond very poorly to vasopressors, which a normal patient would. So in spite of vasopressors, you will not be able to get the BP up. You may need to take the help of steroids to decrease.
Yes.
Steroids in which situation, Dr.?
So because steroids are the only.
In which situation?
No, if the patient of obstructive jaundice is in shock, whether septic shock or
They
whatever,
not operate,
they will
but
not
preoperative.
they will not respond to vasopressors.
So, but then how is steroid going to?
So they decrease the dose of requirement of vasopressors, and then that's the way. And
the reason is usual relative adrenal atrophy or decreased blood supply. So they may have a shutdown, but it's not a standard of care per se. She's talking about a situation where the disease is overwhelming. It may not respond to the usual methods of recovering from shock or using vasopressors. Last couple of questions.
Yeah, just I want to add it on here, like where the take home there for the palliation is like the surgical intervention is a last resort, always endoscopy is being preferred. So because of the n number of other complications which are related to the operative part. When we talk about the operative part, even when you operate these patients, we have to have a fitness of these patients. Most of these patients, they have a low albumin, they have lower hemoglobin, and therefore you have to build up the patient before we operate. So operative intervention as such is not been recommended, rarely been used unless until it is you won't have a facility for endoscopy to perform. I think
we did that, and that is what was conveyed earlier. It's just being posted. If the patient is not even fit for a haircut, you can't be doing it. Patient is operating on the table, the patient is naturally fit for surgery, and you think he's going to survive that long. That point is very, very important. This prognostication happens even before surgery.
Yes.
Okay. And it is usually in a surprise situation. You should take home that the standard of care is endoscopic aggressive. Even PTBD sometimes not showing the endoscopic. So you have to get the jaundice reduced. If there is a suspected outlet obstruction, you need to relieve that. And nutrition has to be taken care of. We suffer from it. Triple bypass, we used to do in the past on cases when we did not know beforehand whether it's going to be resectable for sure. Imaging showed resectable, we went in and we found it's not resectable. Patient is well preserved and otherwise patient will be taken up for surgery only if well preserved. You should not take it.
There have been instances when intraoperative, so far everything was fine, but intraoperatively we realized that superior mesenteric artery and vein are involved. So that is not the reason that since we have opened the abdomen, you should go ahead and do the hepatogenostomy or a gastrogenostomy. You close the abdomen, go back to your endoscopist, ask them for the help.
Yes, so clear that is taken home. Any question? Yes. Please identify yourself and ask the question. Pass the mic, Terry, don't speak over it. You shout.
Our patient is planning for the palliative care with the improve the quality of life. Patient is already PTBD. We are planning. My question is that we are continuing the PTBD or we are planning something sense like standing.
See, first of all, never confuse the answers given. They sound like giving different answers, but the answer is one, simple. Wherever possible, endoscopy can be done, but that doesn't mean it can be done always. Clear, be clear in your mind. And secondly, if you are doing PTBD, there has to be an indication for it. You are trying to reduce the level of bilirubin. If it is working, why would you remove it? Answering your first question, right? Because that's the basis to your palliation. It's not going to work. No amount of nutrition is going to be useful unless the patient will see when the bilirubin comes down, the quality of life issue which you're talking. And in most of the prompts that have been published, patient-related outcome measures, they are not very happy with an external drainage. They are happy with an internal drainage. Having said that, it's not always feasible to do internal drainage because the stent that you put for higher obstruction may not be applicable. It's for the lower obstruction. So mostly it works, but if it does not, then we don't have a choice. And the upper part, you can go for the approach from upper side, the lower part from lower side. And depending upon what you have got, so the answer is subjective. It is one situation that we need to talk about. Why was the PTBD put? So you're talking about different situation.
The comment I wanted to make was that in today's state, the techniques have evolved, like we were talking yesterday also. Initially, you may have placed PTBD, but if your institute does not have those facilities, you can send to a gastroenterologist who by rendezvous technique will be able to drain it internally.
Same thing we are talking. So I hope you understand. It is a question of involving IR people and gastroenterologists. There's so many people who can play that role for you. But as long as possible, don't open up the abdomen because that is going to be difficult to close and it's not going to heal well. Eventually, the patient has to do well, not your surgery. Yes.
Last time, now going to see, when we talk about the biliary obstruction, the lower obstructions are better taken care by the ERCP. But the higher obstruction, they are better taken by the PTC. It's not like the PTC, you can do only the drainage. You can, even nowadays, stent. So stenting can be done there from the lower down through ERCP or it may be done through PTC. So even if they do PTC, they deploy a stent and then they remove the, you can say, catheter. So what means it is the same thing what they are doing it there from below, they are doing it from above. So it is not like when we do PTC is only the drainage. You can deploy the stent, you remove the catheter and the patient will be all right. So it is a sort of internal drainage which can be done there from the PTC also.
Probably you wanted to talk about PTBD, biliary drainage, in a patient who is considered unresectable, inoperable. But again, think and consider that PTBD is a procedure which is associated with a lot of introduction of a lot of infection.
That's why.
So that is why intervention is always better. If we are able to put in a stent wire through even the PTBD or the GWAS needle, again, it is going to be a short-lived procedure, it's because we know that this patient is not going to live much.
Very well made point. See,
I mentioned that. Did you hear? It's all the same. For upper obstructions from above, for lower obstructions from below. You can't put metallic stent from below, so you have to go from above. And if you can leave a stent there, stent either way is okay. But PTVD has the disadvantage of introducing infection. A lot of people prefer to do endoscopically from inside. These obstructions are usually lower. And you can negotiate them. Most of them come with a stent already. You should know that. Because they're referred from gastroenterology, so they already have it. In fact, the trouble is to deal with stented patients when you go for reverse. Technical issues are associated, but most of them have a stent. So coming to the quality of life, it is better with no tube hanging outside. But that, having said, will depend on where you are. Okay? And there is no need to convert an external into internal unless it is going to be there forever. Because you're going for surgery, then you possibly will. Because if you're doing it for various reasons. So understand more than getting the information. So don't get confused. Only one thing was spoken so far. Endoscopy over open surgery is preferred. Triple bypass is asked in the exam, so you should know about it. PET scan, the tumor is less avid, so it's not working very well. Not a standard of care. Any marker that you do, which is what I was going to ask you, because that is missing.
CA
What
99.9.
is its role in these patients?
So it tells about the further prognosis after surgery.
One, and
And
organ that can get affected.
Is if sorry CA 99.9 is more than 100, then I will like to do the side view endoscope to look for tissue diagnosis and plan for neoadjuvant chemotherapy.
So there is another indication that you should operate. It's indicative of the meds that you're not seeing.
Yes, sir.
So those same hidden meds.
Hidden meds.
This is one marker which is good.
Yes.
Okay. Is there any pancreatic PET very specific to pancreas?
IPMN variety of
What is that
pancreatic.
PET we use? Based on some marker or something which is secreted by the
CEA level.
somebody spoke.
Secretin.
And also somatostatin.
Somatostatin.
So you can have these PETs which are specific to certain diseases. Otherwise, PET is limited.
Yes.
Okay. It's not a tumor that picks up the activity much, and the PET is not very useful. So palliation is covered. In the previous case, you covered the surgery.
Yes.
Do you have a question? Anybody? Yes.
Patient of resectable, like this case,
Big pass.
resectable tumor, is there any cutoff for bilirubin to operate? Or we can operate in high bilirubin also?
See, the cutoff thing is challenged. That's why people do biliary decompression based on levels. But if the bilirubin serum bill is more than 18, you would find a patient is not very well preserved anyway. With an 18 bilirubin patient won't be very fit for surgery. And some people take that as an indication. But more than that, don't treat the bilirubin, treat the patient. Some patients can tolerate it. We have seen patients with 15 where we could go in for surgery, and with 10 they were not fit for surgery. So it all depends. It's not just one factor which you take into account. What is the surgery being done to reduce the bilirubin load? So don't get complicated answers in life. No? So serum bilirubin is too high. It will be the white bile that you're going to get initially. That is itself, the patient would not be well preserved by that time. Well preserved patient with 18 is not a contraindication per se. But like I told you, some people take level also as a cutoff. Some take 15. In some studies they've taken 18. Japanese like to do biliary decompression in most cases. Biliary decompression is done in these patients. There is a problem with the anastomosis, the duct, the associated inflammation, fibrosis. The anastomosis will have a problem.
Yeah. When we talk about the stenting as such, is only being recommended if the patient is having a cholangitis or the patient is having a hypoproteinemia. You have to build up the patient. You want to have a time. Then you can reduce the bilirubin by stenting these patients. Because when you talk about the stenting, it is always been associated with a higher complication rate. When complication is the abscess and the wound infection, that is the most troublesome complication which can happen in these patients where you stent it on. It's okay.
Right. So that has already spoken that. So did you understand that part? So anything to add is more important. You know what we biliary decompression is done for what, to build up the patient, etc. But to answer your question, the cutoff is there, but again subjective. Is that okay?
There are not textbook
levels. So take the answer clearly, no confusion about it. We already discussed why decompression is done prophylactically. You understood that part, so we will not repeat things many times.
I'm asking one question.
It should be in addition to what we have discussed, no repetition.
No, sir, use the term white pine. So you tell me what is white pine and what is black pine.
If you don't know, say you don't know quickly, so that you can answer.
So white pine is if there is obstruction above the level of cystic duct, so hepatic cell atrophy happens and it's white pine. If obstruction is below the level of cystic duct, then all those bile pigments and all will be.
Basically, white bile is when the bile pigment, there is no pigment, the liver is not functioning. That can be initial part of it, static, mixed with some kind of a secretion, mucus, etc. So this is what comes through, but we don't do decompression as a routine. Thank you very much. You made an excellent presentation. We move on to the next presentation. We've taken a lot of time there, but I think that takes care of it. In SCRUBS, it goes on. Are you going to make the presentation, Terry? The next presentation is lumps now. Right hypochondrium, then left hypochondrium, then left hypogastrum. We will start with the right hypochondrium. Dr. Terry. Yeah. Also. The right leg Kosala and Gatta Swami from Hindura Hospital. Name you could note down, sir, please. Shoot, sir, quickly.
Good morning, everybody. Today I am presenting a case on right iliac fossa lump. My patient, 70-year-old gentleman, resident of Delhi, came with the chief complaints of pain in the right lower abdomen on and off for the past 5 months, passage of black color stools on and off for the 4 months, and generalized weakness for 4 months. Patient was apparently well 5 months ago. Pain in the right lower abdomen, which is insidious onset, gradually progressive in nature, dull aching, not radiating, no aggravating factor. Pain was partially relieved by the medication, which is prescribed by the local practitioner. And there is a history of black tarry stools on and off with foul smelling for past 4 months. And there is no history of loss of weight and loss of appetite. And there is no history of nausea, vomiting, abdominal distension, constipation or diarrhea, or fever, night sweats, or cough, hematemesis. And there is no history of burning micturition or dysuria, hematuria, or mild descent of testis. And there is no history suggestive of distant metastasis. And patient is not a known case of hypertensive or diabetic. And in the past medical history, there is no history of intake of anti-tubercular therapy. And the past surgical history, there is no history of surgeries like cholecystectomy or ileal resections. And the personal history, patient takes vegetarian diet with normal sleep pattern, normal bladder habits. Bowel habits as mentioned in the history of presenting illness. Patient doesn't consume alcohol, doesn't take tobacco in any form. Patient doesn't give history of any substance abuse. And the family history, there is no history of cancers in the family or cancer-related deaths. And there is no history of TB, any contact with the TB patients within the family also. And to summarize my history, a 72-year-old gentleman without any comorbid illness presented with the right lower abdominal pain for 5 months and the melena for 4 months with generalized weakness, with no other symptoms and no features of distant metastasis. General physical examination after because of the bile salts act as a carcinogenic in
with some suspicion in them. What is
the colon, distal ileum or colon cancers.
Now, then you speak what is the reason for that?
It will, but the bile salts act as a carcinogenic in the.
In your exams, please avoid the writing. If there is a history, yes, you must mention.
Yes,
but if there is no history, I think there is no. It seems that it is a kind of a match fixing. You know it before and you specifically.
Okay.
We can move.
Okay. Oh. After taking due consent, patient was examined in village room with adequate light and exposure. Patient is conscious, coherent, and oriented to time, place, and person. BMI of the patient is 19.6, and ECOG performance score is 1. Patient is moderately nourished and thin built. Gait of the patient is normal. Hydration status is maintained. Vitals of the patient is within a normal limit. Pallor is present. No icterus, no cyanosis or clubbing or generalized lymphadenopathy or pedal edema. Regional examination. On inspection, contour of the abdomen is normal. Umbilicus is central and inverted. All abdominal quadrants are moving equally with respiration. There is no visible scars, dilated veins, or visible lump or visible peristalsis. Hernial orifices are normal. External genitalia is normal. No left supraclavicular fossa fullness is seen. On palpation, there is no local rise of temperature. A 8 cross 4 centimeter ovoid intra-abdominal lump palpable in the right iliac fossa, which is extending into the right lumbar region, which is tender on deep palpation with irregular surface, hard in consistency with well-defined margins and restricted mobility. Bilateral test is palpable normal. And this is the clinical picture of the patient. And on palpation, there is no hepatosplenomegaly, no other lumps palpable in the abdomen. Palpation of the left supraclavicular region is normal. And percussion, there is dull note over the lump and tympanic over rest of the abdomen. And liver span is 13 centimeters. There is no free fluid and percussion. On auscultation, bowel sounds are present, which is normal. On digital rectal examination, black color staining of the fecal matter is present, and the rest of the examination is within normal limit. On systemic examination, CNS, CVS, and respiratory system within normal limits, and spine and muscular system is also normal. Okay. After taking history and examination, to summarize my case, a 72-year gentleman presented with pain in the right lower abdomen for 5 months on and off, and along with history of melena and generalized weakness for 4 months. On examination, patient is anemic and intra-abdominal lump size of 8 cross 4 centimeters, which is occupying in the right iliac fossa and the right lumbar region. Having irregular surface, well-defined margins, and the swelling is hard in consistency with restricted mobility. Lump is dull on percussion, and there is no hepatosplenomegaly. On DRE, there is a dark color fecal staining is present. By history and examination, my provisional diagnosis, a 72-year gentleman with a carcinoma of the cecum, most probably carcinoma of the cecum, arising from the carcinoma of colon, which is arising from the cecum or ascending colon without any distant metastasis.
Examination you mentioned. So what about gait?
Yes,
What
ma'am.
were you having in mind?
Could be psoas abscess.
First.
Yes, ma'am.
Good history and very good examination. I must commend you. Give him a big round of applause like you did. But like you said, you something tailored and something you have in your mind, and you, it's like a, I'll borrow it from a fixed 2020. So that's okay. It's not your fault if there are features present, but better be prepared to deal with the aspects. I'm happy with the way the history came in the examination.
Like what you have said again, I want to emphasize all quadrants.
You can't, I was going to correct
with
it, yes,
respiration.
yes.
They all
You should have corrected by now.
proportionately with the respiration. Then the second thing is why you have included supraclavicular fossa there in the abdominal examination. So is it a routine or it is a separate finding should come out?
No, so it is routine in all. We have to examine spine and supraclavicular fossa in routine in the all abdominal examinations when we have a
Spine and
so
the
left
workup,
supraclavicular. Yes, sir.
Workout not specifically, supraclavicular fossa is separate.
What you have presented is the abdominal findings, so it should be in the general examination rather than being.
See, personally, I like to see it along with the specific findings, and that's what you do mostly in oncology. Important thing is in general examination, you can miss it. But if you say there is no general, you mention in general examination also, it's okay.
Yes.
Why is he saying it is? At least it drew his attention to asking you a question, right? The idea is to invite that question. So we completed by saying the spine, DRE, and the workouts load.
Yes.
So just to pay attention to draw the attention of the examiner that I know about.
Maybe in the last you can add it on like
Yes.
it is a separate finding, but not in the abdominal examination. I think no one will accept that in the abdominal examination.
Right.
The next thing is like a lump which is present in the lumbar region or extending into the lumbar region. You have not mentioned it whether it is bimanually palpable or palatable.
The lump is restricted in mobility. No need to mention.
There's nothing.
Okay.
To do with the palatability
Is
or
the renal angle full?
No, sir.
Where will you put the hand behind if the renal angle is not full?
Sorry, sir.
How would you do the
So
bi-distal?
is it a routine there for all lumbar lump or it is a, you can say, you can skip it here? What I want to say that you have skip it here, yeah?
Yes, sir.
So is it not mandatory to perform a manual examination here in this patient?
I thought if the lump is restricted, no need.
Lump is fixed,
How big is your lump?
8 cross into 4 centimeters, sir.
It may go into that area. No harm in accepting it and saying that I did not do it next time.
One simple anatomical
Exactly. Just explain. And I was listen, that you should not go back confused. Scrubs is different. It doesn't flow that way. So I'll give you the answer to the question. And once they are done.
aspiration for a lump to be bimanually palpable is you should able to.
How do you do it? If you can't go behind it.
Right alien fossa, there is bone. You
Yes.
cannot get behind.
So it can't be done. Okay.
Okay.
And it just, lumbar region is not all palpable from behind. So it is, why do we do it? The question is not semantics. There is logic in everything that you do. Why should you, what is generalized lymphadenopathy?
Involvement of the two or more than two non-contiguous lymph nodes.
Which are these groups that you know?
Cervical, axillary, or the inguinal.
Right? So which group you are talking about when you are doing for metastasis? Workhouse node. So
Yes, sir.
use left supraocular fossa. And in all testicular tumor, mention workhouse node.
Yes, sir.
It's not done otherwise. Why is spine mandatory? We have already discussed it. So this also gets covered. In general examination, you can examine all the other groups of lymph nodes. Is that okay?
Okay, sir.
Similarly here, if you say it's extending to the lumbar region, this question would come naturally. If you do bimanual examination or not, because you're looking for something specific.
Yes.
How does the bimanual examination help in lumbar lumps?
If it is arising from the kidney or not, and
Renal lump.
renal lumps.
Any other lump where bimanual examination would be of any importance to you? For that, as Dr. Penile was mentioning, it has to be behind. Otherwise, you can't do it. And can it be bimanually palpable and as Dr. Puneet was mentioning, ballotable at the same time?
Yes, sir.
What is ballotment and what is bimanual palpation?
Bimanual palpation is we have to be able to palpate from the behind and then, and if it is bimanually palpable, there is no need to, it's ballotable.
No, but relevance.
Yes, sir.
What is ballotment and where is it used?
Ballotability is when we push the lump from the behind, we are able to touch from the other side.
It's basically to achieve the same result.
Yes.
The signs were not created before the lumps appeared. The signs were created once the lumps had happened. So this is one method of examining.
Yes.
He is asking you because any lumbar lump, they will ask you this question.
Okay.
So you should be prepared to answer that. And also you mentioned the testes are normal, etc. We could understand the sense why you were saying. Any other?
Can you elaborate slightly on the type of pain this patient has? Just mention pain because
Which is dull in nature, dull aching, not radiating. Yes, sir. It is an.
what cause of pain we are suspecting a vesicle or a cycle malignancy.
One is that huge lump which is causing the which is causing the peritoneal irritation. One is, and then the second thing is could be the partial obstruction.
One would definitely give a history of some kind of intestinal collapse.
Yes.
That is one thing.
Could the pain be related to the restricted mobility?
So they're talking about luminal pain
Well,
and
are the
pain due to
extraluminal.
So that takes care of it. You want to answer that? Dr. Ratna has given you a hint.
Sorry.
Could the pain be related to restricted mobility of the lung?
Yes, ma'am. It could be the involvement of the surrounding structure which is causing the like peritoneum. Peritoneum.
Can you define that?
Yes, ma'am. It is a passing of the black tarry stools with foul smelling which is stick to the pan.
That is frequent added in the.
You mentioned it somewhere. I heard
Yes,
it.
ma'am.
And is it relevant to examine the lower limbs in these patients?
Yes, sir.
Why?
Because the retroperitoneal tumors which is compressing the IVC may cause the
The reason that you answered, Dr. Khanna, she was asking a very good question. Why the gate?
yes, sir.
You said
So as abscess also.
Neurological deficits can happen due to
Yes, sir.
retroperitoneal. Yeah. But a lot of it is mere semantics. Don't get lost. People don't fail because of these.
One get melina in right iliac fossa or a cecal malignancies.
Sorry, sir, I can't.
Will you get melena in cecal malignancies?
Yes, sir.
Mostly.
Yes,
Why?
sir. Because the right-sided growths are the ulcerative type of growths.
How did melena happen?
Because of the bacteria acting on the.
Melena is happening due to acid emesis.
No, sir. The
No longer.
bacterial acting.
Bacterial action. And the transit is slow.
Yes.
So the right-sided growth.
There has to be certain amount of bleeding staying there for certain amount of time for melena to happen. So usually it is that the cecal cancers, they bleed, but they do bleed slowly. So patient comes with usually what is said as classified as 3 A's.
Anorexia,
Yes.
anemia, asthenia.
We made a recording of that dose, no? What is that? Lung, obstructive
Sure.
features, anemia, asthenia, anorexia, dyspeptic symptom in stomach.
Stomach is involved.
And silent. But usually right-sided growths, you're right, can produce. Fecal malignancies can produce. And the reason is the same. Transit time is increased and slow amount of bleeding. Left-sided growths produce.
What is the classical color of stools from right-sided malignancies? Classically described color. One way to describe is melena, if there is more bleeding.
Could be present as hematochezia.
They are usually described as maroon colored stools, and patients may even have clots.
Do you have any versatile swelling which is present there in that region?
Yes. Yes, sir. Iliac artery aneurysms.
Not been mentioned the versatile or not
Is it
Yes,
firm, hard?
hard because of his consistency is hard.
and won't be extending there to the lumbar region. That's why I have not discussed there. Of course, if you isolated swelling, which is limited there to the right iliac fossa, which is a smaller swelling, not so big like 18 before, maybe 18 before, rarely, but it may be pulsatile.
What are the other features besides this? Being pulsatile, any other feature?
There is radiofemoral. The pulse is.
Very good. Next.
And
what is the cause for it?
Could be the iatrogeny, could be the aneurysm, vessel wall pathologies like Marfan syndromes and
Some history to it, right?
Yes.
Right. So considering what you have is what you're discussing. So with this background, you got a suspicion of malignancy. Any benign condition that can present like this? These are standard questions which I've heard millions of times. For the Royal College exam, MS exam, DNB, MCH. ये सवाल आता ही है, इसलिए आपसे भी पूछें.
Ileocecal tuberculosis can be present. Because first is considering age, which is more older age, and there is a history of melena, and there is no constitutional symptoms.
Slide, picture.
Sorry, sir.
No,
no, sir. No, sir. There is no constitutional symptoms, and there is a history of melena, and patient doesn't.
But they don't normally bleed. They discussed yesterday. They can sometimes bleed.
Why tubercular lesions usually do not bleed?
Because they easily go into the ulcer is subcutaneous in submucosal plane.
But that doesn't answer the question.
Something happens to the arteries.
Ischemic changes.
Yesterday we discussed. What was the answer? Endarteritis. They usually
Endarteritis.
tubercular virtually also. Yeah. Endarteritis, and most of them are ischemic also. So what does that lead to?
There is a fibrosis.
More fibrosis. So there is strictures, not the transverse and longitudinal story. That buncombe is over. And when do they bleed? In which cases?
In the ulcerative type of tuberculosis.
Somebody, actually where the fibrosis won't happen, they'll bleed. These are things you should use, and very important question, and we adequately covered. How do you proceed now?
I would like to do investigation to confirm my diagnosis, to support my diagnosis, and stage the disease and treat the patient.
I think we must discuss what are the other differential diagnoses. So what we have discussed the carcinoma and
anything else? Get to the next. We'll go to the slide where last one. We skipped it actually.
I think
you have any differentials here?
Other differentials. 72-year.
You can stay here. Okay.
Yes, sir.
72-year. We are discussing the case who is
72-year-old, and you think it to be there is a right iliac fossa lump which
Yes,
is extension into the lumbar region, which you know, and it is relatively fixed in location. You have there's melina, know the loss of appetite and weight. What else can come to your mind? Now let's discuss.
My first probable diagnosis.
Discuss that.
Yes, sir.
Any differences?
In this case, sir, in normal.
Only this case.
Okay. Could be.
We're talking theory, it's a clinical exam.
Could be the terminal ileum gist. Gastrointestinal tumor.
I think you obsessed, all of you are getting obsessed with gist everywhere. Gist can happen wherever, but you have patient with symptoms. Right-sided symptoms are usually delayed, but you can have it.
Give importance to your history as well as your examination.
You got melina,
Gist
bleeding.
How does it present? How does the gist present?
Mostly asymptomatic and
Present with bleeding?
no, sir, obstruction.
No, just maybe a one-order differential diagnosis, but it may be a mobile lesion rather than.
Yes, it can't be fixed.
Most of the time it is a mobile lesion.
And not bleeding like this, usually extraserosal. And obstruction is also there. It can grow to a larger size than this and before it becomes noticed. But we grant you, that's still a tumor. Any other tumors there?
Retroperitoneal sarcomas.
So what about that?
Why it is not a lymphoma?
Retroperitoneal tumors, so what are those?
Liposarcomas, leomap.
These are liposarcomas.
Leomap.
Lymph nodes?
Paraiotic enlarged.
No, we talk about the lump is in the right iliac fossa. So the lymphoma comes in automatically.
Yes, sir.
And but you need to explain it. You won't compare apples to oranges, or certainly not apple to a donkey. So it has to be relevant to you. No, everything is possible, but what is probable? So they ask you, why is it not a lymphoma?
First is hard in consistency, and lymphomas is
the history which is important.
melina is there, and patient is.
Yes, sir.
Any point in history which goes in favor of being
Logical. Don't create a laundry list under it.
Just have be patient, go step by step. History, any point in favor of lymphoma?
See, we are not talking about the retroperitoneal lymphoma, we are talking about the GI lymphoma.
They talk about the internal, so it's a malignancy. See, lymphoma would be presenting in a particular manner. Can you tell us how it is present?
The age is a bimodal age distribution.
Good. Next.
And second is there is a night switch like
Constitutional
symptoms.
Third,
And
there is some pattern to it, no? But you know, it can confuse you. It can be a surprise. So you can bail yourself out of it by saying it's not as common as the malignancy. With melina coming handy, and the kind of patient didn't have any obstructive features, although. So this cecal malignancy, cecum getting lymphoma is not so common. ILM getting it is more common. So
yes,
there are few things that can help you there. And as for the gist, they said it is a fixed lump. And don't necessarily invent a differential. Clear?
yes, sir.
Retroperitoneal sarcoma is a possibility. What are the points against it?
One is melina, and
You'll have to investigate now, because everything cannot be clinically done. Right? Whatever my request is asked there, if that is important.
Extending from lumbar region to iliac fossa, or is it starting from iliac fossa and extending towards lumbar region?
starting from the iliac fossa to ram, because the symptoms is and pain is is telling right lower abdomen, more towards the right iliac fossa.
So you should say where it is maximally occupying. If it is maximally occupying the right iliac fossa, you can say it is present there in the right iliac fossa, extending there to the lumbar region. If the lump is occupying maximally there in the lumbar region, then extending partly there into the right iliac fossa, you can say it is there in the lumbar region. So it is vice versa. Sometimes what you have said is mostly the lump is present in the lumbar region. You say it's all because of the reason it is maximally occupying the right lumbar region.
Right. Okay. So we will not confuse you any further. We've done enough. Right? Common things are common, rare things are rare. And that's why they're rare. So let's not beat around the bush. Come directly to the point. Differential diagnosis in the right iliac fossa, you're thinking about benign problem or a malignant. Benign problems you've discussed a few, which could be related to tuberculosis or even inflammatory bowel disease. Unlikely, but all of them are unlikely. Then if you think of things which are outside, lymph nodes, retroperitoneal sarcoma. But your patient has got features which are suggesting intraliminal pathology.
Yes, sir.
So let's stick to something basic and common. So it is a right leg push up and you think it is carcinoma of the cecum. How do you proceed? In 5 minutes, you'll wind up.
I would like to do the investigation.
Possibilities of everything. They can keep on asking you because they exhaust everything. But you should be focused on what your case is.
Yes.
Possible, but is it probable? That is the question.
I would like to do the investigation to confirm and support my diagnosis.
You not stop. You finish your laundry list.
Yes, and to stage the disease and treat the patient. To confirm and support my diagnosis, first I would like to do the ultrasound wall abdomen. In ultrasound wall abdomen, I would like to see the origin of the lump and the margins and the lymph node status and the vascularity and the liver and the free fluid in the abdomen. After that, if it is ultrasound shows it's coming from the cecum or the ascending colon, then I would like to go to the colonoscopy to take the biopsy and to see the synchronous lesions and any polyps within the colon. After taking the biopsy, if it is come as carcinoma, then I would like to do the CECT whole abdomen to stage the tumor in. And after that, I would like to do the investigation to prepare my patient for the surgery. And before that, I would like to talk about this patient in the tumor board. Then I would like to take the decision regarding this treatment.
Perfect. So he's answered everything. And then specific you ask.
What would be the findings? The suspected CA cecum.
Hypoechoic and increased vascularity, and there is a lymph nodes involvement. Yes. Yes. Right.
Yeah, done an endoscopy. Endoscopy is somewhat normal with a coarse granularity which is present there in the colon. That is in the cecal area. What you will do, what kind of biopsy will you prefer to do in these patients?
Sorry, I can't get you.
See, you have done a colonoscopy. There's no means what you expect is the slow proliferative growth which is present there. It is not there. The mucosa is, you can say, coarsening of the mucosa which is present there. So what kind of means what you will do or what kind of biopsy will you do?
CT guided biopsy we can do.
You are doing the endoscopy.
Yes, sir.
Specific, what type of endoscopic biopsy? Are you aware what are the different ways of that?
You don't know, you'll answer. Please answer.
See, what is important is what we are now suspecting probably it is a submucosal lesion, and therefore in those patients, the jumbo biopsy is being taken or bite on bite biopsy is taken. Unless until you take a deeper biopsy, you won't come to a diagnosis, and therefore it is always been recommended if you won't get ulcerative lesions there, means also proliferative lesions, you always take a deeper biopsy. What we call it as a jumbo or bite on
Bite and
biopsy. We have not talked about the CA in these patients.
Sorry, I would like to do the CA, carcinoma antigen.
Why you want to do a CA in this patient?
One is if it is.
You want to do it preoperatively or you want to do it post-operatively?
I want to do in preoperatively, sir.
Why?
One is it will show the prognostic factor, and in the follow-up also it will help to know the tumor. If it is more than 10 nanograms per
Preoperative CA.
because I want to follow up the patient on the CEA so that if before comparing post-operatively, I want to know preoperatively also.
To add it on, like what is important in this patient, you want to identify the individual which are secretor and what are which are non-secretor. Because 30% of the patients, those who have a CA colon, they may be non-secretors. They have a normal CA value. And therefore, in the post-operative patients, these patients, you can't follow up these patients with serial CA values. And therefore, it is important that you must identify these patients pre-operatively that they are the non-secretors.
Very important point. 2 points were very important and he's highlighted it. My job is to speak loudly so that the online people hear. One is in tuberculosis, there are some mucosal, so you may not get the right biopsy, so deeper biopsy or jumbo biopsy or bite biopsy, which is clarified. Also, in contrast, in CT scan, you got to be more focused and specific. They need to have, there is a colon protocol also, so you should be aware of it. Thirdly, we have a role of PET CT in these patients, but importantly, CA, as you rightly said, some are non-secretors, some have liver metastasis that are studying the liver completely, no CA is produced. So you may have to look into it. Or some may have a false rise of CA. What are those cases where you can have a false positive?
In the IBD, inflammatory bowel diseases, and small if the patient is female, ovarian.
Lady.
Yes, and in the perforation also.
smokers,
Smokers.
cirrhotic patients, alcoholic patients. So this value has to be baseline here.
Okay, sir.
So many qualities. It's such a non-specific marker, but becomes specific when you are doing specifically focused on colon.
What would be the colonoscopic, gross colonoscopic finding in a tubercular, ileocecal tuberculosis?
Hyperplastic or could be ulcerative.
Do colonoscopy. What would you say in case of a tuberculosis?
Like
As sir, like, just pointed out.
submucosal ulcers.
Worsening of the mucosa, or you may at times get pseudopolyps. You may not get a classical ulceroproliferative lesion as you would expect in other ways in the malignancy.
Okay, sir.
Dr. Singh.
What is usually the biopsy?
Also in colonoscopy, we should mention or we will look for any synchronous
Yes.
lesions.
Mentioned. Tuberculosis, polyps, and
You've done the workup. How do you stage them based on imaging?
According to 8th AJCC classification, stage carcinoma in situ is involvement of the mucosa up to the muscularis mucosa, and stage 1 is mucosa submucosa involved. Stage 2 is muscularis propria is involved. Stage 3 is the colonic tissue is involved. Stage 4, there are two, stage 4A and stage 4B. Stage 4A is visceral peritoneum involved. Stage 4B is organ involvement. And the nodal involvement is N1, N0 is no nodal involvement. N1A is one lymph node is involved. N2 is 1 to 2 lymph nodes are involved. And N1C is only the deposits over the mesentery. And in the N2, there are N2A and N2B. N2A is 4 to 6 lymph nodes and N2B is 7 lymph nodes. M0 is no metastasis. M1A is only one organ involved. M1B is 2 or more organs involved. M3 is the, multiple deposits all over the peritoneum and the liver. And
That I think deserves a round of applause. He's absolutely spot on. You prepared for it, so we can argue this. We've done the staging workup, and any role of MRI in these patients and a specific MRI?
if it is synchronous lesion in the rectum, also we can go for the MRI to see stage the disease.
Not specifically for colon, but for when there is a
Rectum.
suspicious rectal lesion, which
Yes,
is
sir.
synchronous. I think we can move to management. Yeah. How do you proceed to manage this case?
I would like to discuss in the tumor board. After that, I will discuss with the
We
patient.
want to discuss in the tumor board. You are a surgeon, there will be a radiation person, medical oncologist, radiologist. So how would you put up your case? What is the best treatment for colonic cancers?
Surgery is the best
So
treatment.
you are the target, no? They will have to chip in. So where is it that they get involved? In your biopsy, you can be asked to do more things. What are those?
In the biopsy, I want to do the resectability or like R0 resection or R1 or R2.
No, biopsy.
Oh,
Histology.
yeah,
What do you ask the pathologist? What more questions do you want?
one is immunohistochemistry and the genes involved.
Okay.
KRAS or mismatch repairs.
And also microsatellite.
But instability.
MSI asked for, and they matter in the treatment. And which is the, you mentioned about the panel that you're doing, gene panel. What is in your mind?
One is to rule out the any familial adenomatous polyposis or the Lynch syndromes.
No, but how would it help in your management? Okay.
In the Lynch syndrome, if it is a turnout beam,
No, in this case, you need to know it from you need to know about some planning for the targeted therapy at some point.
and
How is KRAS helping? You mentioned KRAS.
KRAS tumors are the more aggressive tumors and have the poor prognosis. And if it is left side tumor, I would like to do the endothelial growth factor.
I'll leave you at that because you're a postgraduate. That's okay. We'll not go further there. Any quick question relating to surgery or workup? You can move.
What surgery you plan to do for this patient?
Radical right hemicolectomies.
What does that mean?
It includes removal of the terminal ileum of 6 to 10 centimeters and the cecum and appendix ascending colon and transverse colon till the right branch of the middle colic artery.
You said radical right.
Yes, ma'am. Including the mesentery and the lymph nodes, we have to take out till the principal artery. I want to know whether the resection, R0 resection or R1 resection. I want to know the tumor borders, and type of the tumor and the immunohistochemistry and the gene profile. Yes, sir. 12. If it is less than 12, if we remove less than 12, it's we have to remove 12.
To ask which one.
Yes, sir.
No?
Yes, sir.
The numbers is important, and also the other things which are relevant. Any role of in this surgery, role of like we have the TME, we also have the CME, no?
Yes, sir.
Mesocolic excision. Any idea about that?
In this, we have to remove.
Mesocolic would be presented, so we don't discuss the techniques here.
I will be showing you videos.
Yeah, so that's why.
What is this total mesocolic excision? How is it different from the?
You understand, or if you don't understand, then it's okay.
I didn't get the question.
TME, the mesorectomy there, the colon is now taken into account. No problem.
We have to remove total mesentery of the colon.
Longitudinal or circumferential?
Circumferential is more important.
Now, any adjuvant therapy based on surgery that you've done?
If the tumor borders are positive and there is less than 12.
The resection is R0. Any role of?
If it is perforated and spillage in the within the intraop.
R0 perfect surgery done, patient is happy, you are happy. Now in the tumor board again, chemotherapy, yes or no?
I would like to know the nodal status also, like how bad.
What should be the T of the tumor?
That's important. You ignore
Yes,
it
sir.
completely. T is very
T
important.
important.
And you mentioned the stages of T, so they have to be relevant. You'd like to ask the pathologist about it more and
Yes.
more. How does it change your management?
Yes, sir. If it is more than T2, we have to go for the adjuvant chemotherapy.
So then, be focused on that. And what is the adjuvant regime usually?
FOLFOX, we usually FOLFOLFIRI, capacitabin related, capacitabin and.
Last question. You have completed the treatment. Patient is fit and fine. How do you follow up these patients?
I would like to do the one is clinical examination and ultrasound whole abdomen and colonoscopy every 1 year for the first. No, sir. First we will do after 3 months.
Tell your patient that you are going to come back every 3 months.
Yes.
Every tumor has a very high chance of recurrence within the first 2 years.
Yes.
So first 2 years follow-up should be very strict, regular, aggressive. And after 2 years, for next 3 years, still there are chances, but less. So next 3 years, it becomes a bit lazy kind of a follow-up, but still it is good. After 5 years, if everything is fine, patient is fine, you may follow them for every year. Now, what happens in every follow-up visit? You take a history, you take examinations, and then you ask for some investigations if required. So the question is, what history you would like to ask for from such patient who have.
And the distance.
Can you blow up the question? We'll address them now. Trying to be loud, I hope, very low and now. We'll do something about it, Harsh, questions coming. But they've all been covered. Thank you very much. You made an excellent presentation. I think one of the best.
Thank you.
So you should be happy about it. When do you do colonoscopy? Next Venkat City.
Assuming that you have had a preoperative.
When do you do colonoscopy in a follow-up?
In the follow-up for within 1 year, we have to do first.
Not routine. It's not a recommendation.
Sigmoidoscopy plus fecal occult blood test is. After the 4 weeks of the 3 to 4 weeks of the first surgery, and after that 6 monthly, we have to completing 4 weeks.
Therapy,
4 weeks.
Thank you. Well done. We have give a round of applause. We did a very good presentation. And we are moving on to the next presentation. That is Venkat Chalapathy, both Dr. Seema and Dr. Puneet. They're the mentors. Lump left hypochondrial. Are you ready, Venkat?
Yes, sir.
Start.
Good afternoon to everyone. This is a 21-year-old boy, resident of Gaya, student came to OPD with complaints of lump in left upper abdomen since last 5 years, pain in left upper abdomen since last 2 years, with a single episode of black tarry stool 3 months back. Patient was apparently all right 5 years back when he noticed lump in the left upper abdomen, which was insidious in onset, gradually progressive, initially small, which has increased to current size. And the pain was insidious in onset, dull aching with a dragging sensation, gradually progressed, non-radiating, non-referring, with no aggravating or relieving factors. He also complained of a single episode of black tarry stool 3 months back, which was foul smelling and stuck to the pen. There were no history of malaise, nausea, blood in vomitus or blood in sputum. There were no gum bleeding, bone pain, passage of fresh blood in stool, yellowish discoloration of eyes and urine, abdomen distension, anorexia, weight loss, fever, altered bowel habits, admission in hospital during his neonatal period. Patient had 3 to 4 episodes of hematemesis and melena at the age of 9, for which patient was admitted in a private hospital and was managed conservatively with a single unit of blood transfusion and endoscopic intervention. No history of any other chronic illness or medication. Family history were insignificant. He is a non-alcoholic, non-smoker, vegetarian in diet. Bowel and bladder habits were regular, and sleep cycle and appetite was unaltered. So, to sum it up, 21-year non-alcoholic male presented with chief complaints of progressive left upper quadrant lump for 5 years, associated with dull aching pain since 2 years, with single episode of melena. He has history of 3 to 4 episodes of hematemesis and melena at the 9 years of age, for which he was managed with single unit of blood transfusion, followed with endoscopic intervention. There is no history of jaundice, distension of abdomen, anorexia, weight loss, or syndrome. With the patient is in young boy with controlling the upper view and next of the property
Regarding the history question, you want to ask him?
Yeah, is that the only diagnosis you want to keep in mind?
No, he's not diagnosed. In the history, any question?
Further exam.
I'm sorry, I keep that mind tuned, otherwise it goes over.
Is splenomegaly the only option that you have in mind?
Left hypochondrium in the lung,
Sir,
spleen, right?
I've asked for several negative history. That is one of the negative history.
What else did you want to talk?
So, tropical infections and any leukemia history, bleeding from the gums, and any liver derangement.
Since you could connect the dots,
Yes.
so you ask very specific questions, right?
Yes.
But in general, there could be many questions you can ask for us, I think we can cover that later. In terms of history, I think it's a good history. You covered most points.
Thank you, sir.
What impression are you making so far?
So far, he had a hematemesis and melena 9 years, portal hypertension with.
Splenomegaly due to portal.
Yes,
That's in
sir.
your mind?
Yes, sir.
Okay. Let's go.
Proceeding with the general physical examination, he was examined in a well-lit room in supine after consent. He was conscious, alert, cooperative, well-oriented to time, place, and person. He was average build, well-nourished. Hydration status was normal, BMI 20.9. Patient was afebrile. Pulse was 70 beats per minute. Normovolumic rhythm, regular in rhythm in right radial artery. And BP measured was 132 by 76 millimeter mercury in right arm supine position. Respiratory rate is 16 per minute. On general examination, there were no pallor, icterus, cyanosis, clubbing, pedal edema, or generalized lymphadenopathy. JVP was not raised. There were no stigmata for chronic liver disease. Going further on abdominal examination, there was a
His notch looks cute. Right, it doesn't.
There were a visible fullness involving the left hypochondrium, left lumbar, epigastric, reaching up to umbilicus, which moved with respiration. The umbilicus was inverted. Sir?
Is it spleen?
It is spleen. Umbilicus appeared inverted, shifted downwards. All quadrants moved proportionately with respiration. The overlaying skin was normal. There were no scar pigmentation, striae, or dilated veins. Hernial sites and external genitalia were normal. To further confirm my inspectory findings, on palpation, the abdomen was soft, non-tender, with no local rise on temperature. A firm lump of size 12 cross 10 centimeter in size below the left costal margin is palpable, reaching to left hypochondrium, lumbar, epigastric, and umbilical region with smooth surface, well-defined splenomegaly. Yes.
That's why I gave you that description you were smiling on. It's easier. Don't beat around the bush. No, we all understand what you're saying.
Yes, sir. The upper margin was not palpable. Fingers couldn't be insinuated between the lump and the left costal margin. There were no hepatomegaly. On percussion, the dull note was heard over the lump. Liver span is 10 centimeter in the right mid-clavicular line. Upper margin dullness from fifth intercostal space. No clinical evidence of free fluid. On auscultation, bowel sounds were normal, and there were no bruit over the lump and in the umbilical region. Bilateral renal angles were free, non-tender. On digital rectal examination, the tone was normal, no palpable mass, fecal staining of the gloved finger, no blood stain. On proctoscopy, there were no evidence of rectal varices. The systemic examination were within normal limits. So to summarize my case, this is a 21-year non-alcoholic male presented with chief complaints of progressive lump in the left upper abdomen for 5 years with associated dull aching pain since last 2 years, with single episode of melena 3 months back, with a significant history of 3 to 4 episodes of hematemesis and melena at the age of 9, for which he was managed with a single unit of blood transfusion and an endoscopic intervention. No history of jaundice, distension of abdomen, anorexia, weight loss, fever, or umbilical sepsis. On examination, splenomegaly of size 12 cross 10 centimeter was present with no hepatomegaly and no evidence of free fluid in abdomen without any stigmata of chronic liver disease. So my probable diagnosis would, yes, sir. Portal hypertension, most probable cause would be extrahepatic portal venous obstruction.
Wanted you to include in the history was that did the patient have any bleeding tendency of any kind? Because I know you gave a very specific history that there was an endoscopic intervention pointing us and pointing towards the fact that probably some variceal, sclerosis was engagement was given.
Yes, ma'am.
But then still you should rule out because
I've
it's not that splenomegaly only could be the reason for upper GI bleed. There could be any other pathology, lymphoproliferative disorder.
I have asked for gum bleeding. Ma'am, I have asked for gum bleeding and
yeah.
Yes, ma'am.
So in your clinical examination also would have been happy to see if you had mentioned about sternal tenderness and
yes, ma'am.
Asked about mentioned about endoscopic intervention. Any details of endoscopic?
He mentioned it as banned, although there were no documents. Banding was done.
I thought very good presentation. Actually, you covered up many things very intelligently. Those things can be handled.
Thank you.
Don't be repetitive to things that annoy people. Don't be repetitive. Don't be very, difficult. There is a lump in the right hypochondrium, moves on respiration, all sides are very normally, below the living shape, not visible. And tomorrow I'll tell you it's gallbladder. That doesn't make sense. Palpable, spleen, good. Splenomegaly. Is there any differential that you carry?
Less likely non-cirrhotic, but although he had an episode at an age of 9, at an early age, we won't consider such a diagnosis. For leukemia being another differential, he didn't have any growth retardation, anything like that.
External tenderness, bony symptoms, bleeding disorders, tendency to bleed, all they become relevant automatically. That's why she was suggesting that. Now, usually it's a takeaway, these cases are, right? What is the characteristic of a splenomegaly which distinguishes it from any other? Say, if I just by out of curiosity say it's a part of the usual tropical splenomegaly that you observe. So how is the spleen different?
There's a massive splenomegaly.
What are the causes for massive splenomegaly in general? We are dealing with the benign syndrome.
In general, I mean, portal hypertension and
massive.
gaseous storage disorders, leukemia, and any myeloproliferative disorder.
Yes. So we were taught chronic three, chronic myeloid leukemia, chronic kala-azar, chronic malaria, massive. And then minor were these malaria, acute malaria, typhoid fever, and in between were these, hematological disturbances. And the spleens felt different. So is there any difference which by examining the spleen, can you say it's not a lymphoproliferative disorder or any lymphoma or something related to myeloproliferative disorders?
Consistency here would be, there would be more hard. It's firm. And if there is a associated infarct, it would be tender. And
what is the spleen like in chronic malaria?
Sir?
In chronic malaria, chronic kala-azar, what is the spleen like?
Again, firm. It would be firm, sir.
Sometimes, especially in kala-azar, when it is very stretched, it can be tender as well as slightly on the harder side. So it can be confusing. But otherwise, you're okay. With this diagnosis, how do you proceed?
Sir, I would go with an ultrasound, sir. Color Doppler, preferably.
Unless we stop, don't stop. Carry on.
Sir, I would go for an ultrasound, preferably color Doppler. Ultrasound of the whole abdomen.
To answer properly,
yes,
I do investigation to confirm my diagnosis. For that, I use an extension of clinical examination, which is an ultrasound of the abdomen.
Yes, sir.
Any specific things in this ultrasound that you will ask for?
Sir, first the liver status, and then where we'll look for any signs of altered echo texture or any signs of CLD, cirrhosis, and then portal vein, its diameter, flow of direction of flow, velocity, and the portal vein, any thrombosis in first order.
Pressure also, with the added
the portal vein.
that you have,
and any intramural thrombus in the portal vein, first order branches, or
in addition to portal,
cavernoma.
other veins you would look for specifically?
Splenic, mesenteric, superior mesenteric, renal, and any collateral. I look for the collaterals if we get at a thrombus.
This patient bled once.
He bled once.
So what more in ultrasound?
Sir, in ultrasound, we would look for if ascites is present or not.
Okay.
And
so there's so much you can do with ultrasound, adding various appliances to it, whether it is adding the Doppler.
Elastography.
You can do elastography. How is that done?
So that's it's
elastography for the vein or
for the liver. Liver also for the spleen, but generally for the.
Basically, that is where the.
To rule out cirrhosis, we go for that. Normal factors for?
Normal fibroscan by which you can say that.
The values of the fibroscan, which will indicate it is.
Sir, up to 6 kilopascals, it's normal. 6 to 13, it's plus or minus cirrhosis. Yes, sir. Plus or above, it is cirrhosis to some extent, and above 17 to 18%, it is confirmatory, like around 80%. Yes, sir.
So you don't have an ultrasound, your features are by and large okay. Any more investigations?
Sir, then I will go for an endoscopy, sir. Endoscopy, upper G endoscopy, sir. Sir, look for look for duodenal. As we retract back the endoscope from duodenum to the upper esophagus.
What all do you want?
So in the duodenum, you look for duodenal varices, then there may be ulcers too. And there is in gastric varices, portal gastropathy, signs of portal gastropathy, and esophageal varices, esophagitis.
Very good, very good.
Yes.
And anything you would like to exclude when you're doing this?
And
when you're doing the endoscopy?
sir, we'll look see for the banding, the grade, the varices, intervention. There is a classification, Bavino classification. Grade 1 is there is varices. Varices just seen, and mild is, grade 2 is when it involves 1/3 of the esophageal circumference. Grade 3 is when it involves more than 1/3 of the circumference. There are other classification too. There are many classifications. So prophylactic banding can be done based on the grading. If there is a low grade, the follow-up will be after every 6 months. If it is high grade, the follow-up will be after every 3 months after completely sclerosing or banding this thing, varices.
We moved up. How do you manage this patient? Anything more that you would like to do? I am rushing, not trying to rush you.
We assume that this is a early grade or a
early grade is
it is not actively bleeding or anything. So how is it?
Sir, I would order for indication of any other for any other intervention. I would look for order, although there is no other signs and symptoms of clinical hypersplenism. I would order a blood drip, his CBC. Look for any.
We thought we assumed that. What
Yes.
would be the features in hypersplenism?
Sir, there is a splenomegaly with at least bicytopenia, which gets corrected after splenectomy. And although we don't do a bone marrow, it will show hypercellularity.
You know, your hematologist reports back polychromasia. What does that mean? Or the report comes as how Johnny body is present. A cabled ring present. What would you suspect?
Spleen, Howell Jolly bodies are seen in thallus.
These are all fusion positive bodies. They have DNA in them. So that's basically indicating the destruction that is happening. So you'll have to prepare for that. And as you rightly said, hypersplenism is also the final thing is correction of everything with surgery.
Yes.
So the report of hematologist becomes extremely important. You need to look into it carefully.
Yes, sir.
What do you plan for this patient? The scenario is what Dr. Penile just mentioned.
Sir, we can do an banding, further banding if varices is present. I can go for a splenectomy would suffice with or without shunting. Yes, sir.
Some medication?
He was not under any medication, sir. He was not under any medication. Although he should be put on a propranolol following banding. So after banding, patient will be put on 40 mg propranolol.
Collecting? Speak loudly.
That is for.
That is what you plan splenectomy.
But when will you plan splenectomy? Complex situation or any specific indication?
So clinical hypersplenism should be there. Patient should manifest with anemia, recurrent infections, thrombocytopenic features, and if there is a failed banding after 2 times, and if there is
Not surgical options in the man.
banding,
What is that you mentioned? You already mentioned.
tips won't help in EHV.
Look at what you've written. Okay, how do you take a decision about splenectomy and how do you plan it?
So that's what following indications I would do an splenectomy. Before that, if at all there are indications, then I'll go with a.
Any problem doing elective splenectomy in these patients?
No problem, sir. We can do an
No.
elective.
Wouldn't it be a good idea if the patient is bled 2 or 3 times, that you go for it, plan it and do it?
Sir, if
No, would it be a good idea to go, patient, suppose they've had 2, 3 episodes of bleeding?
so after banding, I can give a pre-op vaccination for after 3 or 4 weeks. I can plan for splenectomy, sir.
What is the difference between this splenectomy and the one that you do for trauma? Or
There will be a lot of collaterals we should be aware of. Yes.
What do you approach?
As
Artery or the vein?
the first will be the
It's a planned
artery.
splenectomy.
Auto transfer. Yes, sir. First is to clamp the arteries. Auto transfusion occurs.
So ligating the artery makes the spleen smaller.
Yes,
Don't
sir.
go for the vein, it will become even bigger. Collateral will create a havoc here, right? Anything else you can do locally to make this spleen?
Embolization. Preoperative embolization.
Yes. Anything on the table that's not practiced in the past, still do, put lap tension otherwise.
Not
They're
a
doing splenectomy for hypersplenism.
not
Or
a
for ITP, electives. We are now moved to splenectomy, ITP or whatever. They would inject
Sclerosis.
locally, which will cause compression of spleen, and that will also get some blood out, so that less of damage happen to the platelets, etc. Because you would kind of make it smaller. Have you understood?
Yes, sir.
So there are few things which can do electively there. Any difference in the approach to the pedicle?
Sir, hilum first.
And what is hilum? What is the vessel there?
Sir, splenic artery.
So be more clear on that. So you again say the same thing, approaching the artery first.
Yes.
Right?
Yes.
Which ligament you are addressing when you do this?
Linorenal.
Speak loudly.
Linorenal.
So why do you apologize about it? Speak loudly.
Yes,
Well
sir.
answered. And why vaccination beforehand?
Sir, beforehand, after splenectomy, there are risk of infections. Spleen
How
being
is
the
your patient?
21-year-old.
Till what age is the risk?
Sir,
All ages. The risk is
all
more in the
yes.
younger children.
We give
but all
vaccine.
ages. And what is the cause? What happens if you don't take it?
There are the opposite.
What is the opposite?
Overwhelming post-splenectomy infections.
What are the organisms?
Pneumococcal diarrhea, meningitis, hemophilus influenza.
My case is the risk. Yes.
Yes, sir.
If you're achieving this, where would you look for the exercise?
Most common location being hilum, followed by a greater omentum, lesser sac, and
Put your hand down the pelvis also.
yes, sir. Infracolic compartment.
I think sorry.
Here you have made a diagnosis like extrahepatic portal venous obstruction. You want to say that it is a NCPF or it is a portal venous obstruction because of the thrombosis?
This, sir, NCPF, first of all, present after an age of 25 to 40. 9-year-old, he had an episode of hematemesis and melena at the age of 9. That would be one point. And other than that,
This patient who had jaundice, so all are young patients, so all of NCPF other than the
sir,
because of the portal venous.
so one, that's what said, at 9 years of age, he had an episode of melena, followed which he got banding. So that was the.
What is the difference? Okay. When you call it as a NCPF,
That's
it's a non-cirrhotic portal fibrosis. So there is a portal fibrosis, means the portal venous obstruction is present there in NCPF also.
Yes, sir.
And in the portal venous obstruction, there is a thrombosis of the portal vein which is present. So do you feel like it is the same thing or it is a different?
Sir, pathologically, involvement of main portal vein or the first order branch of portal vein, thrombus in EHPVO. If it is second or third order, it is NCPF.
Beyond third order.
Beyond third order.
NCPF. So beyond third order, you can say fibrosis is present.
Yes, sir.
Or a thrombosis is present. We call it as NCPF.
NCPF.
Otherwise, we call it as a portal venous.
Yes, sir.
Extrahepatic portal venous obstruction.
Then there is age. Then there is the presentation of the age, and then there is As it presents very early, it is associated, it can be associated with growth retardation.
Okay, so what we are discussing, is it splenectomy the treatment of choice or something else?
So
Apart
I
from splenectomy?
can go for a shunting, sir.
You want to do a shunting?
Hmm.
What kind of shunt?
Proximal lenorenal. As splenectomy is done, so that will.
You do splenectomy also, and do
Yes.
proximal.
Yes, sir.
Shunt, right?
Yes.
So would it be inadequate to, or it will be suboptimal to do splenectomy alone?
Sir, that would, most of the times it would suffice, sir. Splenectomy.
So how do?
If the presentation is so late, so it should suffice, sir.
Because it is a very
Yes, sir.
but option should be kept.
Yes, sir.
Keeping the business shut. Only last question.
Can you, by looking at the screen of the table, speak about the blood supply?
Sir,
The appearance of the screen tell you about the type of blood supply to the screen. Do you know about the types of arterial supply to screen?
types, I mean,
So there may be a magisterial and a distributed supply. And in case you find that there are multiple notches, you can expect that it may be distributed in nature. So if you've ligated one vessel, it may not take care of the size of the screen. You may need to ligate more than one. So it's important to identify.
Thank you so much. We have a wonderful presentation.
Thank you, sir.
Wise, but don't stick to just one thought. But I'm glad you mentioned that patient. It's a delayed one, so we would like to go first. You have both options already. Be prepared to answer question time.
yes.
Again, I would say that in surgery exams, postgraduate exams, you have a high probability of getting good marks, passing with flying colors. You think that this case.
Yeah, another case where you can freak out. So you did freak out. Thank you. Well done, Venkata.
Thank you, sir.
And actually, we're very late for the next session, but unfortunately, yesterday we could take care of it. We have a talk as well as this groin session, so both got delayed. So is Haziq and Jamil from JNMC AMU here? You would insist on presenting? Or after the next session? Okay, you please do it. With your permission, Dr. Sanjay, because this class goes on. This is a typical class and not a conference, so the time sometimes goes out of control. Before that, you'll be free. So thank you for that. We move on. This is the last case, and I request the examiners to keep it, I mean, the teachers to keep it.
Hello, check.
I'm glad.
Respected teachers and my fellow residents, so I'll be presenting a case of a hypogastric lump. So we have a 36-year-old gentleman, laborer by occupation of average build, resident of village Rajpur. He presented to our surgical OPD with chief complaints of lump in the lower abdomen for 6 months, pain in the left flank for 1 month, and difficulty in micturition for 1 month. History of presenting illness. Patient was apparently well 6 months back when he noticed a lump in lower abdomen, which was initially of a size of a ball, around 3 to 4 centimeter, and gradually increased to present size of approximately 50.
Just stop, please. Sorry, I'm sorry. Which ball? Football or the tennis ball?
So tennis ball.
Don't mention it. You mentioned 3 to 4 centimeters, that's fine.
Sure.
Okay, thank you.
To present size of approximately 50 into 12 centimeter, insidious in onset, progressive in nature, and there was no diminution of the lump with the passage of urine as observed by the patient. The patient also reported of pain in the left flank for 1 month, which was insidious in onset, mild to moderate in intensity, persistent, dull aching in character, aggravated during micturition, and relieved after passage of the urine. There was no radiation, shifting, or referral to any other site, not associated with food intake, vomiting, and there were no any other aggravating or relieving factors. Patient also reported of difficulty in micturition with narrowing of the stream and terminal dribbling of the urine for the past 1 month. It was not associated with any other obstructive features of hesitancy, urgency, or incontinence. There was no history of fever, anorexia, no history of hematuria, hematemesis, or melena. There was no history of obstipation, no history of hemoptysis and shortness of breath. There was no history of any jaundice, no history of musculoskeletal pain, that is the back pain, no history of any altered behavior and loss of consciousness, and patient also didn't report of any urinary incontinence and bundling micturition. Past history, patient had previous history of recurrent flank pain for the past 1 year. There's no history of any surgical intervention in the past or any specific drug intake. There was no history of any tuberculosis, type 2 diabetes mellitus, or hypertension, or any other chronic illness in the past. Personal history: patient is a married gentleman with belonging to a poor socioeconomic status. The diet is mixed. Bowel habits were regular. The bladder habits were irregular, as I just mentioned. There was no history of any substance abuse, and there was no known drug allergy. There was no history of similar illness in the family member. Treatment history: patient were taking NSAIDs with a local practitioner for pain management. Coming with the examination, patient is of average build and adequate hydration status, sitting comfortably, conscious and alert, well oriented to time, place, and person. The BMI of the patient was 19.8. The vitals were, pulse rate was 90 per minute with normal rate, rhythm, and volume with no special character, felt at the right radial artery. The blood pressure was 132 by 90 mmHg, measured in the right upper arm. Respiratory rate was 16 per minute. Temperature was afebrile, and the patient was maintaining saturation of 98% on room air. Pallor was present. There was no icterus, cyanosis, clubbing, pedal edema, or any lymphadenopathy noted in the patient. Systemic examination: cardiovascular system, S1, S2 was normally heard. There was no added murmur. Bilateral equal air entry present, and there were normal vesicular breath sounds on respiratory system. There was no any added adventitious sounds. Central nervous system was also within normal limits. Patient was conscious, oriented to time, place, and person. There was no focal neurological deficit. Before moving on to the per-abdominal examination, I would like to showcase two videos, examination videos. Can I get this on screen share? Because probably. Okay, fine. Thank you. Taken from the patient and maintaining the privacy of the patient with proper exposure of the abdomen, we shall proceed with the per-abdomen examination. Here we can clearly appreciate on inspection that there is all the quadrants of the abdomen move equally with respiration. There is no scar mark, there is no engorged vein, there is no any visible pulsation that we can appreciate in any of the quadrants. Now, if we proceed with the palpation, which is one of the important components of examination of an abdomen, we shall proceed with the superficial palpation. If we do starting from the left iliac fossa and then moving upwards, here we can appreciate that there is no tenderness which is present. There is no, the abdomen is soft in all of the quadrants. Here we can clearly appreciate towards the lower side of the periumbilical region and in the hypogastrium region, we can appreciate a bulge which is present. And then moving forward, here in the right iliac fossa, again the abdomen is soft, no tenderness present, there is no wincing effect which can be appreciated on the expression on the face of the patient. Now, proceeding with the deep palpation to assess any organomegaly which might be present, we shall proceed to ascertain any hepatomegaly which is there in the patient. सांस लीजिएगा गहरी गहरी. So there is no apparent hepatomegaly in this patient as well. If we proceed to ascertain the splenomegaly as well, so in the midline there is a bulge which we can appreciate, but there is no apparent splenomegaly. So with the necessary consent taken from the patient, so one more video.
In the demonstrating the percussion.
The dull note. Yes. And again it's tympanic. On further elaborating, if we do the auscultation as well to ascertain the vowel sounds present.
I think you can summarize it.
Yes, sir. Yeah, so the vowel sounds also appear to be normal at the rate of maybe 3 to 4 per minute. Okay, so moving on with the abdominal examination, as I just mentioned on inspection, all the quadrants of the abdomen proportionally move equally with respiration and proportionally move with respiration. Umbilicus was central and inverted. The fullness in the lower abdomen was seen. There was no visible peristalsis, pulsation, scar marks, venous engorgement, or any pigmentation as observed on inspection. Moving on to the palpation, the upper abdomen was soft and non-tender. There was no local rise of temperature, no organomegaly, guarding, or rigidity. A firm, non-tender, fixed lump of 15 into 12 centimeter palpable in the hypogastric region, extending to the umbilical, left and right iliac and lumbar region with smooth surface, well-defined lateral and upper margins, while the lower margin could not be delineated. It was not fixed to the overlying skin and not moving with the respiration. The lump became less prominent on leg raising or head raising, and the lump did not fall sideways on lateral position. There was no evidence of any free fluids, shifting dullness was absent, and auscultation bowel sounds were normal. Proceeding with the digital rectal examination, the lumen was normal, fecal staining was present. There was a firm mass felt on the anterior rectal wall. Rectal mucosa was free. Examination of the skin, no lesion noted, and examination of the back and spine, no abnormality noted, as I just mentioned. So summarizing the case, we had a 36-year-old gentleman of average build and nutrition presented with lump in the lower abdomen for 6 months, pain in the left flank, and difficulty in micturition for the past 1 month. On examination, a 15 into 12 centimeter firm, smooth, non-tender lump was palpable in the hypogastric region, extending into umbilical, lumbar, and iliac region, non-mobile, with indistinct lower margin, probably a retroperitoneal mass. These shall be my provisional diagnosis. A retroperitoneal sarcoma, presacral teratoma. We can have neuroendocrine tumors like schwannoma, neurofibroma, or ganglioneuroma.
Right, so good, nice effort, and I appreciate. Give him a round of applause for making that effort. Now, importantly, when you take the lump in the hypogastric, you don't necessarily need to bother about movement or destination.
Yes.
These are not supposed to move. So right iliacus, left iliacus, hypogastric. They would not move. And importantly, when you already found out to see.
Yes, sir.
Okay? And you don't need to do the leg raising test separately. The moment you say intra-abdominal, we believe that you've done it. So you don't need to demonstrate.
Sure.
You can say that this is an intra-abdominal lump. Let the examiner ask you how to do it. These are the two comments I would like to make before they take off.
Again, the thing is that you should not have asked your patient to take a deep breath. Not required. The other thing is, you have mentioned the lump is fixed.
Yes.
What do you want to say? Fixed to what?
I mean, sir, the lump was not, I mean, it basically tends to say, I'm tends to say that it's having a retroperitoneal region because these are deep-seated lumps. These are mostly fixed. Can be fixed to any adjacent organ which is present in the retroperitoneum, or can be a primary retroperitoneal mass as well.
Was it mobile?
No, it was not mobile.
Kind of bimanually palpable there. One finger in the rectum and another.
Predominantly, it was present in the hypogastric region, so bimanual palpation was not attempted.
By digital.
By digital, yeah. Exact.
Okay, what we have said is the 15 to 12 centimeter lump is present there, but what you
Yeah.
have shown there in the examination finding, it is not extending there to the iliac fossa. It has only been restricted there to the hypogastric region.
Actually, sir, with the surgical sketch I mentioned, I mean, I just delineated the prominent part of it.
But it is not the way, because what you have shown there in the diagram, it is very much evident that it is not crossing the mid-clavicular line. So we can't say it is going into the iliac.
Was it visible that much and palpable beyond?
Yeah, it was palpable beyond, visible that much. Yeah,
Visible.
exactly.
Well, that's why I'm
Yeah,
asking.
yeah.
Clarify.
Yes, sir.
It is important because I think that's all.
Did you ask the patient to empty the bladder before you palpated the lump?
Yes, ma'am.
That is an
Important point,
thing
yes.
to note. And if there
Yes.
is any change in the size of the lump after the patient emptied past urine, did you try palpating the lump after catheterizing the patient?
Ma'am,
You
actually,
won't categorize him, but you can ask him to void urine.
yeah,
Sometimes there may be incomplete voiding in chronic retention of urine.
sure.
We can't, in doing clinical examination, don't pass in a catheter. But the point is taken. You understand bladder related.
Bladder related, yes.
So you've made the patient empty the bladder and
Yes,
examine.
Yes, sir.
That's all you do. Otherwise, you do ultrasound.
Yes, sir.
You won't put in a catheter.
Yes, sir.
Yes, if the patient is in retention, then.
What urinary complaints did you specifically mention?
I just mentioned that patient was having difficulty in micturition, but actually, the patient was, I mean, the passage of the urine was not, I mean, patient was not able to pass the urine easily.
in this difficulty? What difficulty did you ask for?
I asked for that hesitancy, urgency, and
Tell me the difference between, we go back to the case immediately after this. Can you tell me the difference between chronic retention of urine and acute retention of urine? Why is it not bladder is what I want to know. Just because you're calling it for any.
no, ma'am. There's one supportive point that it's not a bladder. Bladder origin.
The difference between chronic
Yes,
retention of urine and acute retention of urine.
in acute retention of the urine, I mean, there will be distension in both the cases, but in acute retention, we can delineate the urinary bladder.
Start with history. Don't get confused. History and examination. In history, how is acute different from chronic?
Obviously, so temporal relation will be
Temporal relation. Which one is painful?
acute will be painful.
Basic, don't complicate things. Easy. She asked you a straight question.
Yes.
Now, you've given a differential of retroperitoneal sarcoma, pre-sacral teratomy.
Yes, sir.
Is it because you want to give a differential, you've given it, or you have it in your mind?
So probably because I mean,
DRE?
so there was a mass which was felt at the anterior rectal.
Okay, sir. And all DREs.
Yes, sir.
If you do it properly, in which position did you do it? I would not have asked you this, I swear, but I'm now asking.
So laterally with
What is
knee.
this position called?
Sims position.
How do you put a patient in Sims position?
So we ask the patient to, I mean, in lateral decubitus, and then we ask knee, I mean, to approximate the knee to the chest.
What else? The classical Sims position is left lateral.
Left lateral, yes.
The knees flex to the chest, and right. He said, then pillow under the buttocks.
Buttocks.
Lift it up so that you don't bend down, and the buttocks just getting out of the examining table so that you don't go over the table.
Table. Yes, yes, sir.
So when you're doing it, you finish by saying sacral and hollow is normal. So DI would have shown that.
Sure.
So how does teratoma appear? You do everything. I'm not going to the DRE right now. Position I asked you.
Yes, sir.
But then you should not be taking a pre-sacral teratoma as a differential in your mind. You have examined them.
Yes, sir.
The others are not clinical diagnosis. You don't know. They're all counting out retroperitoneal tumors only.
Yes, sir.
So you think it's a retroperitoneal malignancy or benign condition?
So clinically, I mean, it was appearing to be a benign condition because
all tumors this size in retroperitoneum was taken as malignant.
Malignant, otherwise, yes, sir.
That's why I asked you this
Yes, sir.
specifically.
Yes, sir.
This is your diagnosis. We don't doubt it. One question is very important was asked: why is it not bladder?
So first of all, the mass was felt at the anterectal wall.
What all would you expect?
So the contour of it was not the lump was not taking the contour of the bladder, which shape of the bladder, and on DRE examination also it was like approximating, abutting the anterectal wall.
How was the prostate on DRE?
So prostate was normal.
Important because you mentioned
Yes, sir.
complaints.
Yes, sir.
So there are urinary complaints.
Yes, sir.
Are they because of the
Compression effect.
compression?
Yes, sir.
So is there any posture in which these symptoms disappear?
No, sir.
These are questions of retroperitoneal sarcoma. And one more thing which is missing: all hypogastric, iliac fossa, all retroperitoneal sarcoma lower limb examination is mandatory.
Mandatory, yes, sir.
To that. Genitalia must be described.
Yes, sir.
What would you look for specifically in the scrotum analysis? With pressure, what will happen?
So scrotal bulge.
Bulge. So
And-
veins can get compressed. You can have varicocele.
Varicocele, yes, sir.
Examine in standing position as well to get a clear idea of how big the lump is. As Dr. Puneet was asking, from the picture, it is looking like very confined to just the suprapubic area and that.
Yes, sir. Yes.
Really look like.
Yes, sir.
I like extension would be better appreciated if it stands up.
Yes, sir.
Ask a couple of questions. How do you proceed? Puneet, something bad
Please.
How do you say now?
Presence in the pelvic area, why is it not a pelvic lump and why are you calling it a retroperitoneal
What
sarcoma?
are the pelvic lumps intraperitoneal?
So it can be intraperitoneal, retroperitoneal. We use if it's originating from the adnexa or if it's originating from any large bowel.
Which part is abdominal?
Abdominal, yeah.
Yeah.
Yes, sir.
Pelvis is out of it. No?
Yes, sir. Yes, sir.
Reflection, remember.
Yes, sir.
Pelvic lump would be there. How do you proceed now?
So with this size of the lump, we shall proceed. Initially we will do the ultrasonography of the whole abdomen.
To confirm, to support, to stay, to treat.
We'll confirm the diagnosis
No.
with the help of the investigations. So we'll first proceed with the USG to ascertain ultrasound.
We put out all these questions, so we'll all look silly once.
Yes, sir.
Maybe it's bladder, maybe it is not, so you know, all that's, which is an extension of clinical examination.
Yes, sir.
Yeah.
We shall proceed with the ultrasonography of the whole abdomen to ascertain, the intralesional, what is the consistency of that particular origin and organ of the origin, and then we'll proceed with the CCT of the whole abdomen and probably MRI as well.
Going back, I would say that we should have kept neuroendocrine tumors, schwannomas and neurofibroma as a first diagnosis, keeping retroperitoneal sarcoma lower down. Mostly in the midline, the retroperitoneal tumors, more common ones are these.
These are the common.
Sarcomas are more common on the flanks.
Yes, sir.
If we keep that thing in mind, then definitely this would have gone down and these other tumors, schwannoma and
Yes, sir.
so again, I would say that just don't keep on randomly saying that I would like to confirm the organ of origin. Here probably we would be ruling out the adjoining viscera.
Adjoining involvement of the adjoining viscera. Yes, sir. Yes, sir.
Also the bladder, ureter, kidneys.
All the retroperitoneal organs. Yes, sir. Yes, sir.
Turn out to be a retroperitoneal sarcoma. What are the things means you're going to see there on CT?
So if it's on CT scan, so if it's a retroperitoneal sarcoma, then depending, there are different histological types. So on CT also we can delineate that there can be, fat hyperdensities. We can have calcifications. We can have, peripheral bleed. We can hemorrhagic foci. We can appreciate, and then obviously we can delineate the organ of origin. We can delineate the size of the tumor. We can delineate any involvement of the adjacent structures on CCT. Yes, sir. Urination. Yes, sir. And yes, sir. Yes, sir. Definitely we will. Since it is having a compression effect, mass effect was there because of this particular tumor. So we have to comment on the kidney, the whole, genitourinary system, starting from the renal pelvis, the ureter and the bladder, because of the, clinical complaints of urinary obstruction.
More imaging, which can help you. You can make a diagnosis, like you said, when you mentioned about the fat.
Yes, sir. On CT scan, we can delineate two possible histological, retroperitoneal sarcoma types. One is the well-differentiated liposarcoma, and one because these are having fat microdeposits. So, and as the algorithm also clearly, illustrates that that depending upon the type, the type is role of guided core biopsy. So definitely there's a role of guided core biopsy, but preoperatively it is, controversial because of the seedling of the tumor if it's malignant, and also, so as per the literature, there are controversies. Seedling is the reason, and we don't, in these large tumors, we don't get we do get a lot of false negative. We don't get the definite specimen.
Is there any advantage of having a histology before you proceed, especially soft tissue sarcoma, the retroperitoneal sarcoma?
So it can only guide us in, whether we have to go for neoadjuvant radiotherapy or not.
Is that important?
No, sir, because we have to go for surgical resection.
Very specific. Why the histology is important component there for the sarcomas?
Because grading and TNM staging. Yes, sir.
Giving your head. And immunohistochemistry is extremely important.
Extremely important. Yes, sir.
There are 1% of all cancers are sarcoma and soft tissue, and
yes,
there are hundreds of types.
Yes, sir.
And there are tumors that respond very well to chemotherapy.
Yes,
there are those that don't respond.
Yes, sir.
There is also a role of upfront radiation in some of them. So be clear on that.
Yes.
You can't say no. So
that could be one reason of getting a preoperative biopsy in these cases.
Yes, sir.
There is a role. So in your case, what is the likely pathology?
So likely pathology, because as per the, in our case, it could be a well-differentiated liposarcoma.
Why well-differentiated?
So, because of we have well-differentiated cells based, on regular follow-up. Yes, sir. Liposarcoma. Yes, sir.
Any other? Sorry.
Suppose they turn out to be a round cell.
It's a round cell.
Round cell tumor.
Yes, sir.
So what is the differential diagnosis to the round cell tumor?
So round cell tumor is having a more aggressive course.
Then how you suppose it turn out to be a histology, turn out to be a round cell tumor. Now, what are the differential diagnosis?
So if it's I mean, we have to ascertain the organ from which it is originating, and then depending upon that, we can have, I mean, some malignant forms of other organs like leiomyosarcoma. We can have pleomorphic liposarcoma as well.
Hope that you must know about the differential diagnosis of a round cell tumor, and then you can do a IC in these patients to confirm exactly what is that tumor is. So what are the differential diagnosis of round cell tumor?
I mean, so in this age group, it's not very common, but we can have nephroblastomas and neuroblastomas as a differential. But if it is prevalent in pediatric population.
Fine, partly correct.
Yes.
There's more to it you can read about it. In this case, considering it's a retroperitoneal sarcoma, how do you proceed? You have 3 minutes to wind up.
Yes, sir. So we'll proceed with the laparotomy and the complete surgical excision of the tumor. So in this case, I mean, we planned cystoscopy and we planned DG stenting, but that was not possible because probably.
Your case.
Yeah. We will plan cystoscopy and.
These are 4 things that we routinely do. This CT angio to know the vessel, feeding vessels, and midline can be a dangerous place because they could have direct feeders.
Direct feeders.
And important to make sure of your vascularity, the surrounding structures, bladder, ureters, all need to be.
All the retroperitoneal organs. Yes.
And surgery is a standard of care. I agree with you, but in some of them, neoadjuvant comes in.
Yes, sir.
When it's too large and not likely to get an R0 resection. And R0 in retroperitoneum is very difficult because you don't have proper capsule, mostly adjoining, like you mentioned, ureter, bowel, sigmoid can be closed. So
yes, sir.
Need to be. I'm covering it up so that we can move on.
Yes, sir.
Right?
Yes, sir.
Any last word? I mean, if there's one thing that we asked in the exam, we answered well. What is GTNM classification?
According to the latest, I mean, AGCC classification, it has TNM staging, and then grade has also been added. The histological grade has been added to stage.
Node status.
So node status, as per its AGCC, it's just N0 and N1, whether it's, I mean, node is involved or the regional lymph node.
Stage 4.
So stage 4, if it's become M1 when it's T4, that is more than 15 centimeter, and it's grade 2 or 3 on, I mean, histology. That becomes T4. But in retroperitoneal sarcoma specifically, that is considered to be a stage 3B.
3B mostly.
Mostly, yes.
But N stage, 3 times it has changed. N1 used to be M1 once upon a time. Then they got down to N1 again.
Yes, sir.
Positive or negative?
Negative.
So what is the surgery? And you've done embolization to reduce the bleeding. What surgery is offered?
So in these cases, we will do the complete resection, or we can have en bloc resection if it's involving the adjacent structures.
En bloc, attempt is R0.
R0, yes, sir.
R1, nobody will kill you for that, but R2 is laparoscopic. Radiation.
Yes, sir.
Upfront radiation, any advantages?
So there was a trial, STARS 2021 trial, which included cohorts of 2 groups of patients. One was given radiotherapy upfront, preoperatively, neoadjuvant, and surgery was then followed by. And there were the other cohort in which only surgery was done. So there was no possible better outcomes.
The advantage was the tumor was standing up, so radiation was easier. Collateral damage.
Collateral damage was minimal.
So
yes, sir.
Found that, and post-radiation challenge they found was to find out the margins.
Margin, yes, sir.
Plastic reaction very difficult.
Yes, sir.
So presently, standard of care is surgery.
Surgery.
So all this retroperitoneal sarcoma has been discussed, but when you come across a lump which is extending below the level of pubic symphysis, it is good to define on imaging as well as on clinical examination whether the lump is lying between the level of ischial spine and below, or between ischial spine and the promontory of sacrum, or above that. Because why that is important is that will determine your approach to surgery. Because you kept your diagnosis as presacral teratoma and all, because lumps that are lying below the level of ischial spine, then you can access them from behind also.
Thank you.
We talked about the other situation. Here it's front.
Yes, sir.
So you'll approach it that way. And most of us approach the midline and then access from either side.
Yes, sir.
That you have freedom. And you go for the feeders first.
Feeders first.
Don't start pushing around. It's a challenge. It's a different surgery altogether.
Yes, sir.
Well, very well done. Thank you so much.
Thanks.
Give a big round of applause. I apologize for the next session for getting delayed, but naturally you had such wonderful teachers. They have to teach you everything today. You must have gathered a lot of information. Try to digest that. Therefore, in the next session, we'll break into two parts. We'll have three cases which are environment total, and then we'll have the talks. One that is by Dr. Tarun Mittal, and also after that we'll have the other two cases, and then we'll have the talk by Dr. Sanjay again. So thank you so much, Dr. Meet. Doctors, may I request the following chairpersons to kindly join us. Dr. Sanjay Jain, give a round of applause. He's been very patiently waiting. And the immediate past president of ASI and a very dear friend and excellent surgeon. Please come, sir. Come, Dr. Sanjay. Thank you. That's request for you. Dr. Ratna Chopra. Dr. Rahul Khanna is just went out to attend a call. I hope he's there and join us. And Dr. Rishikesh, please call him. He's there outside. They're thinking that can you call? Both of them are outside. And we'll start with the presentation. Meanwhile, they can all join in. Dr. Manohar Balach. Ram, Dr. Henley's bag was kept. It was here on the chair.
Good afternoon. Case presentation on the inguinal hernia. My patient, Mr. X, 79-year-old gentleman, residence of Sapra, a farmer by occupations. The chief complaint was swelling in the left side groin region since 8 months and pain in the left groin region since 2 months. The history of present illness, swelling in the left groin, 8 months noticed during the cuffing. Initially small in size, 2 into 2 centimeter, gradually progressive to present size approx 6 into 4 centimeter. Size increase on walking and the cuffing and disappear completely on lying down position spontaneously. History of present illness, patient the left groin region into 2 month, incidence onset, non-progressive and dull aching type, pain aggravate on the walking, cuffing and relief on lying down and medications. No associate fever, low backache and nausea and vomiting, and no history of trauma. History of on and off constipation since 3 months. No history of distension and abdomen, nausea and vomiting, tuberculosis and asthma, and the previous abdominal surgery and groin surgery. Past history, patient underwent the prostate surgery for 7-year-old, back for the BPH, and non-case of COPD in the since 5 years. Personal history, the chronic smoker, 40 stick rape for the 40 years, chronic alcoholic, and history of constipation on and off for 3 months, and non-vegetarian, normal bladder and bowel habit. Drug and allergy history, the patient taking medication on COPD since 5 years, and history of hypertension for 2 years, amlodipine 5 mg OD. The patient is taking medications for constipation on and off since 1 month. No history of allergy of any kind of food and any drugs, and non-significant family history. Summary, a 79-year-old gentleman, known case of COPD and hypertension, chronic smoker and chronic alcoholic, come with the complaint of swelling in the left side of groin region for 8 months, which has initially small in size, about 2 to 2 centimeter, and gradually progressive 4 to 6 centimeter size, and increase on walking, cuffing, and disappear on lying down. Patient also complain of pain in the left side groin region for 2 months, and since incidence onset, dull aching type, pain aggravate on the walking, cuffing, and relieving of the lying down, and the medications. Can continue.
Slide C.
although the case of hernia looks very simple, but sometimes it may be difficult even for at least for the MS examination.
Yes, sir.
So let us just revise those things. Will be easy for me.
The swelling in the left side groin regions 8 months.
The two things, swelling, and basically we are dealing with the case of the hernia. So in hernia, ideally it is the pain which comes first or the swelling which comes first?
Usually, sir, swelling is come first and also present with the pain, depend on the content of the hernial sac.
If the other way around, it is the pain which comes first and then the swelling. Because when the peritoneum is sensitive,
Yes,
when it starts getting stressed, only thing if the patient is intelligent enough, then he will be able to tell you. And that's why the smaller hernia people, they will just
complain of pain.
sitting on your head that, sir, I have got pain. In the second hernia, which has got pain only and no hernia, which is that hernia?
Femoral hernia?
No, it's sportsman hernia.
Sportman hernias. Yes, sir. Weakness of abdominal.
So no problem. Those patients' leverage intelligence may not be there. They sometimes ignore that pain and they can come up with pain, or rather they start feeling pain once they feel that it is more than they have got a swelling and now they should get treated. So then they perceive that there is a pain. Next, please.
History of present swelling in the left going 8 months. Notice during initially small in size and great. History of pain in the left growing regions 2 months. Insidious onset, non-progressive, dull aching type. Pain aggravate on the walking, coughing, and the relief by the lying down and the medications.
Fever, low back, nausea, vomiting, trauma. What we want to basically
Sir, we rule out the in the nausea and vomiting for the intestinal obstruction due to the inguinal swelling, which is contained as a enterocoel, and fever is associated with the strangulated hernia and any infections.
Here again, I would like to go with a little bit different view. See, here an elderly patient.
Yes.
We have a small swelling which subsides. So what we are dealing with, a direct or an indirect hernia?
No, direct hernia.
Direct hernia. Do direct hernias obstruct that often?
Not much as compared to.
These are just associated things, may not be that important. Be little bit, underplay on these findings. Trauma, what you want to say with trauma?
Trauma and maybe hematoma, which is cause for the weakness in the abdominal muscles, and also any nerve injury that's caused iliohypogastric. Open appendectomy and hysterectomy is.
But if you take classical gridiron incision, it is most of the time at least 2 centimeters away from the incision. So until unless you really perform the operation badly, I have seen one case where and post appendectomy direct.
In past practice, we are muscle cutting incision. That's why the important of that.
What history will you take to rule out strangulation, if at all you wanted to take? Is this the kind of history that you will take to rule out strangulation?
In a tender area on the swelling and with the toxic look of the patient because of.
It will be sudden onset of irreducibility associated
with the pain.
May or may not be associated with features of obstruction.
The no history of distension, abdominal nausea, vomiting, tuberculosis, asthma, previous abdominal surgery, and the groin surgery. We also cover. The patient underwent the prostate surgery for 7 years back for the benign prostate hypertrophy, and known case of COPD since 5 years.
Is he relieved of this prostatic symptom?
Yes, sir.
So right now, no prostatic.
No any prostate.
Side is the normal bladder model limits, and then you say constipated. Are these two not contradictory?
Yes, sir.
So, this is, both might be having constipation, but what does this recent onset of constipation signify in this case?
Maybe the swelling which is associated with the residual effect of constipations.
Constipation is 1 month, swelling is 8 months.
More progress and additions to no, non-specifically. it is,
Lots. I agree. And what about the smoking? How do you think this is smoking is?
Cause the smoking is the two type of the harm the patients. One is the from it cause the chronic cough, which lead to increase intra-abdominal pressures, and second is that they are also weakness of the muscle and mostly in the anterior abdominal muscle because of their deposit low collagen synthesis and elastic. That's why
Required collagen deficiency.
deficiency.
And cough.
Yes.
And probably this is the only thing which you need to take care of. The patient should start cessation of the smoking before you plan.
Cause of surgery.
After taking the history, do you think you will have some challenges in managing this case based on the history that he has?
Yes.
What challenges?
First, the patient also known case of COPD. That's a
Does he still have any problem related to COPD?
chronic cough persist, and that's why patients. Patient is also hypertensive.
You will manage on medication. Any challenge in, if you, are you thinking in terms of surgical management in this case based on the history at this point of time?
We have plan for the aggravating factor, which is caused the hernia. First, we manage the aggravating factor, just like smoking, and stop the smoking. And
Stop. For how much time must the patient stop smoking before surgery?
1 month, at least 3 to 6 week.
2 months. Still a smoker, he still has COPD, and he is still taking medication for constipation. So these are 3 active challenges that you have. Urinary problems have been taken care of.
General physical examination. After taking proper informed consent, patient was examined in the while supine and adequate exposure and privacy maintained. Examine the supine and standing positions. The conscious, cooperative, and oriented to the time, place, and the person. The average built and well nourished. BMI 20.2 and current Sky performance scale is 90 and afebrile. Pulse 96 mean regular, normal volume, normal characters. BP 144 by 84 mmHg. Measure sitting position on the right arm. Respiration rate is the 16 minute per minute, and abdominothoracic, and clubbing is the present and no paler icterus, cyanosis, edema, and generalized lymphadenosis present. This is the examination of inguinal scrotum. Patient was exposed from the umbilicus to the mid-thigh and examined the both standing and the lying down positions. In the inspections, the right inguinal scrotal lesion is the normal range, and left side in the swelling, the approx 6 to 4 centimeters in the size, present above and medial to the pubic tubercle, and spherical in the shape, and extend from above and the medial to the pubic tubercle, a mid-inguinal point, and not reach up to the root of the scrotum, and overlying skin is normal, and impulse on cuffing is the present. Reduce on lying down position spontaneously, and penis is normal in positions. And palpatory finding, all inspectory finding are the confirmed by the palpations. Overlying skin temperature was normal. Swelling is the soft, non-tender, and 7 to 5 centimeter size and present above the medial to the pubic tubercle, extending from the above and medial to the mid-inguinal point, and not reach up to the root of the scrotum, duffy in consistency, spherical in the shape, smooth surface, well-defined margin, and also right side of the inguinal region is the normal. Deep ring occlusion test was negative, and on Siemens impulse cuff on pulp of middle finger and gate above the swelling is not present. Examination of external genitalia. Scrotum skin normal, And testes, both testes are normal. Spermid cord normal on both sides, and pen is normal. Urethra normal, no stricture, and inguinal lymph node are not enlarged in the both side. Percussion dull overing the swelling. Auscultation, nothing's audible. Systemic examinations. Per abdomen, normal contour and all quadrate move equally with the respirations. Suprapubic small approx 1 into 0.5 centimeter old scar mark present. Tone of abdominal mark muscles are good, so soft and no palpable mass. Normal bowel here. Digital rectal examination is the normal, and the respiratory CNS and CVS system also is the normal. The summary: 79-year-old gentleman, known case of COPD and hypertensive, chronic smoker, chronic alcoholic, come with the complaint of swelling in the left side of the groin region for 8 months, which was initially small in size, about 2 into 2 centimeter, and gradually progressive, 6 into 4 centimeter. Size increase on walking, coughing, and disappear on lying down. Patient also complain of pain in left side groin region since 2 months, which is incidence in the onset, dull aching type, and pain aggravating on the walking, coughing, and relief on the lying down and on medications. On examination, 7 to 4 centimeter non-tender, duffy, globular reducible swelling present in the left inguinoscrotal region with smooth surface, well-defined margin, impulse on coughing present. Deep ring occlusion test was negative and dull not present over the swelling. So on the basis of I taking history and pathologically and examination, patient is the diagnosis of left direct reducible inguinal hernia containing omentum and uncomplicated present on the left side. NYH is classifications type 3rd A.
Start from the examination. First. The first thing is this informed consent. What do you mean by informed consent? Do you really require informed consent for just make an examination?
In the every examinations, patient in respect of the privacy and what going with the patient, and it is important for the doctor-patient relationships to establish for.
Consent is required, but is informed consent required? You are not doing any procedure. You are not operating right now. You are simply examining. So it's a verbal consent, which most of the time you say the proper consent, but the word, see here what we add the adjectives, and these adjectives may not be appropriate at certain places. If you are operating, definitely an informed consent is required. Here,
verbally consent.
verbal consent is good enough to make an examination for this patient. Then you are taking this performance status. Why? What's the purpose of getting a performance status in a case of hernia?
The overall whole idea about the physical and well-built and a normal activity of the patient, which is we planning for the patient for any emergency.
You not go for assessing the performance status in such patient unless you are going to subject these patients for chemotherapy. So again, this is an unnecessary addition in my view. Next. Now you say 6 by 4 centimeter. Okay. Then you say next. Next.
7 into
7 by 5 centimeter, and then you say spherical.
Spherical, sir, because of in the inspection we are my finding is the spherical because
that means you could understand that it is somewhat elongated. So why not oval? Why spherical?
Simple maths, no? Giving two different dimensions, it can't be globular or spherical.
Yes.
Most of the times these swelling, they do not form a complete sphere. They can be hemispherical. So, see, in a hernia, do you think the examiner has got so many things to ask you? But yes, your preciseness does matter. So it will be a hemispherical or an oval swelling. Of course, that oval kind of thing goes
Depthness.
against your own diagnosis. But I have seen the cases where I have operated even a complete hernia on it. The patient in India, they come too late also. So no problem in that. Well, next, it's a third thing which I have got objection that doing fee. I don't think that you will have the sufficient volume to make a doing fee. And third thing is the getting above the swelling. Getting above the swelling is one test which you have to only perform when you have a scrotal or
Inguinal scrotal.
your swelling is hardly reaching to the base of the scrotum. There, this test, I think it should not be narrated in your examination point. So, they were the two things which I wanted to pinpoint, which you can correct. Otherwise, it was a nice history, a nice examination, I do not say anything. Third thing is if we are coming to the tests, so definitely the deep ring occlusion test negative means what?
So on the cup impulse, when we obliterate the deep ring, on the same side, sir, we are first marking the anatomically marking and the ilioinguinal ligament and midpoint of the ilioinguinal ligament and above just the deep ring situated and
How much
just above 1.2
centimeters?
1.2 centimeters.
Yes, 1.25. So you can say half an inch above the this midinguinal point is the deep ring. So you have pressed it. Now what you will do?
Then patient ask patient for cuffing if the bulging and expansile cuff present on the deep ring.
Faster. Deep ring occlusion test is what you're saying.
Yes, sir.
So wind up quickly so that we can move.
So
Simple, straightforward question.
So we
obliterated the deep ring.
Yes, sir. And we've asked for the cuffing if the pulsation failed on deep ring.
Pulse, no? You won't feel any pulse. Deep ring occlusion is a different thing.
Yes.
What do you observe now?
Expansile cuff. If you're not coming, then we remove the deep ring occlusions. Then we
See, for such occlusion test, first you have to ask the patient to lie down, reduce the swelling.
first all hernia first.
You're not answering correctly. You better listen to what is to be spoken. You're wasting time.
Ask the patient to stand up, keep the pressure, and then ask to come. First, and also to put a mask or turn the head to the opposite side. All these things are important. And then you observe whether the swelling is appearing or not.
Now at the point there, if you ask the patient to stand up, sometimes your breath would go loose. The whole purpose is to find out whether the hernia is coming through the deep ring or not through the deep ring. You occlude the deep ring in a patient where hernia can be, you can express it in lying position. You don't need to make the patient stand up. He's talking about a situation where it doesn't become apparent on cupping. You getting my point where the patient has to stand. So both things you should know. Usually the kind of case, I don't know what case it was, so I wanted to cut short on the time. The deep ring occlusion, once you've done, ask the patient to cough. It doesn't appear, then you release it, ask the patient to cough. If it appears, then you suspect it
indirect
coming through the deep ring. It would mean it's an indirect.
Yes.
Is that okay?
Yes.
And the other tests are not useful, they're not relevant and not reliable. Right. So your diagnosis here?
This purpose is swelling. Go to the next slide.
How do you purpose a hernia? It is given in your book, that's the problem. So I must correct you. You can only purpose a swelling which is fixed. You can't purpose a swelling which is moving. And auscultation, nothing audible.
How did you check for the strength of the muscles of abdomen?
No, 1 minute, madam. You wanted me to have and deal with these two lines so that it doesn't go into confusion. So they are not necessary. You're trying to do it as per the book, which is not a mistake, but then you should be prepared. Where do you auscultate? If the hernia has disappeared, where will you auscultate? All right, what's your diagnosis? So that we save on time.
This is a direct reducible inguinal.
That's why Dr. Sanjay was trying to tell you to stand up in a direct hernia. It may not show up even on cupping. So then you need to make the patient stand up. But if it shows up without cupping, you can do it even in the supine position. So you should be prepared to deal with both. Now, direct, yeah, read it now.
Direct reducible inguinal hernia containing omentum, uncomplicated, present in the left side.
Neha's classification type 3, you written type 3A.
No, it's just size type B.
Here, from this point.
B,
The tone of the muscle that Dr. Ratna was asking, how do you check for it?
A leg rising test also.
You can speak from it.
Leg rising test, which any bulging.
What's the more leg raising or on inspection when your patient standing malgaining bulges?
Bulging.
And rarely is not done these days. You can even do a DRE to see the tone of the sphincter there. But these are all outdated things. They don't really come handy. How do you manage it?
So patient is the history of chronic cough because your patient is known case of COPD, and also patient in the chronic constipation, and we're also taking the medication for that. So we are planning defer for surgery and we have plan for stop the smoking. And
what is the surgery you're offering?
Just right in this scenario, patient first we stop by smoking and
You mentioned that. What surgery are you offering?
Just is the hernioplasty, the Latin bug.
What is hernioplasty?
With repairing of hernial defect with the mesh, proline mesh.
Using a mesh for using a mesh to make it hernioplasty, right?
Yes.
Is that what you're saying? You say that, people are asking you. Then this can be opened as well as, why are you getting confused? You saw laparoscopic yesterday.
Yes,
showed the 10 steps. Today you'll see the open one also. So it's okay. Like in stem tangential mesh hernioplasty is one option, but you can also do laparoscopically. So hernioplasty is okay, don't worry. It can be done both ways. I think he
needs to correct his definition of hernioplasty because repair of the posterior wall of the inguinal canal is hernioplasty.
Yes.
Reinforcement of the posterior wall of the inguinal canal is hernioplasty, which may be with mesh or with others.
Okay, so here, all of them require herniatomy if the sac is still protruding, and raphe when you repair the tissue, plasty when you put a mesh. And both are for posterior wall. So it should be clear.
Yes. Would you like to investigate this patient? What investigation you will require?
Although the hernia is the clinical diagnosis, but we also the coma.
In this patient, see now the why is direct question. Rapid fire. First thing, do you require anything to confirm your diagnosis?
Yes, sir.
No.
No, for any occult. Yes, sir.
Occult what?
Occult hernia may be present in bilateral.
Your patient has occult hernia? Doesn't have it. Yes or no?
No, no.
So this is done, clinical. Any investigations that are relevant? How old is your patient? 70. So would you need some investigations?
So the ultrasonography.
For?
For the patient also previous history of prostate surgery.
So what would you now like to see? Save on time, sir. We are wasting a lot of time on hernia because we have 3 cases of hernia. We have a talk also. So you should be, hernia should be a straightforward answer. So why are you taking so long? Ultrasound to look for what? The same thing, prostate, outlet obstruction there.
Bladder bowel.
Bladder, residual volume, back pressure changes, other things. No, urinary system is one. Contralateral hernia, you can also see with ultrasound, which you were trying to talk about, not necessarily all the time. Okay? And we have talked about the treatment. I think we'll have 2 more hernias. We can take the other questions. So thank you very much. Give a round of applause. I think we will save time because one first case took a long time. So I'll invite Dr. Tarun Mittal for a talk on bariatric surgery, past, present, and future. He's got a lecture at the other conference, so I think we'll do the other two presentations later.
Can someone upload the?
Can you load the presentation?
Yeah, I have given it.
I must be able to do that. I interviewed Dr. Tarun Mittal yesterday. He's a very well-known bariatric surgeon, does laparoscopic hernia, as you saw the other day, decent, very nicely all steps are elaborated. And then the senior consultant, minimal access surgery and bariatric surgery at Sarcoma Hospital. Over to you, Doctor.
Thank you, sir. At the onset, I would like to thank Dr. Chintamani sir for giving me this talk. I bring greetings from Sir Gangaram Hospital. Can one see my slide? So this is was the newspaper article just 2 days back, in which it said that 8 crore Indians, including 1 crore youth, are obese, which was there in the Lancet report. So it's alarmingly rising obesity in India. We have both sets of patients, malnourished also and overnourished also. So this, we go back to history, initially the weight loss was there right from 19th century, 1800 centuries also. And one of the, just to tell you that people used to just do a dental wiring so that the person is not able to eat anything and just take a sip of water. Over a period of time, history has changed. And we then had a lot of procedures where we reduce the size of the stomach, do some intestinal malabsorption, and we have changed from jejunal bypasses to RYGB, then vertical banded gastroplasty, and then over a period of time, a lot of procedures have come in, and all the procedure has its role based on the patient condition. So why surgery? Always diet and exercise are not effective long term for patients who are very obese, like to the tune of more than 35 BMI. Then one might be able to lose weight by diet and exercise, but you might not be able to maintain by diet and exercise. So it's a accepted and effective approach, surgery. With surgery, you also improve your comorbidities like diabetes, hypertension, joint pain, sleep apnea, back pain, varicose vein. All those things get better. Your quality of life increases. Overall cost to the healthcare decreases, and the risk of complications is less than 1%. So it is acceptable complication rate, which is there when you are like you're walking also, you can have an accident. If you're driving also, you can have an accident. So just like that. So the ideal procedure should be simple, reversible, should have a good sustained excess weight loss, should have low complication rate, low mortality, and minimum nutritional issues. So IFSO guideline, IFSO is a body which regulates the bariatric surgeons. So these are the 4 commonly performed procedures which are there. Gastric banding is not being performed in India, but it is being performed in Australia and some other countries. Adjustable gastric banding, sleeve, Roux-en-Y gastric bypass, biliopancreatic diversion with duodenal switch, which is also generally not been performed in India because we are mainly vegetarian veg eaters. So it's a very malabsorptive procedure. You have to eat a lot of protein for that. So in other 2 procedures which have now been accepted is a mini gastric bypass or one anastomotic gastric bypass, and a SAD is a single anastomosis duodenal, which I will be telling. And other than that, IFSO recommends ballooning and endoscopic sleeve also as a part of weight loss procedures. So these are the things which have to be told. So for weight loss surgery, bariatric surgeons, body mass, only weight is not important because weight has to be calculated through height. If person is taller, his weight will change. So BMI is a measure which we try to compare the results. So you should know that weight in kg by height in meter square. So the other thing which can be asked in your exam is indications of bariatric surgery. That has also changed. So you should know the correct one. Now what is recommended? Initially it used to be 40 BMI. Now the bariatric and metabolic surgery is recommended for BMI more than 35, regardless of comorbidities. So more than 35, one can undergo bariatric surgery. Metabolic bariatric surgery should be considered in patients with 30 to 35 BMI with comorbidities. The BMI threshold for the Asian population has been reduced to suggest clinical obesity for 25 vis-a-vis in Western, which is 30, because we have more of android habitus, more of abdominal obesity, which has its higher complications and higher diseases are there. And patients, Indian population or Asian population are offered a metabolic surgery. Metabolic surgeries when you're doing mainly for control of comorbidities like diabetes, cholesterol, and other things, in which you can do it if it is not getting optimally controlled with medical management, then you can do it at 27.5 also. So you should know this term of metabolic surgery also. So this IFSO guidelines were for world. Then the Aussie Obesity Surgery Society came up with their guidelines, in which they gave the options of BMI more than 30 with comorbidities you can operate. Other thing which they gave was that Indian patients with waist circumference of more than 80 centimeters in males and more than 90 centimeters in females, you can do a bariatric surgery in them also. So you should know these things. You can be asked and you can have a question also. You should also know the contraindications. In this, it was there that 18 to 70, 65 to 70 you have to operate, but nowadays extreme of ages also you can operate. If you have a severe psychiatric illness like a schizophrenia, which is not controlled, you cannot operate, or unstable angina, heart failure, end-stage lung disease, coagulopathy. In those, you cannot do operate these patients, and they are the contraindications of surgery. So there are 3 types of surgeries which are classified as mainly restrictive surgery, like a sleeve gastrectomy or a gastric banding. Restrictive and malabsorptive, which is a Roux-en-Y gastric bypass, which is the gold standard, and then mainly malabsorptive, like a mini gastric bypass or a biliopancreatic duodenal switch. So gastric bypass was invented by Edward Merson, who is also called the father of bariatric surgery. That question also can be asked in your quiz or somewhere it can be asked. So it was a loop gastrojejunostomy with a partial gastrectomy, in which remnant stomach was kept inside only. So there was some lot of biliary reflux issues were there. Then the first laparoscopic Roux-en-Y gastric bypass was performed by Dr. Vitrov et al. And this also can be asked by you, by the examiners. So you should know this. And this was done in 1994. So gastric bypass is the gold standard. It has advantages. Weight loss is quicker. Higher comorbidity resolution is there. But it has its own disadvantages of internal herniation, which is the Achilles heel of Roux-en-Y gastric bypass, because you are doing 2 anastomosis there. Then you can have higher morbidity mortality vis-a-vis sleeve gastrectomy. There are some complications like anastomotic leak can occur, stoma anastomosis can occur, and deficiencies can occur. So this is a small video of a laparoscopic Roux-en-Y gastric bypass. So this is on the Thomson retractor, which we are using. So in this, this patient has undergone previously a sleeve gastrectomy, and we are doing a revisional laparoscopic Roux-en-Y gastric bypass. Small pouch is made, and then we do the gastrojejunostomy has to be made, a pouch has to be made, and a band has to be placed. So here, this is the small bowel which we are measuring. And after this, a gastrojejunostomy is made, approximately 2.5 centimeter blue staplers are used. And then in 2 layers, we close this gastrojejunostomy. And after this, you have to do a leak test. This is, as it's a revisional surgery, we have to, we are banding this so that the pouch does not dilate when person eats. This was, concept was given by Dr. Phoebe. And then the third part of the technique is a jejunostomy. We do it by a triple stapler technique, in which we fire 1 stapler, then we fire 1 more stapler horizontally, and then we close this stoma otomy with the stapler. And as we know, Achilles heel is of the Roux-en-Y gastric bypass is the internal herniation. So all the potential site, mainly the mesenteric and the Peterson, have to be closed with the help of non-absorbable suture. So this is the concept which was given by Dr. Phoebe et al. And he used to do it open, but now everything is done laparoscopically. So then this concept of gastric banding has come up, in which we place a small ring around the upper part of the stomach. So there is an upper stomach and lower stomach. You have an early satiety, but generally it's the revisional rate is very high. Its complications are high. The patient has slippage, erosion, and patient weight loss is also not very less. compared to the other procedures. And in this patients want to eat something and is not able to eat. So that's why in Indian population, practically it is not being used as a primary surgery, except that you do a band, celastic band is placed, which is non-adjustable. This is an adjustable band which is placed, in which over a period of time you can inflate this band with the saline on in the C-arm guidance. So this is practically not there. The only advantage of this is it is the least mortality is there in this, because you are not cutting anything. There is no leak, though there is no anastomosis. So the risk of mortality is less. Otherwise, this is practically not being done. Then this is now the most commonly performed procedure is the sleeve gastrectomy. It is a modification of a Megenstern-Meal operation, first described by D. Johnston in 1996. Initially, it was a part of a two-stage procedure for biliopancreatic duodenal switch, and then you could first do a sleeve, reduce the weight from maybe patient is 70 BMI, 250, 300 kg. There, the risk of complications is higher. So you reduce there, and then you do a duodenal switch in this, so that the complication rate is less. But nowadays, this is the most commonly performed procedure worldwide. 60% to 70% of the procedure is sleeve gastrectomy, and it is very simple to perform. No anastomosis is there, and the risk of malnourishment is less. So it is becoming no internal herniation will happen, and you are not disturbing the anatomy of the intestine. So this is becoming the most commonly performed procedure. And so this is an Nathanson retractor. And after placing of the Nathanson retractor, you have to enter the lesser sac. Here in this, you enter the lesser sac from the greater curvature, be close to the stomach as close as possible. Then with the help of the energy source, high-end energy source, in this we are using harmonic. It can be ligashore. And then you slowly go to the area, slowly divide from the greater curvature. Then you reach the area of the short gastric, and then you can clip these vessels. And then after this, you have to reach the left crura. Whole of the left crura has to be identified. And then after that identification, you reach the area of the antrum and mobilize right till the area of the pylorus. So here you would see we are visualizing the left crura, and whole of the left crura is well visible. If it is not visible, then there is a hiatus hernia here. Then you will have to repair the hiatus hernia simultaneously. Otherwise, the Achilles heel of sleeve is gastroesophageal reflux disease. That will complications can occur. So hiatus has to be repaired if it is there with sleeve gastrectomy. Over a 36 to 38 French bougie, you have to fire staplers. There is a variable thickness of stapler from the area of the antrum to the area of the fundus. So various length of stapler, height staplers are used. From the area, first is a green, then now we are using a gold, and then a blue. In this, you would see we are using a staple line reinforcement that can also be used to prevent the incidence of leakage and bleeding. But the use of sleeve line reinforcement increases the cost, so nowadays we have reduced that use. So then came the concept of mini gastric bypass, in which there is only a single anastomosis. There is no duodenectomy as it is in Roux-en-Y, and you make a longer pouch vis-a-vis a shorter pouch in Roux-en-Y gastric bypass. So it was technically easier, and earlier shorter operating time was there, and it is also becoming very popular. But the disadvantage of this procedure is because bile mixing with the stomach, so you can have biliary reflux gastritis, marginal ulcers because of bile mixing, and long term, because many of these patients have GRD, you can have higher incidence of bile mixing at the GE junction, which can be dangerous and can have Barrett's and adenocarcinoma over that area. So that has to be managed. So young patient, you should not do a mini gastric bypass. So there is no fear of internal herniation, good weight loss, resolution of comorbidity is there. The disadvantages that I have told you, and also because it is a malabsorptive procedure, they have to be followed and have a high protein diet. Just a small video. So in this, you go from the lesser curvature, not from the greater curvature side. And you have to divide. The first stapler is at the area of the antrum. And then as you do it in sleeve, you have to fire staplers, but not very tight. They have to be very lax, so that because in this more is a malabsorptive component, not the restrictive component. So here we are going from the lesser curvature side, and then staplers are fired. And in the end, similar gastrojejunostomy is done as it was done for the Roux-en-Y, except that this is a longer size gastrojejunostomy to the tune of 4.5 centimeter, vis-a-vis in sleeve Roux-en-Y, which we do 2.5 centimeter. Biliopancreatic diversion is just to be mentioned. It is not being done nowadays. In BPD, you used to make a partial gastrectomy and then do a ileal anastomosis, and the distal anastomosis was 50 to 100 centimeter from the IC junction. Not the length is measured from the IC, not from the DJ. Now the duodenal switch is done, in which you go distal to the pylorus and 2 centimeter distal to pylorus. You do the same anastomosis, and a sleeve is made vis-a-vis a partial gastrectomy which was being done. So this is more commonly performed. So they can have severe malabsorption, but will have the highest weight loss. So this is not being practiced in India. This is the other procedure which is done more for the revisional surgeries of, like, you have a sleeve which has weight regain, then you do a loop duodeno-ileostomy after doing a sleeve. So this is also becoming very popular because it's a single anastomosis is there, but it is generally done for the revisional surgeries. So just revisional surgery, you can do for weight regain re-sleeve, or you can do a Roux-en-Y gastric bypass or a SADIS operation. I'll just skip this. This is not to be. The rest is the recent advances in future. So now it's robotic surgery has come up in a big way, and we have been doing it in Gangaram and in all other hospitals in India. The robot is being used for bariatric surgery, more for the anastomosis like a Roux-en-Y or a mini gastric, because the suturing is much easier to do. You have a 3D vision, so you sit in a console and it's being operated. So there's a comfort of the surgeon and better visualization is there with this, but it increases the cost of the procedure. The other things which have come up is endoluminal surgeries. Lot of endoluminal surgeries are there. The most commonly performed surgery which is there is a procedure is a balloon. Intragastric balloons are placed endoscopically initially, and then you have to you can calibrate those balloons from start from 300 to 700. You can over the CM guidance, so it create fullness. But it is for patients who are not very obese, like less than 30 BMI, 30 to 25, or high risk patients who cannot undergo surgery. In those, you can place these balloons. Nowadays, good other balloons have come up in which you can just swallow a pill without endoscopy. They get inflated there, and they are being used. And aileron is the balloon which is there, and it can help the weight loss, but it is not so effective as it is the bariatric surgery. The other thing which have come up is the medical management of bariatric or weight loss, in which lot of injections and medicines are coming up, and in which one of them is a semaglutide and liraglutide, and which helps in patients who are not very obese, and this can be used as an adjuvant for treatment of these manage these obesity. So this is that aileron which is there and which is used for without endoscopy you can do. Now artificial intelligence is also coming up in bariatric. You can diagnose many of these patients by flowchart, what problems they are having. You can do a risk assessment. Intraoperatively also it is coming up in big way. So all these are advances which will come up over a period of time. Thank you. Ultimately, it's team which helps all these bariatric surgery. You should have a good surgeon, anesthetist, the endocrinologist, the chest medicine. Everyone becomes a part of the team, and if every team member is important and helps in bariatric surgery. Thank you.
Excellent talk. Give a round of applause. Very clear, very crisp, to the point. Any questions? Any questions from anyone? This is the question in the exam almost always, and he's addressed it like that only. So is there any question you can ask now? So most things were very, very clear.
Thank you, sir. Thank you, sir.
And I think with this, you can answer most questions in bariatric surgery. We have taken these talks focusing very much on the kind of examination questions that you're getting. And we move on to the case presentation. Rishabh, Rajat Saini from LHMC is going to make the next presentation. Rajat, have you loaded your presentation? Please. Most things over here were covered in the previous case. We will be very focused and short. Yes. So start. Harsh, can you check if the online people are able to clearly see and hear, because they've written some messages, and if you can bring their questions out, we'll be happy to take them for the previous session also. Start, Rajan.
Sir, it's not working, sir. Good afternoon, everyone. I'm presenting a case on inguinal hernia. My patient was 50-year-old gentleman, resident of Kolbag, Delhi. He's a telepath profession. Presenting a plain of patient was a patient presented to surgery OPD with complaints of swelling in the right groin region since 4 months. History of present illness: patient was apparently well 4 months back when he developed swelling in the right groin region. Swelling appeared spontaneously, which was insidious in onset, gradually progressive in size. Initially, the swelling was small in size, limited to the groin region, which gradually progressed to the size of 4 into 3 centimeter, reaching up to the scrotum, root of the scrotum. Swelling becomes prominent on standing and walking and disappears on its own when the patient lies down. There is no history of swelling in the opposite sides. There is no history of abdominal surgeries like open appendicectomy, no history of trauma, no history of chronic cough, no history of breathlessness, no history of straining during micturition. There is no history of hesitancy or poor urinary stream. There is no history of constipation or straining. There is no history of pain over the swelling, no history of fever, no history of irreducibility, no history of abdominal distension, vomiting, and non-passage of stool and flatters. In associated history, there is no history associated of hypertension, type 2 diabetes mellitus, tuberculosis, and asthma. In personal history, patient is a smoker since 30 years with 15 pack per year. Patient is having normal appetite with normal bowel and bladder habits. There is no alteration in sleep and wake cycle. In family history, no significant family history. The summary on the basis of the histories, my patient, 50-year-old gentleman, a non-smoker, presented with a spontaneous paleness swelling in the right groin region since 4 months, which increased to the present size of 4 into 3 centimeter. It becomes prominent on exertion and walking and reduces on lying down. No history of associated pain, irreducibility, change in the bladder and bowel habits, chronic cough, and heavy weightlifting. In general physical examination, patient was examined in a well-lit room. After due consent in both standing and supine position, patient is conscious, alert, and cooperative. Karnofsky's performance score of the patient was 90. Build was average with BMI of 24.97. Vitals of the patient was pulse rate was 76 beats per minute with regular pulse with right radial artery. Blood pressure was 132/82 mm of Hg in right arm in supine position. Temperature was 98.3 degree Fahrenheit. Respiratory rate was 16 beats per minute. And saturation was 90% in the room air. There is no pallor, icterus, clubbing, cyanosis, and generalized lymphadenopathy and edema. This was the image of the patient. In the inguinal scrotal region examination, inspected in the standing position, right side inguinal scrotal region, swelling in the right inguinal region of 4 into 3 centimeter, extending till the root of the scrotum, which was pyriform in shape with smooth surface and regular margins. There was expansal cuff impulse present, no overlying skin changes like scar, engorged veins, and pigmentation. There was no visible peristalsis. Penis was central in position. Testes can be seen separately from the swelling. Left inguinal scrotal region was normal. On palpation, right side inguinal scrotal region on palpation, localized temperature not raised, there were no tenderness. Expansal cuff impulse was present. Swelling was pyriform in shape of size 4 into 3 centimeter, present above and medial to the pubic tubercle with smooth surface and rounded margins with consistency of Duffy. And the testes felt separately. Deep occlusion test was positive. Swelling reduces on its own on lying down. Bilateral testes and cord structures are normal. There was no palpable or cuff impulse on the other sides. In digital rectal examination, there was no sinus, no fistula and growth, no prostatomegaly. And anal tone was normal. There was no lump. Normal fecal staining was present. On percussion, dull note on percussion on the swelling. On auscultation, no bowel sounds heard during auscultation. In systemic examination, no palpable abdominal lung was present. In respiratory examination, bilateral air entry was present with no added sounds. In CVS examination, S1, S2 was present with no murmur heard. Summary. On the basis of history and examination, my patient, 50-year-old gentleman, a non-smoker, presented with a spontaneous painless swelling in the right groin region since 4 months, which increased to a present size of 4 into 3 centimeter. It becomes prominent on exertion and walking and reduces on lying down. No history of associated pain, irreducibility, and changes in the bladder and bowel habits, chronic cough, and heavy weightlifting. On examination, right-sided inguinal scrotal swelling reaching up to the root of the scrotum of size 4 into 3 centimeter. It has smooth surface, round margins with a positive expansile cuff impulse, Duffy consistency with no visible peristalsis seen over the swelling. Swelling is reducible easily and deep occlusion test is positive.
Go to the picture. So
Sir.
some people are asking, somebody was asking a question on the tone of the abdominal.
Yes, sir.
So you can actually see the suprainguinal bulges. These are the magnetary bulges that they talk of. So that's, if you will observe when standing patients, suprainguinal, right? You can see that bulge.
Yes.
And you cannot auscultate this patient in a standing position, and you certainly cannot percuss, and it's no need to do it. So both these tests are actually not required in a hernia.
Yes.
And you don't need to mention the performance status in a hernia patient. They generally performance status is for sick patients or cancer patients usually. But you can, since you mentioned, nobody's going to harm you with this. And BMI can be just mentioned, don't have to explain anything. The diagnosis is very obvious and very clear. So how did you arrive at your diagnosis?
Sir, firstly, I said that there were side of the swelling in the right side with the inguinal scrotal swelling, inguinal, because it was present in inguinal scrotal region with the, on the deep occlusion test, the test was positive. It means swelling was indirect. It was indirect hernia because deep ring was positive. In indirect hernia, deep ring. Yes, sir.
One question.
You could have just again, he asked you how did you reach to the diagnosis, you could have pointed out points in history also, which you have missed or gone straight to.
You're trying to highlight that since yesterday day. Always answer by saying points in history and points in examination. Don't make it complicated. Any points in history, swelling that appears on cupping, disappears on lying down, is reducible. The patient will give you that history. And any history of irreducibility would have helped you, which you asked also. So that history would be ready. And on examination, of course, there is no doubt if you have cup and pulse. And mostly the cup and pulse is extensile, so you don't need to highlight. But don't waste time on, and you mentioned that video to the pubic tubercle, getting down into the scrotum. How far is it going down into the scrotum?
Sir, to the root of the scrotum.
So it's
up to the root, not base,
not
up to the
base,
root.
so
Yes,
up
sir.
to the root.
Yes, sir.
Once you mention that the patient is a smoker, you must also make it a point to mention if he's still smoking or not.
For the sake of treatment, it's important. And it's not duffy, it is doughy. Doughy consistency. Dough you have, no, when you make a cake or something.
Also, when you talk about pain in the swelling, you must also ask if the pain is interfering with his daily activities or not.
There was
again ask that the pain is dragging pain or it is some kind of a colicky pain, because it could be partial obstruction happening often. So you need to, these are some additional points. Okay, how did you see?
Sir, on the basis of history and examination.
So your diagnosis, can you show us? And the next slide will be diagnosis.
Diagnosis, my diagnosis.
Anything incomplete because it's up to the root only, right?
Yes, sir.
And right side is no problem, reducible is no problem. So usually they describe in terms of right sided indirect inguinal hernia with complete, with no complications. That's what you're saying?
With content as an omentum.
And likely content,
likely content.
Momentum. Why did you say that? Is it on auscultation?
Sir, on percussion and on.
That's why these tests are useless, no?
Yes.
Auscultation or percussion won't be able to let you know. How do
On
you ascertain
palpation
this?
also, sir. On palpation also.
So how do you ascertain?
Sir, on palpation.
Palpation is doing field or whatever field you're saying.
Yes, sir.
But how do you ascertain on whether it's a omentocele or an enterocele or anything? It's a very old tired question, so I'm not repeating it. Even I'm feeling a little dragging in that case, but you didn't answer that.
Sorry, in omentocele, the initial part of the swelling reduces on its own easily, and the second easily, and the second part is difficult to reduce.
And why does it take? Why is it the opposite in enterocele?
So because in enterocele the content is bowel in which we have gas and fluids initially, so it is difficult to push.
Very good. What is gets decompressed? Secondly, the mesentery can drag it. Huh?
Yes.
How do you proceed?
Sir, as my Diagnosis purely on the clinical basis.
It is always a clinical diagnosis. You don't bother us. You don't get bothered also. Yes.
So, sir, we will go for some blood investigation.
You'll do routine, if you discussed in the previous day. Anything
Yes,
specific?
Sir, if there is, we can go for ultrasound whole abdomen if there is any ultrasound in any mass in the abdomen or not, just
Yes.
to rule out.
Good. And contralateral again,
And contralateral.
which you have missed and avoid.
Yes.
So this is more of a run-of-the-mill investigation.
Yes.
You would be directly talking about surgery here or anything else?
Sir, we will advise the patient to stop smoking for like 1 to 2 months. After 1
What
to
is
2
the
months,
evidence? How much is optimal?
sir, in months, sir, 2 months, more than.
It's 3 weeks actually, and they say even if you do up to 1 week, there's an advantage. The American College guidelines. But otherwise, some say 2 months. Whenever you stop, it is good. So you can't postpone it forever.
Yes, sir.
Right? You can't just say 2 months. And anyway, they don't get a date easily. So that is not one reason. But stopping smoking. Sometimes they stop smoking, but they start chewing tobacco. Will that be okay?
Sir, for us, it's good, but for patient, it's not good, I think.
How is it for you? Good? You
Well,
studying tobacco or what?
No, sir, like we won't have any complication during the intra-op and post-op and.
Tobacco abuse is responsible. It's not just smoking. How does tobacco influence the hernia?
Sir, there is a change in the collagen fiber which makes the abdominal muscles weak.
That is nicotine doing it. No. So nicotine either way is dangerous, no? And it happens very frequently. It's a practical problem. You say stop smoking, okay, starts chewing. Good for you, bad for the patient.
No, sir, sir.
Bad for everyone.
Yes.
Any other problem with smoking?
Sir,
Chronic cough, which can
chronic
keep
cough, yes, sir.
bothering you, and you need to let it settle before you operate. Huh?
Yes,
What would you offer as a surgeon? We discuss most of it earlier.
Sir, we can offer open lichen stain free repair to the patient as well as laparoscopic lichen stain tension free, sir.
User open lichen stain free repair.
Tension,
It must be
sir.
free, lady Arden.
Sir, lichen stain tension free repair, sir.
Mesh hernioplasty.
Mesh hernioplasty.
Lichen stain tension free mesh hernioplasty open only. You don't have to mention open. What does it mean?
Sir, we strengthen the posterior wall.
You'll see a video of that. So I'll not get into the details, technical details. We are not discussing because Dr. Sanjay is going to share with you. But what does it technically mean? You should know. We're putting a mesh either way. What is mesh for?
For strengthening the posterior wall.
Which part of posterior wall is the weakest?
Sir, lateral to the.
What is myopectoral orifice?
So myopectoral orifice of Forshad is it is medially bounded by the lateral wall of the rectus, medially by the lateral wall of the rectus, medially by the iliopsoas tendon, and sir inferiorly it by the Cooper's or pectinis ligament, and sir anteriorly or superiorly it is bound by the iliopubic tract.
Therefore, there is a part which is infrainguinal and there is a part which is suprainguinal.
Yes, sir.
And this orifice needs to be closed, obliterated. That's why they prefer laparoscopic repair now, because from behind they can put a big mesh to cover. This is the background. And myopectoral orifice is the orifice through which these structures are going in. You know, whether it's the femoral vessels below or the cord above. But this becomes like a door in the wall. This becomes the weakest part of the wall. That is why this is a significance of MPO. And mesh usually covers the suprainguinal part. That's why few modifications of the mesh came in, like in the protein hernia system, where there was a posterior part plug and it will cover the lower part also. So you should be clear on that part. Dr. Sanjay, one question.
Yes. What is this iliopubic tract?
So iliopubic tract is the condensation part of the fascia transversalis below, like which where the fascia transversalis is attached to the inguinal ligament inferiorly. The condensed part of the fascia transversalis is iliopubic tract, sir.
So it is what inguinal ligament looks like from behind.
Yes, sir.
That's what, if you broadly, like a layman, if you want to understand it.
Yes.
So, any question? We try to cover it quickly. You made a good presentation, don't worry. With this hernia, you will pass. But if you auscultate and percuss, by the way, educate me. How did you percuss this? No, educate me.
So it will get reduced. I won't able to percuss it.
Why did you write? And even if it doesn't reduce, how are you going to percuss and it is going to go all over the place?
We can't fix it
Percussion
also.
is done for stable things.
Yes.
Palpation is done for stable things. Translumination is done for stable things. So you need to be clear in your head. Okay?
Yes.
Right. Thank you. Well presented.
Thank
Give a
you.
round of applause. We have one more from LHMC, Dr. Rishabh. Are you here? No, I'm asking about Rishabh first. I'm asking about if Rishabh is there or not. The next presentation is by Dr. Ayush, and I'll request Dr. Nena to join us on the dais. Round of applause, please. They welcome Dr. Sugupta, who's joined us, Dr. Sumit.
Good afternoon to all the panelists. I'm Dr. Ayush Agarwal, and I'll be making my case presentation on a case of carcinoma penis. My patient is Mr. X, a 50-year-old gentleman, resident of Kasgan, Uttar Pradesh, and a laborer by occupation. Presented to a surgical OPD with chief complaints of an ulceroproliferative growth at the tip of the penis since the past 6 months, and purulent discharge from the growth since the past 7 days. History of presenting illness. The patient was apparently well 6 months back when he noticed a small ulcer over the glans penis, approximately 1 into 1 centimeter in size. It was initially non-progressive in size for 2 months, but has since then rapidly progressed to replace and cover the entire glans penis, approximately 4 into 4 centimeter in size. There is also history of foul-smelling discharge from the growth for the past 7 days. There is history of dull-aching pain around the growth for the past 15 days on and off, which is relieved on taking analgesics. History of phimosis is also present for which patient underwent circumcision in his teenage years. There is no history of difficulty in micturition or any pain during micturition or any change to the stream of the urine. There is no history of any inguinal swellings on either side of the patient. Past history, patient has undergone circumcision for phimosis in his teenage years. No other details are available according to the patient. Patient has no known comorbidities, no diabetes, tuberculosis, hypertension, or any other chronic diseases. Personal history, patient is a laborer by occupation. There is no history of high-risk behavior. The non-alcoholic and non-smoker, mixed takes a non-vegetarian diet, has normal bowel and sleep habits, and no history of any allergies. On general physical examination, the patient was conscious, alert, and cooperative, and well-oriented to time, place, and person. Hydration status was adequate. Performance status is 90 according to Karnofsky scale. Patient was vitally stable. Temperature was afebrile. There was no pallor, icterus, cyanosis, or any pedal edema on bilateral limbs, or any clubbing or lymphadenopathy. Systemic examination, all systems were examined and were within normal limits. Examination of the genitalia and the inguinal region. Patient was examined in a well-lit room with adequate exposure and privacy, and informed consent was taken beforehand. On inspection, the penis was central in location and circumcised. There is an irregular ulceroproliferative growth, which is seen replacing the entire glans penis, approximately 4 into 4 centimeter in size. The margins were well defined. There was slough present over the growth, and there is also foul-smelling purulent discharge from the growth. The urethral opening is in its normal position. On palpation, there is tenderness over the growth, and induration is present all around the growth, approximately 1 centimeter in circumference. These are a few images of the patient. So we can see a growth which is present at the distal and at the tip of the penis, which is replacing the entire glans penis, and the urethral opening is visible in the ventral aspect here. Yeah, the urethral opening is visible here. Patient reported no difficulties in passing urine, no pain in micturition, and no difficulties or any change in the stream of the urine also. As you can see, there is slough present over the swelling. So slough present over the growth here, and there was also purulent discharge from the growth. And an induration margin is seen extending below the growth, approximately 1 centimeter in size. On other examination, bilateral scrotal examination was normal. Inguinal examination was normal. There were no swellings. The perineum was normal. Examination of lower limbs, there was no edema seen. Distal rectal examination showed no evidence of any prostatomegaly. Per abdomen examination was normal. No organomegaly or no evidence of any free fluid. So to summarize, my patient is a 50-year-old gentleman who is laborer by occupation, presented with an ulceroproliferative growth over the glans penis for the past 6 months, with history of purulent discharge and dull aching pain for the past 15 days. On examination, there is an ulceroproliferative growth approximately 4 into 4 centimeter in size over the glans penis with iteration of 1 centimeter extending beyond the margins of the ulcer. Provisionally, this is a case of carcinoma of penis, clinically T1, N0, and M0.
Right. So, any questions?
What you want to say by high risk behavior?
So high risk behavior, because in carcinoma of penis, there can be a history of HPV infection, which is a risk factor for carcinoma of penis. So we have to take history of high risk behavior if he is having, if he's an IV drug abuser, if he's having trucker by profession, which are known to have high risk behavior. That history is important in this. Multiple sexual partners. Yes, sir. Yes, sir.
And HPV is a factor.
HPV is a risk factor.
In how many percentage HPVs is basically responsible for carcinoma?
Sir, I do not know the exact percentage, but HPV variants types 16 and 18 are responsible with 6.
30%.
30%. Yes, sir.
Smoking, is he taking history of smoking?
No, sir, he's a non-smoker, but smoking is also a risk factor, increases the risk of penile cancer also.
Right. And you mentioned about circumcision.
Yes, sir.
Is it protective?
Circumcision, when done early and in the neonatal period, is protective, but as we go later, there is no evidence which has shown that it is protective at a later stage.
Correct. So, infancy.
Yes, sir, in infancy.
So, generally done in which race?
In Muslim population, it is done in early, and in Jews also it is done. Jews also it is done.
Later, but if
Yes,
you do it early, protective.
Yes,
And what are the precancerous conditions that you would make history of?
Sir, for example, the most common precancerous conditions are erythroplasia of Currat, which is a flat growth on the glans penis, Bounce disease when it is present on the shaft. There can be condylomata acuminata or and varicose carcinoma is also present. Varicose growth present over the penis also acts as a predisposed.
Bowen's disease?
Yes, sir.
Leukoplakia?
Yes.
You missed out. Ricketts disease of penis?
Yes, sir. Bowenite papulosis, lichen sclerosis, sir.
Leukoplakia of Currat?
Lichen sclerosis.
Lichen sclerosis, and of course, HPV related genital warts.
Genital warts.
Very well covered history and examination, and you mentioned about the high-risk behavior as Sanjay sir asked.
Yes,
so, what differentiate, if we are happy with the carcinoma penis diagnosis, what differentials regarding the infections? If you would have had history of high-risk behavior, it is a ulcer with no pain. Let me hear what if there would have been a pain, what would have been your differential? Just 2, 3, and if there is no pain, this is dull aching pain. What
Yes,
would
ma'am.
be your differential?
Ma'am, for example, if it is syphilitic chancre, it can cause pain along with inguinal lymphadenopathy. Can have, and other sexually transmitted diseases.
Syphilitic doesn't usually cause pain.
That is a
Yes.
painless
If
swelling.
it is a painless, then
Yes,
it
ma'am.
is syphilitic.
Yes, ma'am.
And if there is pain, then what are your herpes, and you can go
Herpes
towards the other differences. And you mentioned some of them. Like, we can go if there are bulky lymph nodes, we can go towards lymphogranuloma.
Lymphogranuloma.
Right. So, yes.
But still, I have got a few things.
Yes, sir.
I doubt your clinical T1 and N0. Because with such a destroyed, foul smelling, you want to say even there will not be infective enlargement of the inguinal nodes, number 1.
Yes, sir.
Number 2, you yourself said that the induration is around a centimeter proximal.
Yes, sir.
So what do you, that induration you treat is a benign problem or the infiltration of the growth?
Sir, it can, because the patient also has a foul smelling discharge for the past 1 week. So due to inflammation, there can be an extended area of induration beyond the margin of the growth.
So you could cover, you were trying to say that it is T1, including that induration. You can't exclude that induration.
Yes,
You'll have to take it as malignant induration, or malignant infiltration unless proven otherwise. How do you differentiate it from an inflammatory induration?
Sir, inflammatory indurations will usually, there will be raised temperature of the skin and it can be relieved by analgesics and anti-inflammatory.
Clinical examination. I'm talking a very simple thing. Don't
Yes,
make
sir.
it complicated.
So signs of inflammation will be present if.
That you already mentioned.
Yes, sir.
The tenderness would be there.
Yes, sir.
Anything about the extent? Does it remain within the confines of the lesion or it goes beyond?
So it will remain within the confines of the
So
lesion.
that
That's
is
the
the
inflammation.
answer to that question. So inflammatory is usually not beyond it. Well, you mentioned it also. What's the point in mentioning it?
Yes, sir.
Clinically, this would be beyond, and you know, that induration is a part of the disease only. The other thing you mentioned was about lymph node. It's very, very unusual.
Yes, sir.
To have carcinoma penis at any stage and not to have any nodes, although it can happen.
Yes, sir.
So, is there any possibility that clinically you cannot comment on it?
So there was repeated clinical examinations of the course of the past 1 month. Patient was examined
Can you
every time.
understand the question before
Yes,
you
sir.
answer?
Yes, sir.
So, can you say that?
Sir,
You
on
can
extended
only-
ultrasound examination. Yes, sir.
Ultrasound do it, and these days the end stages, like we talked yesterday.
Yes, sir.
You were not there, but must have attended virtually.
Yes, sir.
The lymph nodes can be ascertained only by ultrasound. This clinical end stage business is all over.
Yes, sir.
You can miss out. There is a low sensitivity. But it's unusual, as you rightly said, because it's secondary infection, only you will get lymph nodes.
Yes, sir.
They're common. Okay?
Yes, sir.
Something about the urethral meatus. The meatus is very important in these patients. I asked you to also mention it.
Yes, sir.
You change in the stream, you said no.
No, sir, no.
But whatever you say, we can't believe just like that. Looking at the picture, show us the picture. Take us to take the cursor there.
So this.
Now, it is not lying normally and naturally. So the stream can't be natural, it's common sense. So if it is not, then don't say it.
Yes,
If it is, you know, we can't argue over it here because what you are saying we have to believe. But it is unlikely. And the examination of penile shaft is incomplete without examination of the penile urethra, the membranous part of it, the whole urethra has to be examined. And the cord needs description too. You mentioned the testes are fine, mentioned about the cord also.
Okay, sir.
And DRE is important. Can you tell me why?
Sir, so usually carcinoma penis spreads via lymphatic route to the superficial lymph nodes, deep inguinal lymph nodes, and then
You say DRE.
Yes, sir.
Digital rectal examination.
Yes, sir. So to check for the prostatic urethra, if there is any infiltration there.
Examination will be complete only then.
Yes, sir.
You get even seminal vesicles examined in that process. Basically, urethra needs to be examined. There are stick lesions sometimes. You may have one lesion here, one lesion there.
Yes, sir.
Like we talked of indirect laparoscopy as an office procedure in clinical examination on head and neck.
Yes, sir.
Finally, last word, last question. Did you examine the mobility of the shaft over the pubic symphysis? Because that again can be indirect evidence. What you're palpating could be less than what it is.
Yes, so the shaft was
mobile freely.
Yes, the mobile freely. The growth
suspensory ligament can be infiltrated,
Okay,
and
sir.
then you may have a different decision.
Yes, sir.
It won't be partial, then you go for.
I had a point to ask you. In
Yes,
history, he underwent circumcision at a later age in life.
Yes, ma'am.
So what was the indication? Was it only a urinary flow obstruction or did he have recurrent attacks of injection?
Ma'am, he had a complaint of phimosis, due to which
Phimosis was there. What was the reason for operating that?
Phimosis must have got operated.
phimosis he was electively operated because of his own wishes.
Without any complaints?
No, sir. No, ma'am. No other complaints.
Second thing I wanted to ask was the coronal sulcus visible in this case?
No, ma'am. The growth was entirely involving the glans, and we cannot differentiate it from the coronal sulcus and the shaft below.
Possible because it's distal, so distal growths go outwards, and especially the warty growths, they don't go backwards. So it can happen, they keep
While
going on.
coronal sulcus is involved, would you still call it a growth of glands only?
Then it will be a
Because
growth.
it's a coronal sulcus you cannot see, and there is induration 1 centimeter beyond it. So you think it's a growth confined to glands?
It will be a growth to the glans as well as the shaft of the penis.
Could have started from there.
Yes, sir.
Nomenclature would be the glance only is progress.
Yes, sir.
Now, how do you stage it? They are having an issue with that, so please kill that issue. How do you clinically stage?
Sir, as an extension of examination, we would like to get an ultrasound to check for the nodal stresses.
Yes.
For the primary to involve to check
For T, yeah, for the
for
hair.
T states for invasion into the corpora cavernosa spongiosum, we should get an MRI of the penile region so that we can better delineate the soft tissues and see if there is any invasion into the
What
corpora.
is the TNM drug?
So-
Name. Tell us the status.
Yes, sir. TNM includes T carcinoma in situ, TA, which is varicose carcinoma, T1A, which is invasionally subepithelial connective tissue, but with no lymphovascular invasion and grade 1 and 2 only, well differentiated. T1B is invasion into subepithelial connective tissue with either lymphovascular invasion or grade 3 or 4, which is poorly differentiated. T2 is invasion into the corpora cavernosa spongiosum. T3 is invasion into the urethra. T4 is involvement of the adjacent structures like scrotum and the prostate. And sir, nodal staging is N1 is sir when there is mobile lymph node in the inguinal region on unilateral side, only on one side, and N2 if there is involvement of mobile lymph nodes multiple on the one side or multiple bilateral lymph nodes are felt in the patient. N3 is if there is any fixed lymph node in the patient or multiple fixed lymph nodes on either side or multiple fixed nodes on bilateral side.
And therefore, examination of the pelvic lymph nodes becomes important.
Yes, sir.
Sometimes you have no inguinal nodes, but you have pelvic nodes. And how do you examine for the eyelid group?
Sir,
Turn the patient to the opposite side, flex the hip 15 degrees, and
yes, sir.
you take your fingers down along the eyelid hollow. You feel against that. Okay?
Yes, sir.
It's possible if they're large, you can tap, because when you know you'll be able to feel the vessels, of course.
Yes, sir.
So you should know about the local regional examination completely, and be careful about the lymph nodes in these patients. In any case, with or without any pathology, they may have inguinal lymph nodes. So you have an absolutely clean inguinal region can be a challenge.
Yes.
You may not get it. How do you proceed now? So the clinical stage we have clarified now. You will not know clinically about the involvement of the corpus spongiosum and cavernosa. Therefore,
Yes,
we need to add investigations to know it and begin bare minimum with ultrasound.
Yes,
which you can add Doppler to know the extent of involvement. The old, what was the Jackson staging system? Old one?
Sir, I don't remember, sir. Sorry.
Well, it's old, confined to testis, confined to the, confined to the tip, confined then to the shaft, involving the cord and inguinal region, lymph node involvement. So they did it in 4 stages. You can read about it. It's not followed now. It's a really important. Any question, Anna?
Yeah, just you explained the staging very beautifully. This proliferative growth involves it is kind of pushing the urethra. If it involves the urethra, what will your T stage be?
It will be at T3 stage if it is involving the urethra.
That is why I'm asking you.
Without urethra.
It is ADCP8 have changed the staging that involving the urethra. It does not matter. It can be T2 or T3.
Used to be the past, no? That is changed.
It will affect our management definitely the way we make the opening of the urethra later on. But regarding the staging, it will be T2 or T3 depending only on our MRI, whether the corpus spongiosum is involved, then T2 and cavernosum T3, and urethra can be involved, which can be either T2 or T3.
The significance you will attach to superficial and deep group of lymph nodes.
We move to that. How do you proceed now?
Sir, in this patient, since there is an induration extending to the shaft of the penis, but still on examination, we can see that a 2 centimeter of the penis can be preserved and there is an adequate length for micturition.
How do you proceed now? You have a diagnosis?
Yes. Sir, a diagnosis, first investigations.
What did I ask you? How do you proceed?
Sir, first
simple question,
diagnosis.
simple answer.
Yes,
You
sir.
talk about partial and total connecting.
Sir, first we'll
Have you confirmed your diagnosis?
No, sir.
First, yes or no, sir?
No, sir.
Have you staged your disease?
No, sir.
So how would you straight away start doing the surgery? So investigations, how do you divide them?
So investigations to confirm my diagnosis, to stage the disease and to treat the disease.
Treat the patient.
Treat the patient, sir.
Now what do you do to confirm?
So
what do you do to stage? What do you
Yes,
do to treat?
To confirm my diagnosis, we would like to take an edge biopsy from this
Take the
region.
person, where you take the biopsy?
So we would take this from this region with a block of normal tissue also, so that we can get the most proliferating cells at the edge and identify and have the most chances of identifying the lesion.
There you go.
Yes, sir. And this will confirm my diagnosis. Sir, for staging the disease, sir, we'll go ahead with an MRI of the penile perineum, along with, sir, ultrasound of the inguinal region and, sir, the pelvic region to identify if there is any lymph nodal metastasis. After, sir, after staging the disease, In this patient, for example, the MRI was performed and it turned out to be a T2 disease with invasion into the corpora cavernosa and the spongiosum also. So, sir, and there was no lymph nodal involvement in the inguinal lymph nodes or in the pelvic lymph nodes.
Okay, so you sent a biopsy, so you taken the biopsy from the part that you mentioned.
Yes, sir.
And the report comes back as equivocal. Pathologist is not able to comment. So what precautions have you taken? What could you do now?
Sir, so first of all, we can perform a repeat biopsy in this patient if we do not get if we get an equivocal result, we can proceed with.
Yes. Yes, sir. Omar. Simple question we discussed yesterday also. You have attended some of the sessions at least you should have attended. The usual cause is secondary infection. That's what initially Dr. Sanjay was also asking about the lymph node. Same thing happens. They may have secondary infection. You can repeat your biopsy, but after a course of antibiotics, it should help you get a more representative biopsy and repeat it from 2-3 places. That will avoid the sloughed area.
Yes.
That's okay. Now, there was a question, how will the corpora cavernosa involvement make it T2? Is that what you are asking?
So there was in the MRI, there was a loss of fat planes with the corpus spongiosum as well as the corpora cavernosum. That was indicative of infiltration into these group of muscles.
The cavernosa involvement goes to T3.
Yes, sir.
T2.
Sir, it was infiltrating both the spongiosum and the cavernosa. And these cavernosa. Both
Will it be T3? That's the question, no?
Yes, sir, it will be T3 then, without involvement with
So what it becomes now?
So it becomes a high risk lesion, sir.
No, T stage.
T3, sir, CT3.
What did you say initially?
T2, I said, sir.
T2 or T1 you said?
So clinically it was T1, but after investigation we found it was
you
T3.
should qualify at that point itself. But I would like to comment on it once I've done the investigation.
Okay, sir.
Clinically, you can't ascertain corpora cavernosa involvement, spongiosum involvement. Suppose that is going by what you were saying.
Yes, sir.
So that is why this point was raised, and I wanted it to be repeated for this reason.
Okay, sir.
What is the clinical stage now?
So CT3, N0 and M0, sir.
What is unusual in your?
So no nodal involvement is unusual in this case, sir.
N0 is very unlikely.
Yes, sir.
And contralateral inguinal region is also clear.
Yes, it was clear.
Now you can tell us about the inguinal group of lymph nodes. How many groups are there?
Sir, there's a superficial group of lymph nodes and the deep group of lymph nodes. In the superficial group of lymph nodes, according to the position, they can be divided if they are superomedial, superolateral, along the inguinal ligament. Deep lymph nodes are the cloacated group of lymph nodes in the femoral triangle. From that, sir, they can spread to the pelvic lymph nodes, which include the external iliac, internal iliac, and the obturator lymph nodes, sir.
Now, Dr. Ratna, your question you can ask.
He's already defined the groups.
Yeah, that's what I mean. So it happens here, no? That's why I brought it here. So, if you have done the clinical examination, you've done the basic investigation, you've staged it, and your staging is correct, how are you going to proceed?
Sir, for clinically T3 lesions, we usually take them as high-risk lesions, and studies have shown that it is better to, if there is no nodal involvement, it's better to go ahead with a dynamic sentinel lymph node biopsy if available at the institute, from which if there is an intraoperatively positive lymph node metastasis, we would proceed with ipsilateral radical inguinal block dissection.
Do it in penile cancer also,
Yes, sir.
using
Yes, sir.
both methylene blue and also ICG.
Yes, sir.
What was the problem? It is easier said than done, dynamic
Yes, sir.
sentinel, but what was the problem in penile cancer?
So due to superadded infection here, sometimes the lymph nodes.
Something else with the location and drainage?
Sir, there is.
What is the lymphatic drainage of penile shaft?
So there is a.
From the tip down.
So there is a crossover of the lymphatics at the base of the penis. So there is if only one side involved, then we will always have to perform dissection on the other side also.
So we don't know really. So
Yes,
sentinel node biopsy, although it was done very frequently in these cases. So what is dynamic sentinel node biopsy now?
So it includes two techniques. They are using a technecium 99 labeled sulfur chloride dye, which is and along with that a blue dye is used, usually methylene blue.
And you see happening. So you're able to watch it as
Yes,
it
sir.
goes. You can trace it.
Yes, sir.
and then find out this is a central node. If you don't do the dynamic one, you will miss they are not skip lesion, they are just some other lesion which you are picking up. It's important to understand role of sentinel biopsy is not, it's not a very well-defined zone.
Yes, sir.
Anything else you would do? Suppose it is still N0, it's a high risk case.
Sir, we can go ahead with ipsilateral superficial block dissection, and then according on the basis of histopathology.
Cabana, what approach, Cabana dissection. What do you mean by superficial?
Sir, only superficial group of lymph nodes above the facial artery are removed, sent for histopathological examination. If there is any metastasis in these nodes.
What are the boundaries of this?
Sir, superiorly the inguinal ligament. Sir, laterally it is the sartorius muscle.
No, that is the inguinal proper.
Yes, sir.
Inguinal dissection.
Yes, sir.
When you are doing the superficial only.
Sir, we do not open the roof of the femoral triangle. Above the roof of the femoral triangle, the lymph nodes that are present, we excise those only.
You heard of Cabana?
Yes, sir.
What is that?
Sir, the name of the sign.
No, Cabana dissection in this case.
No, sir, I don't remember, sir.
Say that Cabana, name your word.
Yes, sir.
It's common sense that he is to somebody.
Yes, sir.
Any question then?
We move, I ask you more about that. So far.
You were telling the boundaries of the superficial, just
So you have sent the superficial lymph nodes for frozen section and they turn out to be positive. How will you proceed?
No, first the primary. We come to primary.
Sir,
We do for the primary.
sir, we'll do a wide local excision of the margin.
Right.
Sir, in a penile cancer, usually high grade, the earlier guideline was a 2 cm margin, but nowadays, depending on the grade of differentiation or the staging of the tumor, we can take a 10 mm margin or a 15 mm margin. Since this is a high grade lesion, this is a T3 disease, we would like to take a 15 mm margin. And if there is a shaft of the 2 cm shaft of the penis is available for us, then we can do a partial penectomy in this patient.
Any newer approaches in this so that we can reduce the margin, we need to preserve the length.
Sir, in T3 lesions, sir, we can also attempt neoadjuvant chemotherapy.
Very rarely would it work.
Yes, sir.
Very necrosed tissues,
Yes, sir.
they don't do very well.
Yes, sir.
For the same reason, PET scan doesn't help. These are the very special tumors.
Yes, sir.
Partial, if you can get an adequate shaft,
Yes, sir.
and that is not defined,
Yes, sir.
and you should get a clear margin, and that is based on grade. You're correct there also. You don't need to give a 2 cm margin anymore.
Yes, sir.
So about the primary, this is it. Now she's asking about the inguinal approach. Now you can ask. She says Provisional is positive.
You can tell us the difference between wide local excision and partial
That's why.
penectomy, no?
For a partial penectomy also, the excision always has to be with a margin of 10 to 15 mm. And a shaft of...
You must ensure that just an adequate length enough
yes, ma'am.
is available.
So the
So
patient...
the patient can pass you
Yes,
in
ma'am.
a standing
Standing
position.
position. Yes,
Wide local excision, if it is a large growth, the same principles will apply as partial penectomy. If it is a small lump, you can take that minimal margin to get R0
yes.
clearance around it. Now coming to groin lymph node dissection, if you've done superficial lymph node dissection and sent it for closing section, it comes positive for malignancy.
See, I'll clarify the wide local again. We shouldn't get into trouble.
Yes,
You're
sir.
using this term, which is basically for superficial lesions.
Yes, sir.
When you talk about penectomy, there is nothing like wide local excision. Let's be clear. We need to get a clear margin in 3 dimensions, not in 1 dimension.
Yes,
Okay.
sir.
In a tubular structure, getting 3 dimensions is not easy and not possible. So that is for very superficial. Okay.
Yes, sir.
Very terminal, very superficial lesion, you can also opt for other options. Topical chemo, topical radiation.
Yes, sir.
But for a T3 lesion, you're going to talk about penectomy, partial or
Total penectomy.
total. And when you have adequate length available, which can be ranging from 1.5 to 2.5 centimeter, which is variable, we'll look at the techniques later on because you need to make sure that the urine doesn't fall on the scrotum.
Yes.
And there is no urinary dermatitis. And the other thing is the achieving a good closure, which makes it worthwhile a functional shaft important. Back to now positive superficial block. What are the boundaries? What do you do next? She said it's positive.
If the superficial group is positive on one side, we'll proceed with the dissection of the deep group of inguinal lymph nodes that side. Also, along with that, we will do the superficial inguinal dissection on the contralateral side. This is the minimum that we have to do if there is superficial lymph nodes are positive.
That's right. And if it's the deep is also positive, then what we do?
So then we'll proceed for pelvic lymph node dissection on the affected side
Or
also.
island
Inguinal block dissection, sir.
with the same incision or with the modification.
Yes, sir.
Your question, you were asking about the boundaries.
Yeah, I you just define the boundaries of the inguinal dissection for me.
For inguinal dissection, the superior boundary will be the inguinal ligament. The lateral boundary will be the sartorius muscle.
Which sartorius muscle, which outer of the lateral border or medial border?
The medial border of the sartorius muscle and the adductor longus muscle medially, and the apex, the medial border of the lateral border of the adductor longus muscle and the apex of the femoral triangle inferiorly.
This is for superficial. What about the deep?
This is deep actually. So what is the depth of it?
Sir,
You're talking about inguinal block dissection.
yes, sir. Inguinal. Sir, the superficial lymph nodes, as I said, will be present over
No,
the
I didn't ask you. What was the question? What is the depth of this? You mentioned the lateral limit, medial limit, superior limit, depth.
So depth will be the femoral lymph nodes have to be removed, sir.
You know or you don't know?
No, sir.
Why don't you say you don't know? Some muscle.
Sir, pectineus and the iliopsoas. Iliopsoas, sir.
So they form the depth. These are the boundaries. Okay. And you go lateral to medial. What are those structures that you will need to see as you go lateral to medial?
So we'll see the vein, artery, and the nerve, sir.
Lateral to medial.
Sir, the nerve, artery, and then the vein, sir, and then the cloacoid lymph nodes in the middle side, sir.
Space and lymph node.
Lymph nodes in the middle side.
Label, right?
Yes, sir.
Nerve, artery,
vein,
empty space through which the hernias happen.
Yes, sir.
And the cloacates.
Cloacoid lymph node.
This is it?
Yes, sir.
You see that in all dissections which are formal inguinal dissections. The superficial dissection has got nothing to do with this when we talk about this boundary. Superficial is what exactly is superficial? What is it superficial to?
So the deep fascia of the thigh, the superficial or deep fascia of the thigh. Yes, facial.
Right.
What you need to do with a slight difference as compared to superficial is you remove this fascia triangularly en bloc, and then you need to ligate and cut the great saphenous vein at the level of fossa ovalis. That's how you would reach inside and go up to the.
Now, there again, you should take home correctly. I'm sorry. Here, this is what happens. We must get a final answer. That's what moderation is. You can do without ligating saphenous vein. You've seen it being done. We can follow the saphenous and preserve it. So there is a saphenous preserving and saphenous sacrifice. If there is an involvement at the junction, you would not like to preserve it to make technically it becomes a challenge. Important to understand all aspects. Yes, so it's not about making each other happy here. This is a very clear cut forum. Yes, everybody knows what we are doing. So you know the final answer is boundaries. For the iliac dissection, what are the boundaries?
Sir, iliac, sir, superiorly will be the common iliac vessel bifurcation. So medially will be the bladder, and the depth will be the obturator nerve. Lateral will be the genitofemoral vessel, sir.
There you are. So these boundaries should be remembered so that you can answer in the exam better.
Yes, sir.
But we don't do pelvic dissection. We did very regularly. We can rule out involvement here, then we can avoid it.
Yes.
Your question, Sanjay. Only 2-3 minutes and we'll do advice.
So, how will you follow this patient?
Okay, relating to the treatment part.
Yes.
Anything more? Anything you want to know? Yes, please.
If just tell me the criteria of pelvic node dissection. We discussed it, but if when the inguinal nodes are positive, how many nodes are positive will you move to pelvic node dissection?
If more than 3 inguinal lymph nodes are positive.
More than 2. If
more than 2 are positive.
Remember it like that. If more than 2 are positive, we move towards pelvic node dissection, and if 3 are positive, we will give adjuvant therapy.
Okay. Yes.
When do you do contralateral?
Sir, if there is involvement on we always have to do contralateral if there is any involvement on the unilateral side.
You don't need to do it in the same sitting.
Yes.
You can stage it. And you stage it because of the possibilities of complications that happen. And what is the major one?
Sir, if there is a lymph node large enough, it can erode into the femoral vessels and cause bleeding.
Don't breathe.
Yes, sir.
What's the problem of doing the inguinal block dissection? Question is direct. You answer something else.
Sir, there can be flap necrosis and infection at the site, which is very common in these patients. Along with that, sir, there can be lymphedema in the unilateral limbs
Blood
also.
failure is a major one.
Yes,
You
sir.
don't want to do bilateral because there's a lot of morbidity, so you need to avoid that. No, that's why we were asking. Anything in the adjuvant treatment, that's what Dr. Sanjay was asking. You've done the surgery, you got everything done, sorted on the right side, margins are clear. It is a moderately differentiated squamous cell carcinoma.
Sir, depending on the grading, which is moderate.
Nodes are called.
Sir, if we are going ahead with pelvic dissection, then we can go ahead with pelvic dissection and adjuvant therapy in the form of chemotherapy. The regimens used are cisplatin, paclitaxel, and ifosfamide. And earlier bleomycin was also used, but nowadays platin and taxane bases are used. 4 cycles are usually given, sir, to the patient. And sir, adjuvant radiotherapy is also indicated in some cases where we are not
Why are
proceeding
they
with.
radio resistant mostly, although they are squamous cell carcinoma? Anybody? Necrosis, dead tissue, the response is poor. So although it's squamous, but it doesn't respond very well. But post-surgery, there is good vascularity, so it can be offered. The dose will be much lower.
Yes,
That's another advantage. But chemotherapy, yes. Please.
Is there anything that you can do prophylactically to prevent bleeding from the underlying femoral vessels?
That is, if you're doing island block dissection, we shifted the goal post, so I'm putting it in perspective. But we are somewhere else already. Now we are back to the egg vial block dissection, and we finished egg block dissection. What is it that we do? You've seen it being done regularly to protect these femoral vessels.
No, sir, Sartorius flap can be used to cover the femoral
I
vessels.
want to bring it in perspective. Not that I was guiding it. The answer won't come through. Yes, your question.
You just explained about the modified, what are the things, when we do a normal inguinal block dissection, as sir explained, the most common complication is lymphedema, which is a very common complication. So there's a modified inguinal block dissection. Can you tell me the changes?
Newer approaches, newer incisions, we have also modified it so that the flap failure rate is minimal.
Sir, usually we take a lazy S incision in the region.
Now, so what do? What is it that is changed? You
No,
don't know.
don't know, sir.
Yeah, but we usually don't take a lazy S incision at all. We take a simple incision parallel to the inguinal ligament, but in the modified version, we take a shorter incision. We save first, we take a shorter incision. Second, we save the great saphenous vein. We do not ligate it. Thirdly, we don't go later to the femoral artery. We stay near to the femoral artery.
Do less.
Yes.
And don't dissect the flaps too much. We have tried using no diaphragm, it works fine.
Yes.
Using forceps or scissors or cold line. And don't go lateral to the sartorius, which is what we practiced earlier. The perforators to the flap are damaged.
Yes.
And it's safer to put a flap if you are having a problem before intensive facial something to cover it. So that freshly vascularized tissue is there. There's so many ways to do it. Incisions are about 8 or 9 of them. One of them is lazy S, which takes care of both. Reduced to 1 incision now. Some people use 2 parallel incisions so that you can access both sides.
Yes.
And you can do 1 incision also. There's one lazy S, which is lazier than the previous lazy S. So it goes floating. You don't cut all of it. You only use it when you extend, only when you leave it.
Yes.
Less of that than you close. That is what people try. But still lymphedemas happen. Floating flaps happen. So you need to apply stockings immediately post-surgery.
Yes,
they need that pressure for the flaps to stick. And sartorius flap also helps in preventing that.
Yes.
Done.
Name some organ preservation measures that can be taken in early carcinoma venous.
Ma'am, for example, if it is a TA disease, if it is a varicose carcinoma, we can go for most micrographic surgery. In cases of varicose carcinoma only, mostly, in which we do serial excision and then examine by frozen section. So, ma'am, topical chemotherapeutic agents are used. 5-fluorouracil, imiquimod, they are also used for.
Very early.
Yes, sir. Very early. Yes, very early.
Most can be done even here, but it's late.
Yes, sir.
I mean, so it's
T3.
T3. So you are late in the smaller episode. Most big
micrographic surgeries. Most micro.
Right?
Yes, sir.
You mentioned all the modalities. One more modality we can go for an early cancer apart from surgery.
Chemo
mentioned
top.
radiation, you mentioned chemo, any other?
Laser, we can go for laser.
NDR
excision
laser
as well.
and CO2 laser are used for
Only
excision for
one
early
laser,
cancers.
but you already mentioned it, CO2 laser and NDR.
NDR laser.
Anything which is projecting, it's possible to use.
Yes, sir.
You collateral damage.
Yes, sir.
But again, repeating it, not for distance. You don't
Yes,
mess around, so that you don't speak it where it is not required.
Yes, sir.
When you're doing the penectomy,
Yes, sir.
and suppose you're doing total penectomy, you realize the margin is positive. What do you do to the urethra? Where do you make the opening, and how do you ensure that there is no problem in squatting and passing urine in these patients? We do it, that's why I'm asking for modifications.
Sir, we can, the perineal urethrostomy is made between the base of the.
Urethrostomy is okay. Now, how do you prevent the scrotum from falling? We don't do occipitomy anymore.
No, sir. Sir,
Terry? Or anybody? We take the median incision, no? We go right through the median bracket.
Yes,
and then we close it transversely.
so that
it gets
scrotum
it.
is pushed. Yes.
The patient otherwise has to hold and pass it.
Yes.
This can be one way to modify. There are others, I thought I'll just ask you so that the others. Penile reconstruction is done. Patients are usually young patients. So that option is to be left. So you leave the blood supply there and enabling total penectomy. When you're cutting the dorsal, the ligament, what do you call it? Penile ligament. When you're cutting that, the suspensory ligament, you take adequate flush cut with the periosteum, but you preserve the vessel length. So it's a blend, so that when they want to do some reconstructive procedure, they can utilize these arteries. Thank you very much.
Thank you,
Give a
sir.
round of applause. And with that, we conclude this session. And we move to a very important how I do it session, and I have kept Lycostin by hernioplasty and the radical right hemicolectomy we have AV fistula and 3-field esophageectomy or the radical esophageectomy, which was shown earlier, but lap pupils will be shown today. So the first presenter would be Dr. Sanjay Jain. I've already introduced him. He's going to show and demonstrate the basics of doing the Lycostin hernioplasty. You get this question in your exam as in your theory, and also when you are asked about procedures in your viva. So be prepared for it. And this is a very important question. He's a professor of surgery at Gandhi Medical College, Bhopal. And a very popular teacher, and I forgot in the mention, I mentioned in the morning, I hope you've not forgotten, the immediate past president of the Association of Surgeons of India. A very keen academician, wants to share what he does, and importantly, some nuances. So this is a very common surgery performed by all of you. It will be useful to pay attention. Over to you, Doctor.
Thank you, Dr. Chintamani, first for inviting me here and giving me this opportunity to teach this very important operation. And what is very important, this is one concept which came of the Lycostin or the tension-free repair. The thing is, it has undergone many modifications, and even me reading the books, I have seen the things getting changed. So now what is optimum, what we want to, what is the problems in this, and what is the cause of recurrence, and what actually we want to achieve are the most important thing in Lycostin's repair. Of course, because of this repair, the differentiation between the lateral hernias or the medial hernias or all these things have gone, if properly performed, give excellent result. And even today, so this is started, you can see the 2 points here is the pubic tubercle and the anterior superior iliac spine, that is, and we make incision medial part. So I use the 2/3 more easily. You can come across, or you will come across one or more superficial epigastric vessels, which you have to secure. the two fascias, scarpa, camper, and scarpa, and then you come to the mainly the external oblique aponeurosis. We open it. Previously, it was being opened in the upper part to have an overlap. Now we can open in the middle, and then we dissect it upwards as much as possible and down below to the inguinal ligament. And you all know the inguinal ligament is nothing but the infolding or the J-shaped folding of the same external oblique aponeurosis. The three nerves which are very, very important, you know, ilioinguinal, iliohypogastric, and the genital branch of the genitofemoral. Then you pick up the cord near the pubic tubercle. We can take it on a sling, open the basically the cremasteric envelope, dissect out the sac, perform the herniaotomy. Remember, what is important here is in a large sac, even if you leave the distal part of the sac, it will be less problematic rather than trying to dissect too much, because it causes a lot of seroma, hematomas, and that is the main problem. So once this is the cremasteric envelope being opened, and once you perform this, look for the direct element, and if you find the posterior wall is weak, you can take a few sutures to on the fascia transversalis to make it almost normal. So once we deal with it, and then this something which is very important, if you see I am dissecting it medially because your mesh coverage should be at least 2 centimeters on the pubic bone, which is very, very important. You see the fascia transversalis repair suture, you can take and something here, what is important, just I'll pause. For the direct hernias, this is an essential step in most of the large hernias. And what you can do, you can invert, you need not open the sac. Even the fascia transversalis, which previously being opened, now you need not open, but you can plicate it and take the sutures. So this is, once it is done, then we go for the placement of the mesh. And mesh, nowadays, it is pre-cut. There are pre-cut meshes also available, but we shape it to the shape of the inguinal canal. And you see the at least 2 centimeter or 2.5 centimeter overlap, because all these meshes, they have got a tendency to contract, and the medial part has been seen to be the most common cause for recurrence even after this good repair. So again, the sutures, they have been changing. People were taking prolines. I am been using the delayed absorbable suture, because the concept which has come, it takes around 2 to 3 weeks, where this entire mesh is going to be covered by the own tissue. So, but for the beginners, no harm in taking a non-absorbable suture, slit in the lower end, and just embrace it across the inguinal, your cord. See, the mesh fits properly. There is no frilling, tension, or crumpling of the mesh. This is very, very important. Then the two tails can be united together, or the upper tail is sutured to the inguinal ligament. Meanwhile, what we have to remember, that we avoid putting tension on any of the walls. So that's how it remains the tension-free hernia repairs. Again, the mesh below has to be fixed with the inguinal ligament. We can take a continuous suture or few interrupted sutures, and also in the upper part, it has to be fixed to the conjoint muscle and the tendon with few interrupted sutures. Now, again, another important part are the three nerves. We must try to preserve these nerves, but if they come in the way of your dissection, because all of them, they become sensory in this part. So if they come, it is better to divide them, make a clean cut, infiltrate with xylocaine, and rather than having an entrapped and painful nerve at the end. So this is again few things which I have observed, people getting difficulty in separating the, especially the large sacs and those who are having a congenital hernia, because they are separating it from the cord is a challenge. So in those cases, you can actually open the sac, and near the neck, you can go and do a kind of, you take about 5 ml of saline, and if you just inject underneath the sac, it causes good hydrodissection. You can cut open the sac, and then you can go around the sac nicely and close it, and when it can get retracted. So once, now you can see the inguinal ligament attachments are being completed. And then the suture upwards with the our mainly the conjoined muscle and tendon. You will not find anywhere the mesh is getting crumpled or frilled. This is very, very important to attain this step. And rest, because that is the part from where you begin. You have to close the external oblique aponeurosis again, but that is constant with the absorbable sutures we do. And then the skin is closed to complete the operation. Now, this is something which is very important nowadays. Which I just wanted to ask the presenters, and I just kept it, because what is the anesthesia of choice for these procedures? If you talk of the Liechtenstein's own institute, these operations are done as office procedures and done under local anesthesia. So answer is local anesthesia. We, of course, most of us are doing it under spinal anesthesia. So we have not found, but it increases that we have to keep the patient for a little more time. Here, the external oblique aponeurosis is being repaired, and that is how we complete the operation. You all know the complications of the operation. And main problem which comes is the acute problem, which is the seroma formation, scrotal edema. So if it's a large hernia or a complete hernia, always I give a scrotal support which reduces the chances of scrotal edema, scrotal wall edema. And second thing, which is very, very important, is the late complication, that is the chronic inguinodynia. So if you take care, if you are aware of these three nerves, you take care of them properly, I have not received even a single patient. Yes, one patient has come, he was bit intelligent, so he came that he was feeling bit of the paresthesia or anesthesia, patch of anesthesia around the medial side of the thigh and the lateral wall of the scrotum, which gradually, I think, got corrected, and he never had the problem. So remember, do well, try to have a proper size mesh, fix it properly. I don't think there should be any problem in getting these cases done. Chintamani sir, anything else I should cover?
Really covered. Give a huge round of applause. Ask questions if you have any.
If you have found any difficulty in addressing any of the part, you can you ask me, sir, how to deal with this problem.
Now, if you don't ask on your behalf, I'll ask him.
Yes, sir.
The superior mesh when you're fixing, you saw that he was doing very carefully. And he was taking care not to involve the nerve.
Yes, that's the biggest.
Continuous sutures could be done in the lower part, but in the upper part will be interrupted for this reason. And he said no crumpling. Dr. Sanjay, how far medially you will take the leaf of the mesh?
Sir, medially, I at least have the 2 centimeter overlap.
And you want to go beyond?
Yes.
Will you fix it to the lacunar ligament or to the sheath?
Sir, nowadays we do not scratch this lacunar ligament. I do in the direct hernias because there I have found the little bit more anchoring is required.
Point out, don't fix it to the pubis or the periosteum.
Yes.
To avoid the osteitis.
Osteitis.
Every step was very clear, and you must demonstrate the island one, and these nerves should be taken care of. And cords, we saw the beauty with which he lifted it up. The trick is in being more and more medial. Anything else you want to tell them which is not covered there? If you have a question, please ask him. Because I think it covers everything. I'm trying to find something which can be of use to you and not covered. I think it's by and large all done. What do you do to the sac? Do you rotate and twist?
No, sir. So rotating, twisting should be, I think I say it should be avoided. What I do, I open it, transfix it, but transfixation is under vision, so that I am careful that I am not taking any time because it is the momentum which is popping momentum which comes.
And also, nowadays it is high dissection rather than high ligation. And twisting the hair out of it is a bad idea, which we used to do in the past. Still, some people keep on doing it. It makes it more painful later on, more adhesions later on. Dissect as high as possible. And sometimes if the sac is small, you don't need to open it, you can just push it in. Which is what they're doing in laparoscopic hernia also, because you just need it up. So high dissection rather than high ligation, which I remember staying in my head. And as he said, under vision rather than doing that rotatory business that causes more pain and it has no advantage.
Only two things which I would like to highlight at this point, that we means careful of the two sacs, that's the pantaloon hernia. So if you are careful, means even you are dealing in an elderly patient about the with the indirect hernia, see if there is a direct bulging, just put a 1, 2 or 3 stitches that will tighten the fascia transversus, and later the mesh will take care of. And this, yes.
In direct hernia also, the plication thing is not very quickly
yes.
done because it produces those ischemic spots.
Yes.
Fibrosis, and you need a pliable one.
Yes.
And therefore, many concepts have been discovered on doing the laparoscopy. You see the anatomy, to pulling the sac back in, all of it is inside. There is no ligation to be done in that case, unless it is a complete hernia where you don't have a choice, then you can do as the right.
And next thing which is important is be aware of the sliding hernias. These are the most deceptive, which can create a problem.
That you advise them to do?
See, in sliding hernia, the first thing is don't worry. Only thing what is coming is on the right side, the cecum, and this is part of it is it is not covered by the peritoneum. It's a bare area. So what I do on the both side, I cut or divide open the sac and suture it on the back of the cecum. So the cecum becomes an intraperitoneal structure rather than partial peritoneal structure. And then I will reduce and take a pus-sting suture rather than trying to take a direct transfixing suture and push it inside, close the sac, push it out, down everything, and then put the mesh. I don't think you will have any problem.
The slide, what he's saying is, you don't have to find a plane between the content and the, what is the sliding hernia? When one of the walls is formed by a content. So you can't do anything. So earlier we used to do reperitonealization, as you described. If you can do it, it can amount to some bit of damage. So these days you just push it in, let it be where it used to be. And in any case, we know it's high dissection rather than high ligation. So you don't need to worry at all. It goes in and it doesn't come back. If it is to come back, then your dissection is not adequate. Right? I think with that, thank you very much, Dr. Sanjay, for coming all the way from Bhopal and making it special. This important presentation will be also enclosed in our ebook, and I hope you will consent to that.
Yes, yes.
And all these questions
It's
are
all for
answered.
my students
Thank you so
or our
much.
students. Thank you.
Now I'm sorry, actually, that's my problem. I was just telling Nana the same thing. She's seen previous scrubs also, spoke also. I forgot that there is a lunch. So there is a lunch break, which was supposed to happen earlier, but that's how our courses run. Please get your lunch, come back quickly. We have some very interesting videos and then X-rays to follow. And also Dr. Edel Sai is virtually joining. We left out on the OSCE for the varicose veins, which you must attend. So that he'll be showing virtually after the couple of presentations which are how I do it. Thank you so much.
plus salary, almost equivalent to the retirement.
come in. Welcome back post lunch. I think we need more people inside. They must be having their lunch. Yes, let's come. Keep starting. So, welcome back after lunch. And we'll start with the how I do it session yet again. And give some very interesting and very important presentations. Radical hemicolectomy by Professor Manoj Angle. I think you all, Terry, is there somebody outside? Professor Manoj Angle is the head of the Department of Surgery at Lady Harding Medical College. A big round of applause and call more people. We only start when more people are there. It's a very important video and it will be very nicely demonstrated. Now, call everybody in.
Yeah, a little bit of preliminary this thing. I mean, I must thank Dr. Chintamani sir for having us. Every year we are here and we are learning better things when we come here. And we go wiser after this conference. So I have changed this title slightly. It is not just simply a radical hemicolectomy, but nowadays the trend is a total mesocolic excision or right hemicolectomy. There are large number of studies, publications, reviews, which all support that total mesocolic excision for probably cecal and ascending colon malignancy. They do offer a survival benefit. So probably that is the thing of the day. The basic principle, or I would say, I mean, you should know, all of you should know a little bit about this anatomy of colon. As far as a blood supply is concerned, I believe all of you know. And more important is this, that is a lymphatic drainage. So when we operate on a malignancy, cecal malignancy or ascending colon malignancy, for that matter, our basic aim to get a good lymph node clearance. As per AJCC guidelines, they do tell us that you remove minimum of around 10 to 12 lymph nodes. But there are certain other things which are not taken care of by AJCC guidelines. So as this diagrammatic representation shows, the lymphatic drainage goes into epicolic nodes, which are located, supposed to be on the bowel wall. Then there are paracolic lymph nodes related to the smaller blood vessel just entering the bowel wall. Then there are intermediate nodes, and then there are proximal or principal nodes. The principal proximal nodes are those which probably are related to your major vessels like superior mesenteric vessel, superior mesenteric artery, vein. And those which are related to your middle colic, right colic, they constitute this intermediate group of nodes. So the basic principle of this total mesocolic excision for, say, CA cecum is that we remove a large amount of mesocolon along the tissue, embryonic tissue planes with transaction of critical vasculature at their origin, like ileocolic artery or vein as they enter the superior mesenteric vein or they originate from SMA. Then the middle colic, branches of middle colic, that is right colic. Right colic may be a branch of middle colic or the right branch of the middle colic. They are ligated very close to their origin. The basic reason for doing this is to get a more number of lymph nodes. That is, you clear the lymph nodes along the major vessels, that is superior mesenteric vein, artery, and you also remove a large amount of the mesentery, which you may not have been doing otherwise if you would have followed the earlier principles. You might have landed up ligating the arteries and veins relatively closer to the bowel wall, not going up to the level of their origin. And I believe you know why we are talking always about ligating blood vessels. Why? Because we know that God has created such an anatomy that all lymphatics, they run along or they course along the arteries. So intraoperatively or otherwise, we do not identify separately the lymphatics, but we identify the blood vessels, we ligate, assuming that while we are ligating blood vessels, we are taking away the lymphatics as well. So this particular total mesocolic excision has been shown by various studies all over the world
to give a 5-year survival rate of more than 85%. Here we also land up doing D3 lymphadenectomy, as I have already pointed out, that we do take away the lymph nodes related to these major vessels. Now, combining CME with D3 lymphadenectomy has definitely improved the outcomes. Now, basic steps of this procedure remains the same, whether you do open or laparoscopy. My aim is not to showcase our laparoscopic or surgical skills. My aim is to make you understand what exactly it means. And I can tell you that if you keep on doing this procedure, you assist it few times, you can do it. It is not very difficult at all. So this is the demonstration of the various ports we use for right-sided mesocolic excision. The first port is in relation to umbilicus, which we usually use for putting a telescope connected to camera. The other two ports are on the left side. One is in the just below the costal margin in mid-clavicular line, and the other one is on the left side corresponding McBurney's point. You can use another port in the epigastric region, which might help you to retract the liver. And the other port is in the suprapubic region. They are shown slightly bigger in size because here we use usually 12 millimeter ports because we might be using endo-GI staplers, which will always go through this 12 millimeter port. Now, the first step of this procedure is in laparoscopic right hemicolectomy is to place the terminal ileum and cecum under tension. You are supposed to just hold the cecal area and pull it upwards and outwards so that the mesentery is put at traction, and this allows the identification of this inferior, ileocolic pedicle. And here, as the line, dotted line shows, this is a place where we would give a incision over the mesentery. Then medial to lateral dissection of mesentery off or away from the retroperitoneum, including duodenum and head of pancreas. This is the next major step. One is ligating the blood vessels quite close to their origin from major vessels. The second important part of this procedure is doing a medial to lateral dissection. As you do medial to lateral dissection at a slightly higher level, you will come across duodenum along with the head of the pancreas, which is supposed to be reflected medially. Now, this is a video which, as you see, this ileocolic trunk has been put on traction, and we have been holding the cecum and ascending colon upwards and outwards. This is ileocolic pedicle and superior mesenteric vessels on this side. So here, this mesentery will be opened gently. We are using energy device ultrasonic dissector, but you can use anything, even an electrocautery would work. As you keep on dissecting here, you will come across probably the junction of ileocolic with the superior mesenteric vein. And you will see the superior mesenteric vessels coursing in a cranial direction. Yes. Now here we start seeing this you can see the ileocolic vein entering the superior mesenteric vein. So and this traction is maintained till a later stage. Oh, I'm sorry. So once you have displayed the ileocholic vessel entering, you ligate artery and vein. There may be a bit of variation in relation of ileocholic vein and artery. Most of the time in this position, when patient is slightly with the right side up, you would definitely come across the artery first. Or at times, like in this particular video, you are seeing the vein first. So whatever it is, you ligate the vein, divide it. Here we have used the hemlock clips. You can use titanium clips or maybe suturing. Once you have done this, then you go along the superior mesenteric vein in a cranial direction, and then you try to identify, open the mesentery in at the slightly higher level, show or identify the duodenum, reflect the duodenum medially. I think this is the repetition. So you see this leaf of mesentery or the mesocolon which is being held, this entire thing will go along with the specimen, which you might not or one might not be doing while doing a conventional hemicolectomy. So now we are trying just to locate the artery, ileocholic artery. Otherwise, when you all must have seen and assisted or done hemicolectomies where we don't go that far off. So now the vein is being isolated, and now we'll apply the clips. This procedure do take care of, at times, metastatic deposits over the mesentery. Probably that is not taken care of by the AJCC classification. Here we are taking a lot of this mesentery along with the specimen which have lymph nodes. Definitely you will get more than 10 lymph nodes, but it also do take care of deposits here which otherwise might have been missed. So the vein has been divided and now the artery would be clipped. Now you are trying to develop a plane, that mesocolic plane. So far we have not touched the colon along the line of Tolt. It is still fixed, hanging from there. So as we dissect further, this length of superior mesenteric vein is being shown nicely. This is the ileocholic artery. Again, there are one or two variations of this procedure as well. Some people like to go slightly further to the left side towards the superior mesenteric artery as well. But here you see only the dissection being done till vein. This artery is being clipped. Usually artery is on the left side of the superior mesenteric vein. So this ileocolic artery is now clipped, divided. This is a mesocolic facial dissection. You would definitely see here the Gerota's fascia. Yes, now you can see duodenum, C loop of the duodenum. You are holding the colon up at the level of this hepatic flexure, and dissection is being done laterally, and duodenum reflected medially. You can also see the head of the pancreas. And now the next step would be to hold up the transverse colon and locate or try to locate the middle colic vessels, the their right and the left branches, and the right colic. Right colic usually or more commonly it arises separately, but at times it may be a branch of the middle colic or the right branch of middle colic. So as you keep on dissecting up, in between there is a slightly avascular plane, but as you go up, the first vessel you come across below this would be the right colic, which again is ligated and clipped and divided. And now here we will see the middle colic dividing into its left, right and left branches. Since we are dealing with the CA cecum, so we will just think of ligating the right branch of middle colic, not the left branch. I think in this video, what probably we saw it, but have not been demonstrated is the ureter. That should again be identified in the initial stages only. So transverse colon at the level of hepatic flexure and slightly distally has been lifted up. And this is a duodenum you see. And these energy devices have definitely made our life much easy. So some vessel is just becoming visible. So here goes the right branch of middle colic. You can see how much mesentery has been taken off. And now we have come above, now we are opening the lesser sac. We are dividing the greater omentum. Since we would be removing proximal 1/3 of the transverse colon, we have to create this plane. At times, some people, what they do is they open the greater omentum or lesser sac in the initial stage and they put a gauze piece here, so that when they start their caudal to cranial dissection, they will come across the gauze piece kept from above. So that indicates that that is an endpoint where they should stop cutting. So here we have divided the gastrocolic omentum, and we are separating this normal peritoneal attachments of this hepatic flexure of colon. And now we are coming laterally. So far we have not done anything along the lateral abdominal wall. Now it has been separated, and the next thing would be to divide. I think this vessel was left, right colic was left. It has been clipped and divided. Now the stapling device is being used to divide the distal ileum, which would be approximately around 6 to 10 centimeter. Once that has been done, it is left on you with your experience and facilities available, whether you want to do a intracorporeal anastomosis or you want to take out the divided ends of ileum and transverse colon and do the anastomosis. So basically the key points of this procedure, total mesocolic right hemicolectomy, would be that dissection is done from medial to lateral. We never go from lateral to medial side. Extent of dissection will definitely vary with the location of the tumor. This case particular was a CA cecum. The vessels are ligated as close as possible to the central vessels, central arteries. And this also includes, as I have pointed out earlier, extranodal deposits in the mesentery, which might otherwise be missed. So that is all about this thing. And I would suggest that whenever next time you come across a case where you are doing a hemicolectomy, particularly for malignancies, please step by step follow this procedure and try to do it. It is not a difficult procedure at all. Thank you.
So beautifully demonstrated and he made it slow and showed you each step very clearly. This you are discussing in the case on the right, electrosa lump. So you showed it, what exactly it was. So rather than talking about the elephant, show the elephant, four legs, one trunk, two big tusks, etc. This is the total mesocolic excision and beautifully demonstrated. Any question from anyone of you? You have any?
Very nice to you, sir. How did you, anything specific other than the position that you may have done to keep these small bowel out of the feet?
I think mainly it's when patient is with right side up, we place a sandbag and we tie the patients with the band. And we do have a nasogastric tube. We do have, yeah.
Second thing is that we saw that the colon was nicely held up.
And
so you have two assistants holding from these.
exactly. One assistant is holding the camera, the operating surgeon, and there is another assistant which will definitely hold the above. Yeah.
And do you remove the omentum from the transverse colon also in the beginning? One is that you create a space in the lesser side.
Okay.
And I think that you have a lot of momentum which is attached to transverse colon.
You do have to remove it. I mean, yes. Yeah. Another approach or variation, as I said before, was this was a caudal to cranial. It can be done from cranial to caudal direction also. In that way, the anatomy will be seen from the other side, but the rest of the things remains the same. And again, it is not a difficult procedure. Once you do it, I think we never went anywhere to learn it. We, along with my associates, all did it for the first time, but we realized that it is not difficult.
So, right, actually,
yeah.
you took the same steps as we do in open.
Open.
It kind of becomes an extension of that. And you then make it, even you reinforce it even further, that it's just a tool that you're talking about,
Yeah.
but surgery remains just.
Same.
Excellent talk, Professor Emmanuel. Thank you.
Thank
very
you.
much for this.
Thank you, sir. Thank you.
Give a big round of applause, please. So we had two wonderful demonstrations, both are important for you, and then in the exam. See, the interesting thing about this presentation, especially for me, was when you're watching the laparoscopic procedure, you're also able to say, this is how I'm going to do open. So the technique is just the same, the steps are just the same. And we go from center to outside centrifugal, because otherwise the colon will keep falling on your camera. So the technique is perfect. Both ways, you can do it open also this way. So thank you. So next we have a presentation by Dr. Sudipta Shah, which is I forced him each year to present the same, because the feedback every year we get for this technique is that we must see it. This is making an AV fistula where he covers up the anastomosis also beautifully. A big round of applause for Professor Sudipta Shah. The Professor of Surgery, Medicine, Academician, always a part of our course, and a very interesting talk and very important video. So please pay attention. What do you present?
Respected chairpersons, good afternoon. I thank Chintamani sir for giving me the opportunity to speak on a topic which I am very passionate about. Though this is not asked in the exams, but this is one important skill which one can learn, that is the microvascular surgery. So what in the next 10-12 minutes, what I'll be doing is that the basic preoperative thing which you should do before making an arteriovenous fistula, the operative video, and a little bit about the complication of the arteriovenous fistula. So fistula, as we know, this is a vascular access procedure which is done for the hemodialysis. So you need the veins to the blood to come out from one vein to go to the dialysis machine, and then you need to pump it back. So you need two punches on a vascular access site. So for the best procedure for that is to create an arteriovenous fistula. Now the side of the fistula, it should be in the non-dominant hand side where there are no central line has been placed, because the central line may cause the stenosis of the central vein, which will decrease the chances of the venous output which is going back. It may hamper it. Radial artery is always preferred over the brachial artery. The complication of the brachial artery fistulas are more than the radial artery. And of course, there is ulnar artery is also present. So if there is a complication, it can be easily managed. That is not the case with the brachial artery. And the vein that is chosen for the fistula, it will function if the diameter is more than 2.5 millimeter and the diameter of the artery is 2 millimeters. So that can be assessed by doing a preoperative Doppler study. Allen test has to be seen if you are making a radial artery fistula to see that the communication between the radial and ulnar artery is patent. And of course, these patients are on hemodialysis, so viral markers should be done. Now, this is important to know that how we choose the veins. So as I said, non-dominant hand, radial artery is preferred. And if you can see the cursor, the cephalic vein is on the side of the radial artery. So there are the many veins on the forearm which are on the medial side. Making fistulas on that will not solve the purpose. So you have to choose the cephalic vein, which is on the side of the radial artery. If it is present in the wrist, that is the best position. If it is not there, then you go to the forearm. You go to the proximal forearm, where the brachial artery has divided into the radial and the ulnar, and there sometimes the cephalic vein is patent, so you can make a fistula in the proximal forearm just below the cubital fossa. If that is not also available, then you have to go to the brachial artery. So for that, you have to choose the cephalic vein, which is on the lateral side. So you want the blood to go to the cephalic vein. If that cephalic vein is also not present, then you choose the basilic vein, which is on the medial side. Now the basilic vein, the problem with the basilic vein is that here you can see that the subcutaneous course of the basilic vein is very short. It is only 4-5 centimeter. So if you have to choose this for making the punctures, then very short segment of vein will be available. So if basilic vein is used, then the second procedure needs to be done 1.5 months after the surgery to superficialize this basilic vein from below the fascia to upwards. So to summarize, you have to use the cephalic vein. If it is available in the wrist, very well. If it is not available there, go to the proximal forearm. If that is not also there, then brachiocephalic. If that is also not there, then brachiobasilic fistula. Now, if you before the surgery, you tie a tourniquet in the upper arm and make the veins distant, and then you palpate and see whether the veins are available or not. If there is a doubt, then of course, then you have to do the Doppler study to assess the veins. And then on the this side of the photograph, you have seen that we have done the Doppler, and then we have marked the vein by using mehendi. So when the radiologist colleagues have seen the vein, and then we mark the site of the vein, so that during the operation we don't hunt for the vein. We should know before giving the incision where the vein is present, so that we can directly reach over there. So it is not that we try to open the area, then try to find the vein. It doesn't work that way. So the site of the vein should be marked before you give the incision. Now this is a vascular set you require. You require a magnification. For that you require the loop, and then you require the vascular set where you should have the vascular forceps. You should have a pot scissors, the angled scissors, and should have the bulldogs. So the vascular set is required for making the arteriovenous fistulas. Now, the basic principle of the surgery is that the vessels has to be handled gently, and they should be used vascular loops or the feeding tubes as we use it for handling the vessels. The sides branches of the veins and the arteries are to be ligated so that can be mobilized adequately so that they come near each other without any tension. For exposing the artery, we have to incise the fascia. Artery lies below the fascia. These veins, cephalic veins and basilic vein, they lie above the fascia. There are always the deep veins which accompany the artery. So when you are isolating the artery, there may be chance that you injure those veins that will cause bleeding. So that one has to be careful about. And of course, there should be sufficient mobilization so that there should not be any tension. Now the anastomosis that we do is that either it can be end of the vein to the side of the artery. So you cut the vein and you anastomose to the side opening of the artery. But that is little difficult. So easier one is to open the vein, open the artery and anastomose side by side. That is much easier procedure. And it has been seen that the results of a side-to-side anastomosis are equally good as a end-to-side anastomosis. After finishing the anastomosis, one can tie the end of the vein, making it as a functional end-to-side anastomosis. The site of the anastomosis should be about 7 mm in the radial artery and 5 mm in the brachial artery. We make a smaller anastomosis in the brachial artery. We don't want the blood to go completely from the artery to the vein. That will cause the ischemia, especially in the brachial artery anastomosis. And then you require a 6-0 polypropylene suture, which has needle on both the ends. So this is the suture which you required for making the arteriovenous fistula. The important thing is that it has got 2 needles which are attached to both the ends. So as I show in the video, this 2 needles is very essential for making the anastomosis. So we use a monofilament sutures for doing all kind of vascular and arterial suturing. So what I'll be showing is a short video on a proximal radiocephalic arteriovenous fistula. So here, to make you orient, this side is the head end of the patient. This is the arm. This is the wrist end of the patient. So we have given an incision just below the cubital fossa, vertical incision, so as to expose the radial artery, where the brachial artery has divided already into the radial artery, the proximal radial artery, and the cephalic vein. So this is the cephalic vein, and this is the median cubital vein. So after exposing the vein, then we incise the fascia. When we have to expose the artery, we have to incise the fascia, and below the fascia where we are finding the pulsation, we go directly there and try to expose the artery. So as I've said earlier, the arteries are always accompanied by the veins. There are 2 veins on the side of the arteries, and these veins should be carefully preserved. And we should not separate these veins from the arteries and isolate the arteries separate from this and try to not injure this. That will cause unnecessary bleeding. So after we have exposed the artery, we have exposed the vein, then we loop the artery and vein with a vascular loop, or we use a feeding tube. A gloves can also be used. The idea is it should be gentle. And then here we put the artery and vein together in one feeding tube, the other end with the other feeding tube, and we bring them together. And we see that these should come without any tension. If there is, you feel that there is a tension, if it is possible to mobilize, you mobilize. Otherwise, you change it to an end-to side arteriovenous fistula. So after that, you apply the bulldog clamps, proximal and distal, so that when you are making the arteriotomy, venotomy, there should not be any blood which is coming out from the incision. So after that is done, then you have to make an venotomy and arteriotomy. So the size of the arteriotomy and venotomy that is usually made is from 5 millimeters to 7 millimeters. So you use a number 15 blade and make an opening into the vein, and then you use a pot scissors to open that venotomy to the whatever desired length you want to do. Now here important thing is that while you are making this arteriotomy or venotomy, that the posterior wall that should not be injured. The intima of the posterior wall should not be injured. If you injure the intima of the posterior wall, then it will become weak, and then it will lead to the formation of the pseudoaneurysm. So similarly, where you have made a venotomy corresponding to the same site and of the same size, you made an arteriotomy. Here you see that if the blood comes, the best way is that you use a syringe and with a needle hub which has been broken, and you just flush the blood with it, so that the area where you are operating, that is well visualized. So that is the one thing which is done in the vascular surgery, is that if you want to remove the blood, you just flush it with the saline. And then you start suturing. Now the thing is that there are the wall of the vein and artery which are near to each other, that has to be sutured first. That will make the posterior layer of the anastomosis. And the wall of the venotomy, arteriotomy, which are away from each other, that is sutured in the second layer. That will form the anterior layer of the anastomosis. So you start from one end. You start from the one end to the walls of the vein and artery which are near to each other, and you finish the posterior layer first. Then you go up, come to the anterior layer on one side, you leave the suture there, and you pick up the other side of the needle which you have left earlier. Then you come from the upper, the anterior part. So the idea is that the corners of the anastomosis are the most important one. The important one and the difficult ones are the corners. So you have to be careful there. So they has to be taken first. So here you go from the inside of the vein to the outside of the vein, and from outside of the artery to the inside of the artery. So from one side, you start doing it. You start from the one angle, from the lower side, and then you finish the whole suturing and come to the anterior side. Now, when you are doing this suturing, one has to be careful that first thing is that you should not hold the intima with the forceps. If you hold the intima with the forceps, then it will injure it and it will lead to the formation of the thrombus. So what you are going to hold is to just the adventitia of the vein, or you can use the forceps and you put it in the opening and open it so that you can able to take the sutures. The first complete no is that no handling of the intima. Second is that when you are taking the sutures, the next principle is that you have to always take the intima. Intima is to be taken. If you don't take the intima, then there will be formation of the pseudoaneurysms. The third thing is that the adventitia should not come into the anastomosis. They should not come inside the anastomosis, because that is thrombogenic. If that comes in, then it will lead to the formation of the thrombus. It's a continuous suturing. It's a continuous suturing, and it's about a millimeter apart. So it was just a half millimeter apart from the edge and about 1 millimeter between the sutures. So you keep taking the suture in the same side, inside of the vein to the outside of the vein, outside of the artery to the inside of the artery. You do this and you come out to the one side. So you start from the one corner and you do the anterior, come out of the anterior layer on the other side, and then you take the suture on the other side and then start suturing from the other side. So you make the posterior layer first and then the anterior layer of the anastomosis. And then when you are at the corner, then important thing is that you should not take the posterior layer along with the sutures. So posterior layer has not to be taken. So to avoid that, you can just put a vascular dilator or a cannula to open up the opening so that your suture doesn't take the posterior layer. So when the sutures are come both to the middle part of the anatomy, you're not going to put the knots at the corners. The knots are put at the center. So when the suture have come, both sutures have come in the center, then you tie the knot. And the knots that is taken, as with any other monofilament sutures, you put 6 knots. Put 6 knots, and then you release the clamps. And after releasing the clamps, there will be bleeding there. So when you release the clamp, there will be little amount of the bleeding will be there. Even if there is a perfect suturing done, there will be little amount of bleeding. So one has to be patient. Put gentle pressure there, and this oozing is going to stop. 2-3 minutes one has to give so that the platelet plug forms, and then this oozing is stopped. The another thing is that when you can just sprinkle little amount of piperine after you have finished the anastomosis, that will relieve the spasm which can occur into the artery and the vein, and that may result in the functional fistula. When we say intraoperative that it's a functional, is that when we get the thrill. So just after when you have released the clamps, you should be able to feel the thrill. If the thrill is not present, then there is a high likelihood that this fistula is not going to be functional. Even if the thrill is there, there is a chance that this fistula is not going to be mature. But if the thrill is not there, then it is very unlikely that this fistula will be functional. Now, for the brachial cephalic fistula, the principles are just the same. You have to put in the brachial artery, cephalic artery, make a arteriotomy, venotomy, and suture it. Only thing is that this suturing the arteriotomy and venotomy is much lesser. It will be 3 millimeters to 5 millimeters. So after completion of the anastomosis, one can sprinkle the piperine, give gentle pressure. All bleeding is going to stop with patience. Tie the distal end of the vein, ensure adequate hemostasis. There should not be any bleeding. Before you suture the skin, there should not be any bleeding. Check for the distal capillary filling and pulsation. That is very important. Before you close the skin, check for the radial artery and the capillary refilling time. They should be normal. If there is a doubt, then you clear it. Sometimes the whole of the blood gets passed to the vein. If that is the case, you feel that the distal part is not adequately vascularized, then you take down the suture, the fistula. You ligate the fistula on both above and below the anastomosis so that the limb has to be saved. Post-operatively, patient has to be observed for 3 to 4 hours. These are done as a day care surgery. Pulsation and capillary refilling time should be checked before sending the patient homes. They require analgesic and antibiotics. They have to be followed up after 48 hours to see whether the fistula is functioning. There is thrill, there is no hematoma, there is no bleeding, no infection. Sutures are removed little longer, 2 weeks, because the healing is not very good in the patient who have got renal failure. And these fistulas are to be used only after 1.5 months after making. So the veins requires this much time to get adequately thickened up and the flow to increase, and they are to be used cannulated only after 1.5 months. Complication is that there can be failure. 80% to 90% success rate is there, and that too every year these fistulas are known to fail. There can be vascular steal. The arterial supply to the distal is not complete. There can be ischemia. There can be pseudoaneurysm. The blood leaks between the anastomosis and they can form a clot and it result into the pseudoaneurysm. There can be bleeding. There can be rupture. So these are the all complications that can happen. There can be aneurysmal dilatation. And here one of the things that happen is that the central vein, there is stenosis or there is a thrombus there, and the blood is not able to go. So whatever the increase in the venous flow that has happened, does not reaches the heart. So the limb gets swollen. In that scenario, then you have to close that fistula. And here we have done a vascular graft. And then we realized that after doing a vascular graft between the axillary artery and the cephalic vein, the limb has gone swollen. So probably she had a long-term catheter present in the neck, which has resulted into the stenosis. And then we have to take the graft out. This is the aneurysmal dilation. You see that this is the vein. This is the diameter of the vein, which has occurred after 5 years of the dialysis. And the skin, the puncture mark, they keep using the same puncture site and the skin may get thinned out there. So they have to be told that if you use at this point, then there is a high chance that this skin is going to rupture and there's going to be bleeding. So this is a boy which we have done the arteriovenous fistula, 8 years boy. So in the end, I'll like to say that the vascular suturing skills are essential for a general surgeon. So you are in a practice as a general surgeon, your likelihood to have some injury into the vessels while operating in the abdomen, you may require to suture it. And in the trauma patients, here you are not able to find the person, a vascular surgeon or a trauma surgeon, to do the anastomosis. So basic vascular surgery suturing everyone should know, and the opportunities are limited. And there are a large number of patients who required arteriovenous fistula for end-stage renal disease. So it's a win-win situation for everyone. We can train the students and the patients can get benefited. Arteriovenous fistula provides excellent opportunity for vascular training. And this is one of the paper which we have published, which says that the residents which make the arteriovenous fistula, of course on supervision, they have the similar result as what a consultant does. In our unit, most of the fistulas are made by our residents. So thank you so much. I again thank Chintamani sir for giving me this opportunity. Thanks.
We so much to take home from just one presentation, so much teaching in it. I think it covered up so many aspects of it. Thank you so much, Dr. Sudhir.
Thank you so much.
Any question from the students? Any clarification? Can't make more question, but you can learn more if you want to. Dr. Ratnatha. Dr. Sanjay.
Thank you, Dr. Sudhir. That was a nice demonstration. Basically, the vascular anastomosis is one thing, which I think every general surgeon must be doing. These are the things, whether you use it or not, when it will be required. So that's a nice thing. I hope this will pick up the implications of this. Thank you.
Thank you so much, sir.
Brilliant, actually, and made so simple. Thank you so much, Dr. Sudhir. Now, we will immediately get into the off-key sections now. The first one is what we missed out because Dr. Sao was missing his slide that day. That is varicose veins, off-key for that, and maybe examination of it. Following that is all Dr. Gyan and Dr. Sumit will teach us about the X-rays and MRIs, CTs that we get in the examination. And believe me, we kept the best for the last. That is very, very useful and very effective. Both of them will make it very, very useful for all of you. So pay attention, be awake. We'll serve you coffee or tea in between, don't worry. So Dr. Shah, are you able to hear us?
Sir, your sound is coming very low. Am I audible?
You are audible, your sound is quite loud. And I think there's some issue with our volume. Can you do something about it, Harsh? But you're loud and clear, so Dr. Shah, you can start.
Am I audible?
You are audible.
Yes. Can I start?
Please start.
Okay. Good afternoon. I am going to demonstrate a video session on how to examine a patient of varicose vein. I am skipping the history part. So you have this history part in your book. You can go through what history you should take. I'm just going to the examination where I will be examining the both lower limbs. As I said in arterial examination, when you examine patient having a arterial disease or venous disease, our heading will be examination of both lower limbs. Patient is standing with his legs side by side. First of all, you notice about any attitude and deformity of the limb. And patient with varicose vein may have some deformity, like some patient of long-standing varicose vein may have equinus deformity. And then while examining for a patient of varicose vein, you have to have an idea about the surface marking of the great saphenous vein and the short saphenous vein. Whatever vein you see in the leg, all are not great saphenous and short saphenous trunk. You have to know the anatomical course of great saphenous. Then you can say that this part of the great saphenous vein trunk is affected and whatever you see on either side are the tributaries. And you have to describe which venous system is affected, what you are seeing to be varicose. Then look at the skin of the leg. There can be some skin changes which are on the markers of varicose vein. And you describe the skin changes looking at the patient. And then ask the patient, expose the region of saphenous opening and ask the patient to cough. There may be an impulse at the site of saphenous opening. We call that the Morris's test. So how do you do the examination? You ask the patient to stand and you remain seated by the side of the patient. Look at the patient. The normal attitude of the limb is ankle is 90 degree, knee and hip are straight. And some patient of varicose vein, which are because of arteriovenous fistula, may have disparity of the limb. There may be local gigantism. So you just inspect the limb, and what you do, you just remain on the side of the patient. Video. Yeah. So you look at the patient. Look from front. See the extent of varicosity. Then you have to look at the patient from the side also and back. And you comment about which veins are affected. The trunk of the great saphenous, is it the trunk of the short saphenous, or there are some other tributaries which are affected. So you have to look from the front to look at the great saphenous trunk, you look from the side to look for the tributaries, and look from the back to comment about the short saphenous vein. So you sit in front of the patient and look from the front. This is the trunk of great saphenous vein. You can look which is coming from the leg and then going up in the medial aspect of the thigh. Then look at the side for any tributaries which might be varicose. Ask the patient to turn around and look at the back. The short saphenous vein lies at the back of the leg and it is in relation to the posterior aspect of the medial malleolus and it ends on the popliteal fossa. Then, as I said, the next part to examine is the skin of the leg. There may be some skin changes in a patient who has got a varicose vein. There may be just dark pigmentation. And if you have the pigmentation, you look at how far the pigmentation is present up to the dorsum of the foot or extending up to the leg. There might be some eczematous skin changes in the skin around the ankle, or you may find a healed ulcer, or you may find in a particular patient a active ulcer. So if you have an ulcer, you have to describe that ulcer. So the next part will be, you look at the ulcer, just inspection. So you look at the ulcer. You see this patient has got black pigmentation in the dorsum of the foot extending under the mid leg. And there is an active ulcer with some oozing from the surface. So you have to inspect the ulcer and describe the ulcer as you describe in other sites. And as I said, at the end of inspection, you expose the area of saphenous opening, ask the patient to cough. Patient who has got gross varicosities, in mild varicosities, you cannot appreciate this impulse at the saphenous opening. So you expose the region of saphenous opening and ask the patient to cough. In gross varicosities, you can make out a expansile impulsal cough in the saphenous opening area. We call that as a Morris's test as positive. Then come to the palpation. And as I said, the palpation again will be the palpation of both lower lips. Patient having arteriovenous fistula or some so examine for the temperature. There might be associated thrombophlebitis of this varicose vein. So palpate along the course of the vein. Once you have done these two tests, there are some tests that's to be done in a patient who's got a varicose vein, which is to be done clinically, like Trendelenburg test, Soares test, Figan's test, modified Perthes test. And then if the patient has got an ulcer, you have to examine for the ulcer. And any patient with varicose vein may have associated arterial disease. So you have to palpate all the peripheral pulses. So how do you do the temperature? That we have demonstrated in arterial system examination. So or you start palpating from the dorsum of the foot and go up. Patient having arteriovenous malformation or patient having arterial fistula may have increased temperature in the affected leg. So examine for the temperature. Then press along. You know the surface marking of the vein now, and you press along the course of the vein. Look for any cord-like filling. Look for any cord-like filling in the vein or any tenderness in the vein. Varicose vein. To do this test properly, in the exam, you'll be asked to demonstrate the Penile buck test. So in that case, don't jump and tie a tunicate. In that case, you have to follow some steps to do the Penile buck test. First, you have to mark the saphenous opening. Where is the saphenous opening? You have to first mark the pubic tubercle. You adduct the leg against resistance and follow the tendon of aorta longus. This tendon takes you to pubic tubercle. Mark the pubic tubercle. Measure a distance of 3.8 centimeter below and lateral to the pubic tubercle. That is the point of saphenous opening, which is the termination of great saphenous vein to the femoral vein, which is described as the largest perforator. So that is how you adduct the leg and find that taut aorta longus. You go up and find the pubic tubercle. Mark the pubic tubercle. Once you mark the pubic tubercle, from pubic tubercle, you go 3.8 centimeter lateral and below. These are 3.8 centimeter and below that point. That is saphenous. Idea of marking saphenous opening is when you are doing Penile buck test, you have to tie the tunicate below the saphenous opening. If you tie higher up, then your occlusion will be imperfect. So that is the idea. So you can do the test in one go. You can describe the Penile buck test one go, where you keep the tunicate tied and observe the venous filling and then release. Or there are another ways of doing the test. I will demonstrate the two tests separately. So the first part of the test is, how do you do the Penile buck test? You ask the patient to lie down, elevate the limb, meet the vein empty, and we have already marked the saphenous opening. Tie it to the saphenous opening. Ask the patient to stand, and on standing, release the tunicate immediately and look for any venous filling from above. If there is venous filling above, we take that test as positive, and our inference is SFJ is incompetent. So elevate the leg, meet the vein. We have already marked the saphenous opening by taking the pubic tubercle as a marker point. So you empty the vein and take a tunicate. And we are now tying the tunicate below the saphenous opening marking. And it is below the saphenous opening. You ask the patient to stand and release the tunicate immediately. There is quick filling of vein from above. Once you find there is quick filling of a vein from above, we say that the test is positive, and the inference is the SFJ is incompetent. The next part of the test is, you can do the test without releasing the tunicate. Again, ask the patient to lie down, empty the vein, tie the tunicate, and ask the patient to stand up and release. Keep the tunicate on. Now, if you keep the tunicate on and there is slow filling of vein from below, that indicate again the test is positive. And now the inference is, this test is positive now because of some perforating incompetence below the SH. So this you keep the tunicate on, not releasing, of about 30 seconds, 40 seconds. So from below slowly, that indicate that test is positive. Last time you released the tunicate, it was filling immediately. You see, now the veins are getting full in the leg. With the tunicate on, there is some filling of vein from below. So the inference is the test is positive, and this is because of some perforating incompetence below the SFJ. Now, if the veins are big, you release it now. So these two states can be combined where you tie tunicate, ask the patient to stand, the tunicate on. If the veins are seen from below, we infer that some perforated below is incompetent. Once you have done that, you now release. See, on reading, there is further healing from above. You can say that this is positive. If you are smart enough, do the test in same go. You tell the examiner, sir, I have done above test. The test is positive. What is the inference? Tunicate on. There was filling of vein from below, suggesting there was some perfect incompetence below the SFJ. And on releasing the tunicate, there is further filling from above, suggesting that the SFJ is incompetent. Next, with advent of this Doppler study, marking this individual perforator is not very important by doing a two tunicate test, but this test is also described where you can localize the perforator incompetence by tying two tunicate, one above and one below the perforator, and asking the patient to stand. To do this, you have to first mark the perforators. So how do you mark the perforator? The largest perforator you say it is a termination. Next, you mark the adult canal. You measure the thigh from antecipulate spine up to the joint level. The middle third of the distance is the canal, and the is the side for the canal. Find the joint line. A point just above the joint line is a above knee perforator. A perforator just below the knee is a below knee perforator. And come to the middle malleolus. 5, 10, 15 centimeters from middle malleolus at the 3 fixed. These keep in mind perforator. There are some inconstant perforators. You have perforators. The largest perforator marks the saphenophyseal junction, adult canal perforator, above knee perforator, below knee perforator, 5, 10, 15 centimeter perforator. So you have to empty the vein again, and then you have already marked the saphenous below the saphenous opening, above the perforator. That means already marked the canal region. So now there are two techniques. Isolating with these two techniques. So now the inference will be the test is positive and the incompetent, but there is no filling of the vein. We infer that the adult canal perforator is competent. The test is negative. Similarly, all the perforator can be tested by this. Next is SWOT test. It's very simple test. You ask the patient to stand. The vein is full. You put one finger at the sacral vein and then tap the dilated vein below. Normally, if you do this tapping in normal, the impulse generated lower down get dampened by the competent valves. You don't feel anything in the hand kept in the saphenous opening. Patient who has got a varicosity, there is a static column of blood because of peripheral incompetence and this valvular incompetence. There is static column of blood from ankle up the saphenous opening. Now you can feel this tapping the wave in the saphenous opening. So that is how you do the SWOT test. You keep your hand in the saphenous opening and tap the vein below. You can feel this tapping impulse in the. So that is described as SWOT test. Next is Higgins test. What is Higgins test? There are some veins in the leg where you have a superficial vein and the deep vein. And these veins are communicated by the perforator veins, which are fine veins. These veins pierce the deep fascia and go into the deep veins. And these perforator veins are snugly fitting into the deep fascia. When there is incompetence, there is reflux of blood from the deep to the superficial vein. This perforator veins gets dilated. This dilated perforator vein stretches the deep fascia, and there is a large gap in the deep fascia at the site of perforator incompetence. So to do the Higgins test, The first part of the test is you have to mark the varicose vein, which are ankle region up to the thigh. You mark the varicose vein by using a skin marker pen. So that is how you do it. You mark the trunk of the vein, and we have already marked the site of perforators. So you mark the perforator, and mark the perforator. We now will ask the patient to lie down. You ask the patient. So that is up to the saphenous opening. That is the whole course. So on lying down, you lift the leg, empty the vein, and at the site of perforator, if you feel there is a crescentic gap, you can find out, yes, there is a incompetent perforator at this level. Here also below the knee there is a crescentic gap. So that is what is Figan's test. Then there is another test which is a clinical test to assess the patency of the deep veins. This has modified test. What you do is you ask the patient to stand. The veins are full. You tie a tourniquet below the saphenous opening and ask the patient to walk briskly for about 2 minutes. Ask him to stand. Observe the veins. In a patient who has got a patent deep vein system, will get collapsed. We say that modified Perthes test is negative, suggesting that deep veins are patent. If deep veins are blocked, because of walking, there is more blood coming to the limb. The blood cannot go back via the deep veins because of the veins are occluded, and we have kept the superficial vein occluded at the saphenous opening. So patient will have distension of vein which are more, and patient have bursting pain. So that is how you do the Perthes test. So veins are full. You tie a tourniquet with the veins being full. You tie a tourniquet below the saphenous opening because we want to occlude the largest perforator. And ask the patient to walk briskly. You see, you can observe that the veins has collapsed. That is negative. Then in the palpation, this patient has got deep ulcer. So you have to palpate. So I'm not going to the ulcer, that is usual for other ulcer. So on palpation, you have to look for it, find any and palpate the ulcer, try to move it and comment whether the base of the ulcer is indurated or fixed to the underlying bone or not. So this is how you examine for the ulcer. And then, as I said, in a patient who has got a venous disease, you have to look for the arterial pulses. Patient may have arterial disease. I'm not going to this because I have demonstrated the palpation of these peripheral pulses in my arterial disease examination. So that I conclude the examination for the peripheral arterial disease. And patient who has got varicosity, if this is secondary to a arteriovenous malformation or because arterial fistula, he can hear a audible bruit by auscultating along the course of the vein. So auscultate along the course of vein to assess for any bruit. In a patient has got a simple primary varicosity, the bruit is usually not audible. So you have to auscultate along the course of the vein and look for any bruit along the course of the artery. And the CC examination. Okay, thank you. Any question from this clinical examination?
Thank you so much. Thank you very much, Dr. Shah. That was wonderful. And I think we can move on to Oski. If there are any questions, you can let me know. I'll pass on because our voice is not.
Okay, fine. Fine. So Oski, actually, this would have been better that I am physically present. So one boy could have come. But what I decided is, you see, Oski is a very important part of DNB.
Just 1 minute, I'll get one person. For X-rays also we require them. Terry, you come.
Okay.
And the lady yesterday. Yes, third.
You see, keep in mind that in Oski, you are not supposed to write a paragraph. Oski is a very focused examination. You have to write specifically 1 or 2 liner answer, and that has to be very specific. So some of this video will be repetitive. I have shown you just now. So just answer as it goes in OSCE. So I give a scenario. This is a 45-year-old gentleman who presented with swelling along the medial aspect of the right leg and thigh for last 2 years. The swelling started around the ankle and extended upwards up to the middle of thigh. There are multiple swellings in the outer aspect of the leg. The swelling gets aggravated during walking and standing and reduces completely on lying down position. So this is a picture of this patient where I have described the swelling. There are some swelling along the medial side, and apart from this, there are some multiple swellings in the leg and also on the thigh. So I ask you, as part of OSCE examination, what is the likely diagnosis in this patient? Can you give the answer?
Camera here now. Camera can come on there.
Yeah. What is the likely diagnosis?
So the likely diagnosis is varicose, patient has varicose veins.
But you see, I said OSCE is a very specific question. If you just say varicose vein, the answer will not be complete. You see the vein. You have a dilated vein along the great saphenous trunk.
Varicose veins of right leg involving the
And also you have some veins on the legs. So the correct answer should be, this is a varicose vein involving the great saphenous system vein along with the varicosities of some tributaries in the right lower limb. Okay. This is a OSCE question. In this patient, what in past history may be relevant?
history of any immobilization, history of any previous
Yes.
surgeries, history
Yes.
of disability, any coagulopathies present.
Any?
Coagulopathies, previous history of any surgery or any immobilization for more than 3 days. Any orthopedic.
And he should ask some questions to find out whether the patient has got any history of deep vein thrombosis. So what are the symptoms patient may have, you ask, and then you can assume that yes, this symptom might be the history of deep vein thrombosis. What symptom patient may have?
After some time.
What symptom patient may have if the patient has got a deep vein thrombosis because of immobilization earlier?
Patient will be telling of complaining of pain after walking for some time.
Yes, pain,
And also patient
pain,
will give any
swelling, patient may have fever, patient may have fever. And if you examine the patient, you see this is answer. Any history of prolonged immolation in the bed, any history of deep vein thrombosis, which may be a pain and swelling in the leg, history of fever, patient may complain of sudden appearance of dilated veins in the lower leg. Okay, so these are the importance of the past history. So this patient, you see some small dilated veins in the thigh area. What is this vein described as?
These are the spider veins, the telangiectatic veins present in the thigh. And saphenous
got such varicosities, we call that as reticular varices.
reticular veins.
These are reticular varices. Okay, there is a term we often describe as saphenopharynx. What is saphenopharynx?
This is the incompetency of the great saphenofemoral junction seen on cuffing. We'll ask the patient to cuff and we'll see the incompetence of the saphenofemoral.
Yes. So saphenopharynx is the dilatation of the terminal part of the great saphenous vein. Dilatation terminal part, where if the patient asks the patient to cough, you can have a palpable impulse on cough at the groin. You see the lower picture. There are these are the manifestations of vena hypertension in the leg. Lower picture. There are a number of findings in the lower picture which are suggestive of chronic venous hypertension.
So you can see an active ulcer and the greater area of the left foot.
Yes. So there is an active ulcer, and apart from that, you find the pigmentation.
And the pigmentation.
You find there are some eczematous changes around the ulcer. So these are the features of venous hypertension in the leg. Okay. The features of venous hypertension in the leg. Okay. I have described this. What are the cardinal features of deep vein thrombosis? We have discussed that. So patient may have pain and swelling in the cuff, fever. Patient may have chest pain, hemoptysis, rednesses if there is associated embolism. And examination in the leg may reveal swelling in the leg, calf tenderness, and some signs are not to be demonstrated but described. Okay, observe this test. Observe this test being done. This video will run and then I ask some question. On keeping the tourniquet on, there is slow filling of vein from below. The question is, what is the interpretation of what is being done?
Perforated incompetence is seen, Trendelenburg test too.
What is the observation you're looking at in this patient? What is the observation?
There is slow filling of the veins seen, which means the perforated incompetence.
Then what I've shown first is on keeping the tourniquet on, there was slow filling of the vein from below, and on release, there is further filling of vein from above. The interpretation of the test is positive, positive. What does the first positive stands for?
Sensory incompetence.
No, first positive. Tourniquet was on. The tourniquet was on. The first positive is because of some perforated incompetence below the SFJ. And second positive is on release of tourniquet, there is further filling. So okay. So this is a Trendelenburg test being done, and keeping the tourniquet, there is slow filling of vein from below, suggesting that there is some perforated incompetence below the SFJ. And on release of the tourniquet, there is further filling from above. Okay. You observe this test. Patient is standing with the veins being full. He is asked to walk down, and on stopping, I find the vein has collapsed. What is this test? Modified Perthes test. What is the interpretation? The vein has collapsed. What is the interpretation of this test?
They all answering you.
Deep veins are
On asking to walk, tourniquet on, the vein has collapsed. So test is positive or negative?
negative, and there is no obstruction in the deep veins.
Yes, good. So the deep veins are patent. Can you explain? In spite of perforated incompetence, why this vein has collapsed? In spite of perforated incompetence, why the vein has collapsed on walking?
The communicating veins present between the superficial and the deep system, the blood from the superficial system entered into the deep system, and there is collapse of the veins seen.
What happens during walking? The calf pump starts working. As the calf muscle squeezes, there is rise of deep venous pressure to the tune of 200 to 300 millimeters of mercury. That pushes the blood up. In spite of perforated incompetence, the blood is sucked in from soil to the deep system. So that is the explanation for this Perthes test. What is this test being done?
Pregon's test palpation for the defect in the perforator.
The test is positive. What is this test?
Pregon's test to palpate the defect in the perforator.
That is Figgins. What is this? You have lower leg and
this is Schwartz test to see the continuity of the blood column.
Why in varicose vein Schwartz test become positive? What is the explanation?
Because there is a perforated incompetence, we can see a continuous column of blood present.
Yes. So if the normal valves are there, you tap, this impulse get dampened by series of valves. In incompetent perforators, the valves are incompetent and there is a continuous long column of blood. Varicose vein. What does the CEAP stands for? C stands for?
E for clinical, E for etiology, A for anatomy, and P for pathology of the varicose veins.
Good. So you should be knowing this CEAP classification. C is C, C0 is no apparent disease, C1 in telangiectasia or reticular veins, C2 is varicose vein, C3 is presence of edema, C4 are skin changes, which can be either a C4A, C4B, C5 is healed ulcer, C6 is active ulcer. Etiology, it can be either congenital, primary or secondary. And anatomically, it may be either involved a superficial vein or deep veins or a combination, or pathology classification may be either reflux or obstruction. This is a very common test we do even in the bedside. What is this test being done in the bedside for patient having varicosity?
Doppler investigation of SFJ to see whether there is reflux or obstruction at the cephaloperoneal junction.
This is what?
Doppler.
This is what? Which test is being done at the bedside? This is the examination with the handheld Doppler. This is the examination by using handheld Doppler. Okay. If you take this Doppler study, can you describe the characteristics of venous flow in a normal person? If you place the probe over the deep vein, what is the characteristics of a normal venous flow in a normal person?
Triphasic flow.
No. Triphasic arterial flow. Venous flow is not triphasic.
Biphasic.
If you place the probe over the vein, what do you find? You have a visa targo which takes the blood through the vein. So you can demonstrate the venous flow in the vein by using color coding number 1. What happens if you press the probe over the vein in a normal person? You press the probe over the vein. What happens in the vein wall?
Wall collapses.
Collapses is described as compressibility. So if you press the probe over the vein, the two vein meets. The normal is a thrombus in between. The compressibility is lost. If there is a thrombus inside the vein, the compressibility is lost. As a patient took a deep and take an expiration, what change may occur in the vein flow? You keep the probe over the deep vein, ask the patient to take a deep breath, inspiration, and then expiration. Will there be any change in a normal person?
Yes.
Flow will increase.
In inspiration, there is negative intrathoracic pressure. In inspiration, there is negative intrathoracic pressure. So the venous flow will increase during inspiration. And during expiration, this flow will get dampened. This is normal characteristics of the venous flow in a patient who has got. So the normal venous flow appears blue. The normal veins are compressible. And there is a phasic variation in venous flow with respiration. This is a typical sign the sonologists demonstrate. What is this sign called as? And what are the three vessels seen?
They're all shouting here.
This is described as Mickey Mouse sign. And you find these are the three vessels which show this Mickey Mouse sign. When you do a laser ablation of this vein, where do you keep the tip of the catheter in relation to this SFJ? When you are doing laser ablation of this great saphenous vein, where the tip of the catheter should be sighted in relation to the Mickey Mouse sign? Would you keep at the junction like you do open surgery? The tip of the probe should 2.5 centimeter below the SLJ, because otherwise, as you pass the energy, it may cause occlusion of the deep vein. Okay. The answer has come here. So, what are the important causes of secondary varicose vein? You see, the answer is here. It can be deep vein thrombosis, it can be arteriovenous fistula, it can be pelvic mass, or it can be pregnancy or intravenous thrombus in Bariatric syndrome. So, these are the important causes of secondary varicose vein. You see this operation. Yeah. You see this operation. A incision is made. Three important vessels there, and then do a flush SFJ. So what is this operation being done? This is Penile operation.
Yes, spoken, Dr. Shah, they have answered that.
Ligation of the tributaries to be done. Superficial circumference iliac, superficial epigastric, so okay.
Superficial epigastric, superficial.
Doing Penile operation, why ligation is important? Lead to the first ligation, not anything beyond the SFJ. Why you need to do a first ligation?
Because it needs to the varicosities later on. If we won't flush ligate later on at the cut in. So
if you ligate beyond, you are leaving behind a segmental part of great saphenous, and the incumbent valve will be there. So if you ligate away from that, this may result in a saphenovarix. Okay, so in that case, in a Penile operation, you should always try to ligate flush the.
Right, are we done, Dr. Shah?
Yeah. Two more. What is this instrument shown? What is the instrument shown?
Myers stripper.
This is Myers stripper. Myers varicose vein stripper. If you see this vein, I have labeled one important vein in the leg parallel to the great saphenous vein. What is that vein? In the leg. In the leg parallel to the great saphenous vein, there is another vein running. What is that vein?
Short saphenous vein.
No. Is going ending in the great saphenous vein. You see, this is described as posterior arch vein, which is a very prominent vein running parallel to the great saphenous vein. This is posterior arch vein. Okay. What are the different system of veins in the lower leg? Deep vein, superficial veins, and the perforator veins. Okay. These are the sites of important perforators. What is microsclerotherapy?
We'll inject the.
What is microsclerotherapy?
We'll inject the sclerosins into the veins. We'll use one is to.
Microsclerotherapy is done for reticular varices, where you inject only 0.1 ml of sclerosant, diluted sclerosant solution. So that is described as microsclerotherapy. This is a straight question. Can the main trunk of varicose vein be amenable to sclerotherapy?
Yes, sir. After emptying the vein, we can do sclerotherapy even in the main trunk. But after
main trunk. Can the main trunk be treated by sclerotherapy?
No.
The answer is yes. If you have the facility the advent of home sclerotherapy, you can treat the main trunk of varicose. Okay. Sclerotherapy. And what is this? How you create a foam sclerotherapy? You take a 3-way stopcock and then take air in one syringe and push alternately. So this creates a foam inside the sclerotherapy, and this is used for main trunk. procedure will be done. What is this operation under process? You see, you are seeing an ultrasound guided cannulation. You are finding an ultrasound guided cannulation and a probe is passed.
Radio frequency
So this is endovenous
endovenous facial
ablation of varicose vein. Okay? So in treatment, both laser and radio frequency, what is the principle of treatment? What is the principle of treatment in laser and radio frequency ablation?
injury to the endothelium, so that they on the healing process, both the walls will be fibrous and get adherent to each
So
other.
this is basically a thermal ablation. This is basically a thermal ablation of this. While doing this procedure, you need to use a special form of anesthesia described as tumescent anesthesia.
Tumescent anesthesia to
What
protect
is
the blood
tumescent
vessel.
anesthesia? How does it act? How does tumescent anesthesia
We
help
will
in
get
this
the
patient?
tumescent anesthesia below the vessel, so that the vessel will be elevated to which the procedure to be done, and also it will reduce the injury to the other structures surrounding it.
Number one is you inject the tumescent solution between the vein and the skin. This tumescent solution causes the collapse of the vein so that the vein wall meet. Number one, it creates a gap between the skin and the vein wall so that the thermal energy does not reach the skin, preventing skin burn. Okay? This is tumescent anesthesia. What are the complications of radiofrequency ablation treatment for varicose vein? What may be the complications?
Recurrence.
Recurrence is yes. Late, immediate complications.
DVT, deep vein thrombosis.
It can cause deep vein thrombosis. It can cause skin burn. Okay. It can cause skin burn. Deep vein thrombosis, consequent embolism, it can cause skin burn. There is a nerves running along the vein. It can cause paresthesia and also can cause skin ecchymosis and seroma. This is a device you use for patient with varicose vein. What is this device called as?
Stockings. These are
This is
classified
not
depending.
stocking.
These are 4 classes divided depending on the pressure that to be applied. 18 to
Compression
25,
stocking.
25 to 35, and more than.
Yeah. So there are some different standards in different classification. There is a great compression stock in it. Thank you, sir.
Thank you very much, Dr. Shah. Very well attended, and everybody is. You can hear a round of applause, and also a round of applause for both the students, also named doctor.
Thank you, sir. Thank you very much.
Leela and
thanks for the opportunity.
Thank you very much. Thank you, Dr. Shah.
Thank you, sir.
Now, I'm sure you're ready for the OSCE now, so they can also pick choose if these two or the others. You want to the radiology for exam is X-ray chest and abdomen by Dr. Gyan and CT MRI by Dr. Sumit. So, floor is yours. Both of you can initiate. I think we'll start with Dr. Gyan Saurabh. A big round of applause for him. He was a professor of surgery at Lady Harding Medical College and a backbone and an essential part of the scrubs earlier scope that I used to do. So he's always there, and you would find him enlightening. You really enjoy this session. We are missing Raman. She's the third musketeer in this group, but he's not here for some reasons. So Dr. Gyan, it's all yours. You control
Okay. Thank you so much, sir. At the outset, I'd like to thank you for inviting me here, and it's always a pleasure to be here. I would say what Dr. Anley has said. Whenever we are going back from here, we are going wiser. We ourselves learn a lot from this Gurukul program. So, I like this session to be a bit interactive. And first of all, I will tell you how to read the X-rays. And once you are done, what's a good way of reading an X-ray? I'll let you read X-rays one by one. So I'll just invite. So since we do not have much of a time, so I'll just be trying to involve as many students as I could. And since we have to cover up three important X-rays, X-ray chest, X-ray abdomen, and contrast studies. So I may not be able to cover up each and everything, but I like you to be sensitized with whatever is being asked in examination. This is what I'll try to cover up, okay? So I'll start on with chest X-ray. So as I said, first I'll let you know how to read a chest X-ray, right? So as you are all aware that relative density ranges from black to the most dense, that is white. Gas, sweat, water, bone, metal. So it's increasing from black to white this way. What are the important views of X-ray? We have a PA view, we have a AP view, we have a lateral view. The most common view being done is PA view. So how do we take a PA view? You all would have seen it. The patient has the chest toward the, what do we call? Yeah. And the rays come from back, posterior aspect. Okay. So we have a PA view. The advantage of the PA view is the patient, majority of the information that we want to gather could be gathered from PA view itself. And later is done only when we want to see something related to heart or diaphragmatic dome. Lateral decubitus is when we are doing it for pleural effusion, which is not observed in upright position. And AP view is used only when the patient is immobilized or can't move or can't stand up. Okay. Especially in a trauma patient where you don't want to move trauma patient too much. In that situation, you may have a AP view, but a preferable view is a PA view. So what are the differences? This is going to be asked. So you can see both the films are placed near to each other. You can see that clavicle are lying over the lung field in a PA view, and subsequently look at the AP view. They are above the lung apex. They are more down in the PA view. Scapula is away from the lung field in a PA view, and it is coming in the lung field, if you could see here. Coming in the lung field, in a AP view. Ribs, posterior ribs are very distinct in a PA view, and the anterior ribs would be distinct for reasons because the way we are projecting the rays. Heart is relatively enlarged, as you could see in the AP view. These are few ways which you can identify whether the patient is having PA view or AP view. If a patient can stand, if a patient is mobile, majority of the time we would prefer the PA view. Always a film needs to be taken in full inspiration. If you don't take a film in full inspiration, you'll end up in what is there on the left side. You would have crowding of ribs, you would have high-sided diaphragm on that particular region, and you'll have a false impression of congestion around the hilar region. Proper penetration as exposure is important. You can see the first film is over-penetrated and the second film is under-penetrated. Both are wrong. How do we decide rotation? From the midline, you see the level of insertion of the medial end of clavicle. It should be equidistant. If it is not equidistant, probably the film is rotated. That's a very easy way to see whether the film is rotated or not. I always teach a very easy way. Am I audible to the people at the last? I always teach a very easy way. Whenever you're reading an X-ray, follow A, B, C, D, E, F. That's what we have started on with. A is for airway. So when I'm saying airway, you are looking at the tracheal position on the X-ray. Just understand it. Thereafter, we'll just quickly pass on one slide and explain completely in all three categories that I'm going to cover up, and then subsequently you would get to know what you are expected. Proper final diagnosis is not expected of you. A PG is expected to tell the correct approach. So when you get an X-ray, you identify this is a chest X-ray PA or AP view of my patient Mr. X taken on this date. So identification of the study. Then you start with trachea. So trachea is central. How would I get to know whether trachea is central? There you could see. I'll just see. Can you see this is structure? This black shadow, this is trachea. Okay. Can you see the shadow of spinous process at the back? This shadow of spinous process should lie in the middle of the black line, or it could be bit toward the left. Why? Because the trachea is dividing primarily into the right bronchiole. Got it? That's an easy way to see whether trachea is deviated by a slight. A gross deviation is very easily appreciable. Okay. So first is trachea. Then B comes for bones and bronchoalveolar markings. C comes for cardiac silhouette. So you see the cardiac impression and measure the diameter and measure the full diameter. I'll let you know what is CL ratio, T ratio. And usually this cardiac diameter should be not more than half of the total thoracic diameter. If it is more than that, we call it as a cardiomegaly. So C is done, D is for diaphragm bilateral. E is for effusion or emphysema. F is field of lung, or I would always say any foreign body. Sometimes the patient might be intubated, ECG leads may be there, chest tube may be there. And the G is for gastric bubble, H is for hilar and mediastinum. So how would I read it? This is chest X-ray PA view of my patient Mr. X taken on this date. Trachea is central, there is no deviation. Bones seems normal bilaterally, there is no obvious fracture. Bronchoalveolar markings seems normal, there is no prominence of bronchoalveolar markings. Cardiac silhouette seems normal, there is no evidence of cardiomegaly. Diaphragm bilaterally seems normal, there is no evidence of effusion or emphysema. And I can see some ECG leads or maybe endotracheal or a ICD in situ. Is it a good way of reading? That way you'll not miss any of the point. Got it? So I'll just quickly pass on for the few next slides. This is how do we count ribs. You could see the first rib, the second rib. I labeled it properly so that you can see. And all the structure that I have told you in ABCD format are more or less covered up in this picture. Sometimes in a patient, you would have a completely white out lung or a black lung fields, and you would be asked what could be the probable causes. So for that, you should know the white lung field could be because of effusion, consolidation, collapse, fibrosis, and the black primarily could be because of pneumothorax, hydropneumothorax, cavitary lesions. Pleural effusion, how much minimum fluid? Sometime in exam, they might ask you, if a blunting is there, so what is the minimum amount of fluid that could be present in X-rays? It is somewhere around, see, with the latest facilities available, digital X-rays, they say even 75 to 100 ml they can catch. So the question a PG would answer, I would like to see what kind of X-ray has been taken, whether it's a digital X-ray or whether it's a normal. So it would depend on the kind of X-ray, the kind of machine that I'm using. But earlier, yes, it was around 150 to 200. 75 to 100 ml can also be caught in a good, properly done X-ray. Okay, in ultrasound, 3 to 5 ml, lateral decubitus around 10 to 50 ml. That's a question which might be asked in exams. Hemithorax completely wide out. So mediastinum, if pushed away from the opacified side, the diagnosis is usually effusion, large lung masses, a diaphragmatic hernia. If mediastinum is pulled toward the side, opacified, then it's total lung collapse, pneumonectomy or pulmonary hypoplasia. And if mediastinum remains central, it could be consolidation, pleural chest hole mass, or combination of pathologies. Now, I would expect one of you to read. This is a 20-year-old gentleman who had a road traffic injury 3 hours before. He was brought to the ER with airway patent, breathing rate 30 per minute, oxygen saturation 88%, GCS is 15 by 15, people are normal size, normal reaction, and you got an X-ray done after primary resuscitation. Please read this X-ray for me. Yes. It's an AP view, chest X-ray. How do you know it's an AP view or PA view? So I said if a patient could, most of the time, it's not that all trauma patients would be having AP view only. The patients could be having PA view as well, right? So how did you get to know? In the film I told.
Clavicle is below the bridge.
Okay, so I'm asking you to read the X-ray on the left side. Yeah. So this is a chest X-ray
of a patient taken in a PA view, where it is trachea shifted slightly to the right side.
Very good. Most of the time, our mind goes to the pathological. The best way to impress an examiner is when you go systematically. Trachea is
shifted slightly to the right side.
Okay.
The bones.
Very good finding. You could see the spinous process and you could see the trachea shifting. Is it to the right side? Or which side are you seeing the black shadow more toward?
Left. Okay, it's shifting. Okay. The bone bilaterally seeming alright. Okay. So there's, see, always make it a point when you get an X-ray exam, count the rib the way I had it demonstrated. You saw it all, but make it a habit to see each and every rib anterior posterior, so that you won't miss a fracture. What else? And sir, with the cardiomegaly, most likely. Why do you say it's a cardiomegaly? The rates. I told you. I will also show you. See, I told you this ratio. You have to measure the breadth of the shadow, the width of the shadow of heart, divided by the total thorax. It should be. It should not be more than half. So does it look like? Grossly, it doesn't look like a cardiomegaly. Okay. So A, B, C. B also included bronchoalveolar markings. They are absent on the left side. Yeah, so you have to verbalize that. C, cardiac celote. And D, diaphragm. What have you got to say about the diaphragm? They're not raised. But could you see something on the diaphragm on the left side? Yeah, madam is giving a hint. What is this? Airfoot level, you say it's a, I made a history of a very good history of a trauma patient. He had a road traffic injury, he was riding on a bike, fell down. So we can comment what would be the fluid in a trauma patient. Is blood unless proven otherwise? So you can say there's a blunting of CPA angle, yes, and according to the history, it seems like a pneumothorax. Okay, what else? So D is done. E, effusion, so effusion is there. Is there a blunting of left CPA angle? Is there any evidence of emphysema? E is for effusion and emphysema. F for foreign body. Is there any foreign body in this? No. Oh, there is a chest tube. So that's the use of remembering this formula. So you would say there is a chest tube. And when I'm seeing the chest tube, I'll also like to see if there is any eye which is outside or inside. Okay. So that's an advantage of reading chest X-ray properly with ABCDEF format. Trust me, it is your approach. Even if you find nothing on the X-ray, approach, follow this approach ABCDEF. Examiner would be very happy with you. Okay. So up ek baar mein sara pad do. This is chest X-ray PAV of my patient Mr. X taken on this date. The trachea, yeah. Trachea is to the right side. And the bilateral bone seems normal with the absent broncho marking on the left side and normal low cardiomegaly and the diaphragm shifted, absence of CPA angle on the left side. It's not absence, it's a blunting. Blunting. Yeah. Blunting. So you would say, considering the history of trauma given, it looked like a case of a pneumothorax. So how would you treat this patient? Already treated ICD. So it is already treated. So why there is air in spite of ICD in place? Not aligned. Yeah. So your viva can go to this direction as well. Why? What answer did you get? An eye is not properly inside. One of the reasons. Second reason, chest tube could have been blocked. Yes, third reason, something else could be there. There could be injury. There could be bronchopleural fistula. Right? So you think of all that. See how one simple case can guide your viva. So always focus and read it properly in a ABCDEF format. Okay. So now I'll go to the other one. See, in the same way, yeah, please read this section. The 25-year-old gentleman presented to you with a history of respiratory distress in your ER. You got this X-ray. Read it.
The PA chest X-ray.
Okay. With
trachea.
So I maybe advise you to read the one on the right side. This one, yeah, to make it easy. Yeah. So this is a chest X-ray.
Chest X-ray
of my patient, Mr. X.
My patient of Mr. X.
The
trachea is centrally placed, and no any bony.
There is no evidence of bony injury in the X-ray.
And bronchoalveolar.
Absence of bronchoalveolar marking on
left side.
Left side. There's complete blunting. You could see the fluid level on the left side. Okay. The cardiac velocity you had commented upon. D level of diaphragm. You could hardly visualize diaphragm on the left side. There is evidence of effusion. There is no evidence of emphysema and no foreign body that is visualized your diagnosis. On X-ray. Hydropneumothorax. Okay. So then you would be asked, how would you manage it? So similarly, this is one of the cases where you can see subcutaneous emphysema. Okay. So now I'll go into the abdominal. You got the point? A, B, C, D, E. When you have airway, you're looking at the trachea. When you have B, you're looking at bones and bronchoalveolar margin. When you have C in your mind, you're looking at cardiac velocity. When you have D in your mind, you're looking at diaphragm. E, you're looking at fusion and emphysema. F, foreign body. You had foreign body in one. G, gastric bubble. Hilar, H for hilar. You have this format, you will not miss anything in X-ray. And rest, you can have 20 X-rays. We won't stop here, but just remember how to read. Going on to the abdominal X-ray. Similarly, I'll let you know how to read the abdominal X-ray. So first you have to identify the patient, identify the film, whether it's a PA or AP view. In chest X-ray, PA is very commonly performed. In abdominal X-ray, the usually film that we get done is a AP view, usually a supine view. And majority of the time, it's more than enough. We get enough information from supine film itself, but we may be required to do a X-ray abdomen erect in few situations. And if at all we are suspecting any perforation peritonitis, we would rather get a chest X-ray erect view and look out for the gas in the diaphragm. So the main film would be the AP, as I have already said, but it could even be supine, erect, or lateral decubitus. So again, I have already illustrated you in the X-ray chest from where the rays are coming in PA and AP, and same goes true for abdomen as well. So there's nothing different. Sometimes examiner might ask you the radiation exposure in these X-rays. So an abdominal radiograph along with pelvis will have a exposure of 1.5 millisievert. And this equates to 75 chest radiograph, which gives a 0.02 millisievert dose. Approximately 1/6 of the dose incurred by standard CT chest, CT abdomen, which gives 9 to 10 millisievert. And we should use all these exposures cautiously. These are the various things that would be visualized on abdominal X-ray. You could see that I can have a look at T12. I can have a shadow of the liver, 11th rib, Schwarz margin can be seen, hepatic flexure can be seen, iliac crest or sacrum, gas in the sigmoid colon, sacroiliac joint, femoral head can be visualized, transverse colon can be visualized, and the left kidney shadow can be visualized, splenic flexure. So even a simple X-ray can give you so many information. Okay. So how would you read it? Again, this is X-ray abdomen, AP view of my patient Mr. X, and then you start reading from outside to inside or cranial to caudal. Maintain some, objective way of reading it, and just don't read blindly and tell the pathology, sir, ye to obstruction ka hai. No, I would rather expect you to identify the whether it's properly exposed, whether it is an AP film or a PA film, and with reasons behind that, because you might be asked. So now what is normal? In stomach, we would always have an air in stomach, a small bowel, 2 or 3 air fluid level may be normal. Large bowel, almost always air in rectum and sigmoid. So in a stomach, always there will be air fluid level. In a small bowel, 2 to 3 are normal. Large bowel, none. If at all it is there, it is abnormal. So how would a small bowel look like? The small bowel would usually be localized in the central position of the abdomen, and it would have valvulae conventus. And the large bowel would be usually localized peripherally, and it would have hostrations. And what are valvulae conventus? They are mucosal folds that cross the full width of the bowel, while hostrations will not be crossing the full width. There is a 369 rule. Normally, small bowel greater than 3 centimeters is supposed to be dilated. Large bowel greater than 6 centimeters, cecum greater than 9 centimeters. This logic doesn't hold true for digital miniature films. It's for the actual scout film taken.
So a very common X-ray, taken up in exam. This is just a repetition of chest X-ray that I had already told you, just for showing the finding of gas in the diaphragm. This is a regular sign where air on both sides of the bowel wall, which will suggest perforation. Falciform usually will not be seen, but if there's air on both sides of the falciform, it might get prominent and could be seen in X-ray as a falciform ligament sign. As you could see, falciform ligament sign, since air is present on both sides of the falciform in a perforation peritonitis patient. Pneumobalia, sometimes after a procedure done on any HPB procedure, you might have air in the biliary system. This is how it will look like. I have marked it with arrow. Localized ileus could occur in condition like pancreatitis and all, and you would have a view something like this, a localized bowel loop around. This is generalized adynamic ileus where all of the bowel loops are dilated. So since we have to cover up 3 topics, so I would just illustrate on one and make a OSCE of 2 or 3, but let you know how to read it so that in exam you are able to read each and every X-ray. So I'll start on with this. Yes, who's there? Yes. He's a 30-year-old gentleman, had presented to your ER with 4-day history of obstruction, vomiting, 7 to 8 episodes in a day. He is having abdominal distension, tenderness, and has presented to you in your ER. You got an X-ray abdomen done. And this is the X-ray. One, you'll have to identify, although I made it a point not to label it clearly, which one is a supine film, which one is an erect film. Why do you think so? And read both sides of the film. Sir.
Sir, I'm reading the left X-ray. This is a X-ray flat plate abdomen of my patient. AP view, supine, and I can see a little less exposure on the X-ray, and on central part I can see a small bowel dilated.
Why do you call it a small bowel?
Sir, actually the position which is central plus volvular conventus could be seen, and some part of featureless ileum which can be visualized. And this is a supine view since there are no air fluid levels. And on the right side X-ray, it's a X-ray of flat plate abdomen of my patient with centrally located dilated small bowel with volvular conventus and air fluid level.
Would you like to see how many air fluid level? Another one important point. What's your name?
Sir, Rishabh Chaudhary.
Good, Rishabh. But as I said, as a surgeon, we tend to focus completely on one thing. We completely neglected about the comment on the ribs, the comment on the vertebrae, the comment on the sacroiliac joint, the comment on everything. So make it a point, you verbalize them as well. It gives a very good impression that you saw the patient in totality and did not focus entirely to the bowel. You did catch the findings absolutely correctly, but make it a point the way we had illustrated in chest X-ray. Similarly, we're going to talk about everything, whatever is visible. The lower ribs are visible, the vertebrae is visible, the sacrum is visible, sometimes the shadow of psoas, sometimes the shadow of kidney is visible. So whatever you can interpret in that film, just verbalize it. It gives a very good impression. Okay, just sit down. Okay, so he said it, he read it properly, identified the finding. So what do you think the patient could be having? Small bowel obstruction? Okay. So then your viva can go toward the direction of managing it. All of you are well versed with it, so I'm not going to go into detail of that. So this is another one where you can see another case with small bowel obstruction, and you can see valvulae conventus which are covering the entire width. This is large bowel case of a large bowel obstruction where you can identify a large bowel with the presence of hostrations. And as I have already told you, hostrations are not going to cover the entire width. This is another, I have repeated it again because, you know, when nothing works, this X-ray is going to save you in MS exam, gas in the diaphragm. Chilardity sign, this is where sometimes there might be gap in between the diaphragm and the liver, and the transverse colon may lie there, or any other part of the colon may lie there, and it may mimic as if free gas in the diaphragm, but it is not. Why? You would always see some hostrations or something in there. And moreover, remember, the free gas will always take the contour of the diaphragm. And if it's a Chilaiditi syndrome, it might not be taking a contour of the diaphragm majority of the time. And then this is another not very common situation to be encountered in 2024. But yes, a radiopaque shadow this way can be a gallstone as well. How do you confirm it? I would answer, I'll simply get a beds on ultrasound. At the time when I was doing PG, we were being taught I'll get a lateral film, we'll try to confirm it, whether it's a renal stone or a gallstone. In 2024, we all have ultrasound in our wards. It's so easy to confirm. But yes, you could have radiopaque gallstones as well. Calcified enteric lymph node, calcified fibroids, pancreas, in that particular region, radiobesity, then your Viva would go on to the direction of what could be the causes of this chronic calcified pancreas. Then you would go into chronic pancreatitis and all. I'm not going to discuss that. This is one situation where you could have a gastric volvulus rotation and a hugely dilated stomach. I have explained the normal radiograph well. So if in that region you are having, it's very easy to identify that this is most probably because of stomach distension. Cecal volvulus, again, you would be having a distended X-ray like this. Sigmoid, as you could see, you could reconfirm your sigmoid volvulus even with the barium studies, where you would have a sign known as a bird of prey sign. When you give the contrast per rectally, it won't proceed further. So these signs sometimes look fancy, but trust me, majority of the examiner themselves wouldn't be remembering the name of each of these signs. So even if you can verbalize the finding, tell the diagnosis, differential diagnosis, that's more than enough. Perforate peritonitis due to appendicitis, sometimes this is not, I would say, a very common X-ray to be asked, but yes, this is an appendical lith that we can visualize. And since the patient had examination finding of peritonitis, we expect it to be perforation because of appendicular perforation peritonitis. This is just a film where we can see appendical lith. This is a sign where you could see double bubble sign because of duodenal atresia. The green one shows enlarged stomach, and the blue one, the duodenum. Another X-ray that you might be given in exam in necrotizing enterocolitis. So the diagnostic feature of this NEC is intramural gas. The gas would be outside the bowel, inside the bowel, but in the bowel wall also. That's a particular sign, and we always give such X-rays where findings are very prominent. We are there not to confuse you in exams. So as you could see, this is intramural gas, and this is quite pathognomic of necrotizing enterocolitis. Intersusception, the typical sign is meniscus sign, crescent sign. So it happens because of bowel loop inside another, the bowel inside the bowel, which give this typical crescent sign. Then you could have malrotation in which entire abdomen, the bowel would be dilated. Then you could have few X-rays like where you could have a presence of surgical clips or foreign body per rectum. And then you could also get X-rays with bladder calculi, renal calculi, stagon calculus. I know these are not difficult to be diagnosed. Then you could have multiple calcification shadows, nephrocalcinosis. And this could nothing but be a sign of medullary sponge kidney or a hyperparathyroidism. And then you could have a putty kidney, which is a caseous kidney tuberculosis. It could happen, most of the common cause would be tuberculosis in India. You could get this kind of X-ray as well. So as I have told you in both chest X-ray and abdominal, it's a way you read it. A, B, C, D, E. And then you identify the finding. So I'm spending time in one or two X-rays the most. Rest I'll have to walk away by telling you the finding. Now the contrast X-ray. One thing I've found is that none of the surgery books give details about contrast properly. Okay, so I'll forward a book which I took from radiology people, and I'll forward it to Sir. And Sir can share that book to all of you if you are there in a WhatsApp group. Actually, how much contrast to be taken, what contrast to be taken, how much before to be given, when do we scan for the IV people, why only barium sulfate, all these are given. Because of lack of time, I would cover the important examination points for today. But if you want to read detail, I'll share the book with Sir. And I'll appreciate if Sir could share it in their group. So contrast. What are the various kind of contrast? You could see first, I'm talking right now about X-ray, and CT is will be covered up by Dr. Sumit. So for X-ray, it could either be negative contrast media, that is air or CO2. So when we give barium sulfate and we call it as a double contrast, barium, we are actually giving air along with it through a nasojejunal tube. Then there are a few other positive contrasts. Barium sulfate, very commonly used. Why? Because it is less absorbed in the body, quickly passed through. We are able to it get adhered to the mucosa, so we can mucosal anatomy could be better delineated. Now we have CT scan available with oral contrast, so the indication of barium studies have decreased. But you might still be asked in exams. Some of the other films. So then we have a oily contrast medium, which is not commonly used, iodinated. They could be having hepatic excretion or renal excretion. In renal excretion, we could have the dye like ionic monomers or ionic dimers. So I have enumerated all these. So sometimes an examiner might just ask you why barium sulfate in all barium studies. Let's take something else. So you can say this is one of the contrasts that we use. Other contrasts can be urographene, gastrographic, and what exactly is the component? These are the components. And why do we prefer this in particular? I'll let you know the reasons, which I have already elaborated. So barium solo, what are the indications? Like dysphagia, regurgitation, or any, in perforations, you must avoid. Barium is irritant to mediastinum and peritoneum. This is a situation of a patient who had achalasia cardia. So you could see the dilatation of the esophagus with a beak-like deformity near the gastroesophageal junction. If you are given this patient an exam, you would be asked what would be the most ideal investigation. Don't think that I'll ask you to identify the finding. I know almost everybody would be able to identify it. I would rather ask different question. Yes, sir. What would be the ideal investigation to confirm your finding? You got it? So this gentleman presented with problem in deglutition. You got a barium contrast, which is showing this finding. I have already enumerated the finding. What would be the ideal investigation to confirm your diagnosis?
Which is manometry.
Yes. So please elaborate it properly. What would you do? Okay.
24 hours esophageal pH with manometry finding.
So there's something known as multi-channel intraluminal impedance monitoring, and one thing is known as 24-hour pH manometry. So what you want to do here is a 24-hour pH manometry, right? This is what you're planning, and the actual diagnosis, confirmation of diagnosis would be with that. How would you manage this case?
Sir, first.
What's the patient is? Yeah, somebody already said it from the back. Would you want to associate this myotomy with some other procedure as well? Okay, so usually we can either go in for an anterior or a total 360 degree, but we would first, assess the patient, whether the patient has a reflux associated or not, how much is the degree of assessment of reflux, and that could also be confirmed through our pH manometry and impedance monitoring. Okay. So sometimes your OSCE or sometimes questions may not be related to that finding per se. It may, please sit. It may even be related to the further management of the patient. So this is another where you can see a stricture, long narrow stricture involving the middle and distal esophagus. I am trying to label everything. You can see the stricture. Sometimes the finding on contrast are very evident. It doesn't require a lot of diverticulum. You could see in this very clearly visible. A hiatal hernia. Okay, so you could see a part of the stomach going into the thorax. Okay, then you could then your viva could be toward the direction of how would you manage a case of hiatal hernia? What are the various kinds of hiatal hernia? Where conservative management could be applied? What is type 1, 2, 3? So you would be expected to know everything there. Carcinoma esophagus. As you could see, I have compared both CT. CT would be covered up by Dr. Smith, but on the right side, you can see the film. So you could see there is a filling, not a proper filling in this part of the esophagus. So probably a large centrally ulcerated. When we got a CT scan onto the same gentleman, this was the finding. Now, regarding all the barium studies, what does a normal anatomy look like? So you have to make it very clear. You can see the fundus. We can see the body, the pylorus, the first and second part of duodenum. So the contrast is going, usually the contrast in this study is barium. For the reason I have told you, it's not absorbed and it get adhered to the mucosa. it's not toxic, it doesn't cause a lot of allergies, and especially if we are using air as a double contrast, we can delineate anatomy inside anatomy better. So this is where a huge filling defect looking like motile soft tissue mass occupying the entire gastric lumen. It is gastric dissolve. This is diaphragmatic hernia. We could see the contrast in the thorax itself. Esophagus is stomach, and the bowel loops are going into the thorax. And this is a contrast study where you can see the widening of the C loop of duodenum, possibly because of pancreatic mass, would be confirmed with ultrasound CT scan. This barium meal, then barium meal follow through, localizing the upper part of jejunum. Then the lower jejunum and ileum are also calcified. Crohn's disease, you would have a typical sign. This could be given in your exam. Typical sign, a long segment of narrowed ileum. Yes, good. Ileocecal tuberculosis, very favorite of examiners in India. Everywhere. You would have patients, you would have film with a pulled up cecum. You could have a film with some name sign, terminal sign. Terminal ileum may be looking like a string. Okay. And then you could have a Fleischner sign. Fleischner sign is nothing. As I said, all these are fancy signs. It is just hypertrophy or enlargement of valve at the ileocecal junction. As a result of which the gap in between the valve increases and it gives an appearance of an inverted umbrella. These are some fancy named signs. Pulled up cecum, gooseneck can occur because of constriction at ileocecal junction. The terminal ileum distend a lot. Okay. A Sterling sign. So as I said, all these signs are not very typical of tuberculosis alone. Some of them may even be present in Crohn's disease, thinning of terminal ileum. But pulled up cecum is quite pathognomic of tuberculosis. So this is what you can see, a thinning, as you could see, right, of the terminal ileum. Hirschsprung disease, there would be reduced caliber, as you could see in this X-ray. The caliber of rectum is even lesser than the caliber of the descending colon. This is quite pathognomic of Hirschsprung. And then you would be asked about management of Hirschsprung. Then you could have multiple polyps inside the colon, representing as a filling defect. Large bowel malignancy, you could see that the contrast did not fill this part of the bowel. So probably you can see there is a growth. It could be a malignancy, or it could be benign, it could be polypoidal, it could be anything. Barium enema, this is one film where I had given from the rector. It's a normal barium enema. This is distal leukogram of one of our patient in whom, when the dye was injected through loop, there was a constriction at transverse colon. And this was the site where earlier transverse colon, they did some surgery, as a result of which stenosis had happened in that part of the transverse colon. So distal leukogram, one of the films, and the finding, as you could see, the proximal loop remains distended, then there is a constriction, and the rest of the loop is not distended. You might be asked about T-tube cholangiography as well. This is quite favorite of examiners. So I'll just put on one scenario. Yeah, I'll take somebody from back now. I can see. Okay, yes, sir. You. Yeah. So this is a 35-year-old lady who underwent open cholecystectomy with CBD exploration. T-tube was placed in situ by the operating surgeon. The patient had come back to you after a week, and this study has been performed. Can you read this? Majority of the time, see, just for the sake of teaching, we put on this scenario. Majority of the time, either we would be closing the CBD over a stent. Now, most of the surgeries, lab CBD explorations are being done. We are putting in a stent, easily available. Removing the stone, we have intraoperative corridoscope. We can visualize clear. But for you, this is quite favorite of examiners. So read this. What is this study? And what do you see in it?
Sir, a T-tube.
Okay.
A T-tube is visible through which.
I have already labeled it. So I'll just make this one for you. I should not have labeled the finding, but nonetheless. Okay. So it's a T-tube cholangiogram. And what do you visualize in this T-tube cholangiogram?
So the patency of the CVD duct and the biliary tree.
So right side, I have already labeled, but can you just let me know where can you see the filling defect in this to label it as a CBD stone? Okay. Is it here somewhere?
So down.
It's down. I'm coming down. So where is it? Okay, this is one of the filling defect. This is one of the filling defect. So you would say this is a T-tube cholangiogram of my patient Mr. X taken on this day, properly visualizing the intrahepatic biliary radicals which are not dilated. You have to verbalize everything. The hepatic duct is not dilated, but I can appreciate filling defect in the proximal aspect as well. Here also I can appreciate the filling defect here. And I can appreciate filling defect here as well. Mild dilatation, I will say here, but majority of the CBD elsewhere looks normal. So it looked like some retained stones. Okay, then you would be asked, what would you do next? The second.
Just one point there. What else could it be? Stone is one option.
One is, yeah, that is another important thing. Could it just be a stone or
So how would
something
you
else?
We can change the position of the patient.
Yes. Yes.
Yeah, please.
How would you confirm whether it's a stone, or I'll make the question very simple, presence of air?
We can change the position of the patient, we can elevate the head end and take, if the changing of this defect will go up.
So could it be anything else than air or stone?
Warmth also.
Considering this appearance, see, I made situation very easy for you. Patient underwent cholecystectomy with CBD stone, CBD extrusion. I have made very easy for you. But sir is very correct. That could it be something else? It could be retained stone. It could be air. So you would get the patient into which position?
Heading up.
Okay. And you would like to see the movement. Can stone also move?
No, stone will come down.
Okay. So the air is going to move up.
Yes.
That way you can differentiate. Basically.
Short question, therefore I ask. And in what position do you inject the dye when you're doing T-tube cholangiogram?
Right lateral position.
Right?
Lateral position. Right lateral position.
Right?
Lateral position.
Right, lateral position. No, you don't need to put that. You will be lying on the tube then. So just when you're taking the tube, it's the right side down. Why?
Right side should be down. Why?
Why?
Because the vertebrae will come in the.
Very good, excellent. Give him a big round of applause. The white will be on white, so you won't be able to see unless it falls.
That's the first slide where all details how to do T-tube cholangiograms. So as sir said,
the left side of the patient would be bit up so that the vertebrae is not overlapping with it. And then you would also change the head position in order to differentiate it from stone from the air. But these are very old questions, as sir is saying, but you will still be asked all these questions. And how do we go about it? As I said, it's usually done in 8 to 10 days. It could sometimes be residual hematomas or abscesses or worms, which may give an appearance of filling defect. I did a surgery on CBD. There might be some hematoma there. So have your vision open for every possible cause. Okay, coming on to the IVP. Radiological examination of urinary tract, including renal parenchyma. So IVP is a misnomer. It should be IVU. Okay. A scout film is first taken. Then we inject the contrast media. Test injection of 1 ml of contrast is given prior, and then rest of the contrast is inserted in 30 to 60 seconds. Now, many of you might just be asked, how are we doing it and when do we take the films? We are so much used to get CT urography that IVP has gone out of our mind, including us faculty as well. So we should know when are we exactly taking films. The first film is taking within a minute, and that would visualize the entire cortex. And the cortex would have 2 components. So as you said, vascular filling is actually the cortical phase and a tubular phase which is the contrast within the lumen of the renal tubule. And this would happen within 2 minutes. And as I said, appearance of pyelogram, that is contrast in calyces, is seen in 2 minutes. If a kidney failed to excrete a detectable amount of contrast, it is termed as non-visualized kidney. This point I want to emphasize. On IVU, we never say non-functioning kidney. We say non-visualized kidney. And
what is the time duration after which you would call it as a non-visualized kidney?
20 minutes.
Yes, madam. You were saying something, yeah?
After 12 hours.
After 12 hours. So when should be the last film that you want to do?
24.
After 24. So it is a very cumbersome process for anybody to be there in the hospital throughout. First take a IV contrast, then the entire face is covered up within 30 minutes to 1 hour. But in order to call as a particular kidney as non-visualized, the last limit is the last limit of taking X-ray film is 24 hours. And why do we use the word non-visualized kidney? And why not we use the word non-functioning kidney? Yes.
Because ideal is it only tells about the function of the kidney, not about the function of the kidney.
No, we are seeing the excretion of contrast here. Why do we, if it's not a functional study, why are we at all we are doing it? IVU is a functional. You are looking at the excretion of contrast from both the kidneys. Why am I scared not to call it a non-functioning kidney? Why non-visualized? Because you very well agree to this fact. कभी रेडियोलॉजी का रिपोर्ट देखा है उन्होंने नॉन फंक्शनिंग लिखा है IVU में NVK लिखते हैं वो लोग. So why do they write NVK? Why non-visualized kidney term is used for IVU and not non-functioning? Sometimes some basic questions are asked and we are prepared because we are so much used to CT, including me. We hardly see IVP anymore now. See, the reason here is that in IVU, if there is no visualization of contrast even after 24 hours, it is being observed that 30% of the kidney may still be functioning. And the decision to do a nephrectomy is taken only when the function is less than 10%. You don't take a decision at 30. You would never take a patient for any procedure like a nephrectomy after IVU. You would always get a DTPA scan. The reason is IVU may show non-visualized kidney even with persistent or remaining 30% function of the kidney. So that's one of the biggest drawback with IVU. Am I clear to everybody? Please sit down. So that's the reason we use the word only non-visualized. We don't use the word non-functioning. So 1 minute film shows nephrogram, 5 minute film show nephrogram, renal pelvis, upper part of ureter, 15 minutes visualization, 35 minutes it goes into the urinary bladder, and then we have post-void films. Delayed films taken 1 to 24-hour injection. It is only after 24 hours, but it is very cumbersome. Majority of the time you don't be following up this protocol. This is the actual protocol of IVP which they follow and which probably have resulted in us switching on to CT urographies, which is just get and take the films and everything is done. 10 minutes is the time for the delayed film in CT urography. But nonetheless, the importance of these investigations is not lost. Okay. So delayed films are used usually in cases of obstruction, long-standing hydronephrosis, congenital lesions. Now these are a few films. In first one, you can see the presence of histagon calculus. In the second one, there is a presence of ureterocele, the dilatation of the lower part of ureter, visualized on an IVP. Horseshoe kidney, where both the kidneys are fused together, and then we can have a retrocable ureter, where ureter is actually lying behind the IVC. And with the IV contrast, we get a film like this. Then, and then I will just conclude. It's the approach, how you read X-ray chest, abdomen and contrast study, which is important. Sometimes you may miss the diagnosis. Examiner is not going to punish you or not going to give less marks to you as long as you have followed a good approach. And I always say, make it a point to read X-rays in a very good format. I would sum everything by saying chest X-ray में कैसे हमने पढ़ा था? ABCD. A was for trachea, B for bone, bronchial valve marking, cardiac salute, diaphragm, effusion. We followed the same protocol for X-ray abdomen. We have to identify supine and PA and erect view, and then we do not have to just comment on bowel. Do comment on other possible structures that you are seeing. And a good X-ray would cover up from trans-nipple level up till the sacroiliac joint for a good abdomen and pelvis X-ray. Know the dosage is required. Contrast study, I would say relatively are easier to read.
because you have a contrast and you would be able to see whether it is flowing properly or not flowing. But do remember the differential diagnosis. Do not just stick on to one. In contrast study, you can only make differential diagnosis. There is a filling defect. It could be because of malignancy. It could be because of something benign like polyp. It could be because of some external obstruction as well. Extramural. So have your vision open. How would you confirm? I would either confirm it through ultrasound or a proper CT scan. Then know the details of contrast, which is very important. Okay. So with this, I'll end here and I'll thank you all from my team of Lady Harding Medical College. Any questions are most welcome.
Big round of applause. So this is what Scrubs is about. We had almost every possible question covered in the CT, in the X. I think you can recollect any questions. He's still here, or you can ask directly. Otherwise, I'll request Dr. Sumit to make his presentation so that we cover the radiology completely. You can't get a more thorough understanding in the way it has been taught. I think that's all to you.
Thank you, sir. Thank you.
Dr. Sumit is a professor of surgery at ESI Medical College and very active member of all our academic activities, very keen academician, good teacher. And he's going to show you something which is very, very important for your exam again. And I asked him at a very short notice to do this presentation. Dr. Sumit, thank you very much for agreeing all over to you.
Good evening, sir, and good evening to all. And thank you, sir, for calling me here. And it's always a pleasure and I am honored. Thank you, sir. So I thank Dr. Gyan for keeping me slightly easier for me. So because you have talked about elaborately about the contrasts and all those things which are essential for my part of the talk also. So I'll talk because it's related to OSCE and the postgraduate examination. I'll be very basic. I'll talk about basics of the CT and MRI. And after that, at the end, I will have some questions along with the questions and the films. And I ask you all to diagnose the film. So to begin with, I'll cover the principles of CT and MR, then what are the different generations, CT number and the MR sequences, the role of contrast, then indications, prerequisites, then shortcomings, drawbacks, and contraindications, then which modality is better in which patient, and then, of course, the questions. So you can all familiar with this gantry and the room, the CT or the MR room, which is very familiar with all of you. The components of the CT scan room are the gantry, the data acquisition system, and the operating console. So all are in that suit, which you can say a radiology suit. So operating console has a computer, a keyboard, and a multiple monitors, which do even different monitors, different consoles also to do the constructions and reconstructions. So about the generations of the CT, started beginning with the first generation, the ancient CT machines, which I even not seen. So we are in the era of 6th generation and the 7th generation CT scan machines. So the 6th generation is all we have available in most of the medical colleges, which have the typical helical or the spiral CT facility. But the 7th generation CT is the latest one, and it is the most advanced, which can give us up to 128 slices. And it is scanning time, as you can see, only 0.25 second. One cut every 0.25 second. So it is the most advanced one. Then about the sequences, the sequential is when there is complete gantry rotation. The whole gantry is rotated and it takes the sequential image of a particular part of the body. And then a spiral is the continuous gantry rotation along with the table also moves. So not only the gantry, so we can get the spiral CT films also. Then about the CT number. So all the images which the radiologist, or we can also, CT is very friendly to the surgeons than the MR. So we also should know about the Hounsfield units. So they are called the CT number. So you can see the CT numbers right from negative to the positive. So air has got the -1000 and water has the 0. So water basically is the criteria, and it can go up to the air for -1000, and bone is the most positive CT image, which gives a +1000 Hounsfield unit. So with these Hounsfield units, we can describe an image or a particular lesion as either hypodense. Hypodense means going towards the negative from the 0. Isodense means it is equal to 0 or near 0. Or hyperdense means it is towards the positive, like the bone. So higher the density, whiter is the appearance in the CT, or lower the density, darker is the appearance. So you can see here. So the whole thing which coming from darker to the most brighter. So most brighter is the bone, and the darker is means isodense is the water. So CSF is more near the water, and air is the most negative. That's why it is giving the most dark area of the image. So the role of contrast and already been spoken by Dr. Gyan. So here I can say about the route of contrast agents which are utilized while doing the CT. It can be intravenous, it can be oral, rectal, or intra-articular during the diagnosis of joint pathologies. So what is the role of intravenous contrast? They differentiate the vascular and the non-vascular structures. The IV contrast, they enhance the vascular. If vascularity is high, the organs or the tissue or the lesions get advanced. So in angiography and venography also the IV contrasts are used. Then types of contrast can be ionic or non-ionic. Basically, all these contrast agents are basically iodinated. So this iodine is responsible for the brightness, which is given by after giving the contrast. So you can see here the left side is the non-contrast CT film, and the right side one is the after giving the contrast. So you can see the organ has been enhanced after the IV contrast. So you can also see here different phases of the CT film. One, the left side up is the plane without contrast. Then contrast has an arterial phase. You can see the arteries are the opacified, and the venous phase, which is the return phase, showing the lower cut section of the CT. So we can have oral contrast also. Then what oral contrast does, it is basically used in the diagnosis of the GI pathologies. So you can have positive oral contrast, which are diluted barium, gastrographin, or non-ionic contrast. Then neutral is either water or mannitol, or negative is air. You can see here a neutral contrast means either water or mannitol. You can see the neutral contrast also gives quite a good picture of the bowel. Bowel gets distended. And positive contrast means either iodinated dyes or barium, which is being manifested in the same patient with the distended bowel loops. Air as a negative contrast. You can see the in the one of the lumens, you can see the small polyp can be visualized by giving a negative contrast by pushing air either from a rectum or from a Rice tube or the oral cavity. So CT can have many reconstructions. So a multiplanar reconstruction, either the left one is the sagittal view, middle one is the axial cut section, which we normally see, and then the coronal. These are all CT urography reconstructions. Then the arterioaortography, renal angio, abdominal angiography. You can see different reconstructions of a skull. Then cerebral vessels in a CT angio of the cerebral vessels, then CT angio of the abdominal vessels. This is a film which is showing a virtual colonoscopy. You can see a polyp, which is normally called a CT colonoscopy or a virtual colonoscopy. It is one of the non-invasive methods of doing the diagnosis. So indications of CT can be anything. So you can image every part of body, every system. So what important points you want to remember before going for a CT? So you have to put, while you fill up the CT form, you should write the indication, why you want to do, what is the clinical suspicion. Then the kidney function test, preferably the GFR should be written, because most of the contrast agents, they pass through the kidney, and if kidney function is deranged, then they must avoid the contrast CTs. The status of the thyroid function test, because most of them are iodinated contrast agents. History of associated illness. If barium study has been done earlier, then CT should be done after 7 days. Why? Why a CT should be slightly delayed after a barium study? Because you will not be able to give other oral negative or the neutral contrast. The barium will only be seen. So you cannot give those. So you should delay it till the time barium passes off. Then a history of previous reactions to the contrast agent or allergies or bronchial asthma. Pregnancy is a contraindication for doing a CT. And CT is avoided when other modalities are better than CT. So here comes the role of MR. So MR is better for imaging the soft tissues like brain, spine, musculoskeletal system, hepatobiliary, pelvis, genitourinary organs, and soft tissues of the face, neck, and the orbit. So MR has slight advantage over the CT. Then when you don't require a radiation exposure, you must advise MR. And if there is deranged kidney function test and there is anaphylaxis to the contrast agent, then you must do a MR. So what is MR? It is a magnetic resonance imaging, magnet, radio frequency, and imaging. When all these are combined, we do a MR. So in MR, we have different modes of images. But as a surgeon or as a postgraduate student, you must remember out of these two, the T1 weighted and the T2 weighted, and the angiographies, MR angiographies. So you can see here, you can see in T1 weighted and the T2 weighted images, will the radiologists say which part of the organ or which tissues show which image, means from darker side to the brighter side. And then again in T2 weighted also, darker side to the brighter side. So if CT brain is done, then CSF, what CSF looks like in a T1 weighted and what CSF looks like in a T2 weighted. So CSF looks like dark or lower than the darkness in a T1 weighted, but in T2 weighted it is mostly bright. I can give you the example. Here you see the T1 weighted, the CSF looks like a low dark, but in T2 weighted the CSF looks like brighter. So these are the clear-cut differences where you can say. So what can be the checklist before going for MR? So in the MR console or the MR room, no mobiles, no credit cards, nothing, please. So known potential safety concerns, what we need to do, because the patient has entered into a magnetic field. So those things which can affect the magnetic field around that patient should be avoided in the MR console. And the most important of them all is whether the patient is claustrophobic or not, because it's a time-taking procedure, and in a closed room there are lots of sounds. So patient might feel claustrophobic. So MR should be avoided in those patients. But there can be advantages because there is no ionizing radiation. The soft tissue, all planes of the soft tissue can be very well delineated by the MR. But few of the systems of the body which has clear-cut advantage over CT, like neuroimaging, stroke imaging, spine, muscles, pancreaticobiliary, local staging of a cancer patients in genitourinary and rectum. MR has the clear advantage. And of course, the breast imaging also. But nothing in this world is perfect. So MR also has limitations. Where are those limitations? In the bone, air, where there is air, it is time consuming, and an expert radiologist is required to report the MR. Now coming to the OSCE thing. So it is basically a normal CT film of an axial section. You can see here everything is visible. A normal gallbladder, a stomach with contrast, with air fluid level. Pancreas you can see very well with all the parts of the pancreas. Then both the kidneys, then intestines, liver. So it's a normal CT film. So now the scenario 1. One of you can stand up. Who will volunteer, please? Patient presented with pain in the upper abdomen and fever for 15 days. His TLC count is 17,000. Liver function test is deranged. So next investigation.
Passing the mic if you can. Perry? Can you pass the mic, please? Start asking.
Yeah. So what will be the next investigation for this patient? Don't see the film first. Talk about the next investigation. Okay. So what do you suspect? Patient presented with a upper abdominal pain with fever and a high count. One of those possibilities. So you want to do a ultrasound. So if ultrasound is equivocal, so ultrasound says there is a SOL, might be abscess, might be something else. So next investigation, CT. So what this CT is saying? You can see a lesion in the right lobe of liver. Yes, very good. Hypodense. Yes, of course. Because the density of it will not be enhanced. Because if it would have been a malignancy or a liver mass, after giving the contrast, it would have been enhanced. So hypodense meat is going more towards abscess. Okay. So how do you manage this patient? It's a large abscess. Image guided drainage, culture sensitivity, and then treatment. Good. Thank you. So next scenario is someone else.
Yeah. You passed on the mic so you can take it.
So this patient presented with anorexia and weight loss for 1 month. There is lump in the upper abdomen, altered bowel habits. Which investigations will you offer the patient first? Ultrasound. What do you suspect out of all these complaints? Malignancy. Malignancy of which organ? Don't see the CT first, because that is the end. No, he has altered bowel habits also. So, commonest malignancy can be a large bowel malignancy. Then what investigation after ultrasound? If ultrasound says there is a enlarged liver with multiple lesions in the liver, in the both the lobes, and then minimal ascites also, and there is a suspected mass in the left side of the colon. Colonoscopy and biopsy. So what this film is saying? What these are? These are secondaries in the liver, and most probably the commonest primary causing these type of secondaries is the colorectal malignancies. So what are the other differential diagnoses? One is colorectal, then before renal can be stomach, gallbladder. Renal mostly goes to lung first, liver at somewhat later. So mostly the GI malignancy. Okay. Thank you. Sit down. So the next, well, you can stand up. So this is a 10-year-old child had a fall from an under construction wall 4 hours back, sorry. And he had a severe pain over the back. There is no signs of peritonitis as such after 4 hours. What are the possibilities?
That it is a case of traumatic pancreatitis injury. So we will start proceeding with the ultrasound.
But he doesn't have signs of peritonitis.
Pain over the back.
Pain over the back.
May be a possibility.
What are the other possibilities?
Sir, musculoskeletal pain because of the fall, it's just 4 hours ago. So could be that, and could be a fracture in the vertebra as well.
Okay. So how will you go about it? Patient has pain in the abdomen, which is more towards the back. He will not come after 4 hours.
So first we'll give supportive treatment to the patient, and if the pain does not subside, then we can plan for.
You see, patient has come after a trauma. You must do a fast. Abdominal pain after trauma. So
we'll do a fast.
But fast is giving nothing. Patient is still having pain. What next?
So in stable patients, we go for CT whole abdomen. And
so what this CT is saying now, you see.
So this is a
CT has been done in this child, and there is a clear-cut breach between the head and neck region of the pancreas and the body and the tail. There is a clear-cut gap in between. So what has happened?
Traumatic transaction of.
So this is a isolated traumatic pancreatic fracture, because most of the time traumatic pancreatic injuries are associated with duodenal injuries also. But if duodenum would have injured in this child, patient would have come with peritonitis. So mostly these type of child, they come with a late presentation, they don't improve, then we go for CT, and this will be the CT finding. So what will you do now?
Depending on the pancreatic
There is a clear-cut breach. So definitely pancreatic duct is also breached and the enzymes will be released.
duodenum preserving pancreatectomy we can do. Biggest procedure. Biggest procedure. Duodenum preserving pancreatectomy. Because
Main duct is involved, we can go for the bigger.
Why you want to remove head region also?
Duodenum is in pancreatic, because head we have to preserve.
You see, you can do either a stenting and you can repair, or you can do a distal pancreatectomy. Head and neck should be preserved because they drain in the duodenum. Okay, sit down. Now you can stand up.
You raise your hand like this, nobody is looking at you. So the best thing is to have a focused therapy. Yes, madam, you stand. Please identify yourself.
Sir, Dipali Gupta from Fortis Sport Hospital.
Okay, yes.
So the scenario is 40-year man had a road traffic accident 2 hours back. He presented to the ER with headache and slurring of speech. So what will you do?
First we check for the patient vitals. Where after, if patient is stable, we go for the NCPT head.
So you'll follow the trauma protocol, which is very good, and then you will proceed with some specific investigation. So you're happy, Sumit? You want to go ahead?
Yeah. So NCCT head. So what does this NCCT film is showing? What has happened to the man?
There is a subdural hemorrhage. Back-shaped hemorrhage.
Why it is subdural, not epidural? Crescent shaped. That will come in my next scenario. So how will you manage this patient? You have a diagnosis now. It's a large bleed.
So decompression surgery, one hole.
Yes. Sit down. Next one. A 65-year-old man had giddiness and then he had a fall in the bathroom. Presented to the ER with GCS score of 8/15. Possibilities. Stroke. Okay. Then you will resuscitate 8/15 and then
I will intubate and we'll proceed for
CT. What this CT is showing?
impact in the right side.
It is a massive intracranial hemorrhage. So how will you, along with midline shift, because you can see the shift also. That's why his GCS is so low. So how will you manage? Craniotomy, deconstruction, might have to do a craniectomy also because large hemorrhage. Okay, sit down. A 25-year-old young boy had a fall from bike 2 hours back. History of loss of consciousness for 15 minutes, then he is okay. So temporal headache and vomiting, possibilities. He has a transient loss of consciousness and then he regained.
So concussions also, Lucius period, lucid interval. So it's an epidural.
So what is there in the CT?
EDH, epidural.
So you can differentiate now EDH from a SDH by a CT film. So that was crescent and this is lens shaped or biconvex. Okay. Treatment is almost same. No, young lady.
5 minutes now, we finish. 5 minutes.
Yeah. 45-year-old gentleman presented with hematuria for 5 days. There is a palpable right lumbar area lump. So,
The NCCT.
This is not NCCT.
It's a CECT abdomen.
Because you can see the bowel and all, everything is taking the contrast. What is there? Which organ it is?
The renal, right side.
Okay. So, there is a large renal mass along with hemorrhage inside. So, what would be the diagnosis?
Carcinoma. Maybe carcinoma.
Renal cell
Renal cell
carcinoma.
carcinoma.
Sit down.
So, miss, how many more scenarios?
2-3 more.
We have a talk after this.
So, I just come to the MR.
No problem.
Just finish.
Now, okay. Take two more. You can take.
So this is a normal MRCP film. You can see everything in this film. The gallbladder, the right and left hepatic ducts, pancreatic duct, and cystic duct. Even you can see a sphincter of Oddi, and the dye has passed into the duodenum, showing the C loop. So now the next scenario is pain. Patient presented with pain in the upper abdomen with dyspepsia. There is history of cholecystectomy 15 days back. The ultrasound is showing a dilated CBD. So, next investigation. And what is there? So, you can see a feeding defect in the lower part of the CBD. CBD is dilated, both extrahepatic and intrahepatic. And there is a feeding defect. Probably it's a CBD calculus. So what next? This is almost similar picture with multiple filling defects. And here in this MRCP film, you can see the CBD is dilated, even pancreatic duct is also dilated. So there may be a mass sitting on the junction of the ampulla of Vater, which is obstructing both the ducts. So you can see a double duct sign. This film, this is an MR film for a local staging. What you can see? It's a rectal tumor which is being seen. You can see the whole wall of the rectum. So MR of the rectum is done for the localized staging. This is all we have covered. So this is about MR of the breast. You can see a normal, how normal breast looks on MR, and there is a mass. So to conclude, we can always say advancement in understanding of the disease and availability of the state-of-art tools for diagnosis and management have brought the radiologist and the surgeons closer. This has benefited both clinicians and patients alike. But at the end of the day, technology cannot be substitute for a good clinical equipment. You must remember. Thank you.
Brilliant. Thank you very much. You can hear it. This advance is very spontaneous, like it happened with Sean, it happened with you. This is how it should be. They're all awake and happy listening to what you both presented. And I think that takes care of radiology. And thank you very much, Dr.
Thank you, sir.
And we have, we'll have you tomorrow also. So also Dr. Gyan is going to speak on reflux surgeries. We have one talk remaining from the How I Do It sessions. We did 3 field, that is radical esophageectomy yesterday. And we're going to do ripples today by Dr. Tiwari, who is, I introduced him yesterday, senior consultant of surgery at Northern Railway Central Hospital. You saw the skills of laparoscopy yesterday, and you would see them even more now. What you would understand by these procedures that we have included is that the same principles can be followed when you're doing open surgery or laparoscopic surgery to achieve oncologically clear, correct outcomes, and also making the patient outcome better, quality of life also better. Over to you, Dr. Tiwari.
Good afternoon to everyone, and thanks to Chintamani sir for chance of presentation. And it is the same principle that we follow in the laparoscopy as well as.
Hi, good morning everyone. Today operating a case of 53 male with a patient with periampullary tumor. We confirm it by the biopsy as well as CT scan and PET CT.
Okay. So we follow the same principle, and first important is diagnostic laparoscopy is most important. That in our study, 18% of the patient, in spite of MR and CT and PET CT, we got inoperable case, and it is a mesenteric and peritoneal deposit. So these are port plan, and surgeon usually that is staying on the right of the patient, and we usually use a 6-port technique, and umbilicus is the camera port. And first step of dissection that begins with division of and identification of the greater omentum, and we follow the important techniques of dissection that right gastroepiploic vessels after the dissection of the greater omentum and opening of the lesser omentum, that we have to divide the right gastroepiploic vessels. And again here, HD 1000 that using as a energy device, it is a very fast. And right gastroepiploic vessels, we divide it twice, once near to the D1 and again going to the superior mesenteric vein. And after this clearance, we identify the D1. That is a first part of the duodenum. And that is blue cartridge or white cartridge that we can use here. And because all case, unless it is a specific indication that preserve a pylorus preserving vipers, and it is an important post-operative weight loss, vomiting, these all are less. So D1 is identified after the dividing the right gastroepiploic vessels. We have to confirm you are at the right place, and we have to just rotate the cartridge to identify it and then fire. So once D1 is divided, pylorus is preserved, we roll back the whole of the stomach to the left hypochondrium. Now next important steps is all lymph node dissection. And lymph node dissections that begins in all these stations that we follow. This is the rollback of the stomach towards the left hypochondrium. So whole pancreas now and all the station of node that is visible in this area, and ask the assistant surgeon to retract the pancreas down with the another instrument. And this is the method that how we dissect the all the station of node, that is a level 8, and going progressively towards the 12 stations, and ask the assistant just along with the gauze to holding and retracting the pancreas down. And we follow the plane of dissection along with common hepatic artery, just dissecting all the node, and that is pushing it. And this is the level 8 dissection of node, and then progressively going towards the level 12. So that is the identification of common hepatic artery along with the ZDA, and it is a meticulous dissection is needed here. We have to follow the plane of dissection, and we always respect the blood vessels, use a less energy source, and then begins with identification of the Kellogg's triangle and all the fatty tissue and loose tissue that is we pushing towards the specimen side. And again, we use our energy source is the same. Now we loop out the common hepatic artery with the red loop. It is a very important, and ask the assistant surgeon to hold it so that all the nodal tissue that we pushing towards the specimen side, this is a level 8, level 7 nodal station clearance, and we can use here right angle Maryland dissector, which is the excellent instrument, and to identify it. Next important step is GDA. That is a gastroduodenal artery, as yesterday, that is even in the demonstration. So ZDA that we ligated by using the hemlock clip. And once ZDA is ligated and divided, whole of the common hepatic artery is now free. And all the nodal tissue that is near to the hilum, we have to demonstrate it. Yellow loop that we have to demonstrate, take it around the common bile duct. So this is the common bile duct. Again, all the nodal tissue we have to identify. We using a hook, L hook, and L hook is a preferred option to divide the common bile duct, because in the harmonic plane of division is going oblique. So that I preferred putting the using a L hook. Now all the nodal tissue along that retroduodenal and retropancreatic tissue that we have to go behind the retroduodenal area, and all the nodal tissue from that we have to clear it and we have to divide it. This is how you perform the cauterization. That is a cauterization of the duodenum and head of the pancreas. Now pancreas is looped out, and we just plan for the transection of the pancreas. We just loop it out, and we retroduodenal area, we have to deliver the proximal 10 centimeter of jejunum. And through the retroperitoneal that we have to identify, and we have to take out the proximal jejunum, and now jejunal transection, proximal 10 centimeter of the jejunum that we have to identify. Now this, we have to secure it. Now we using a ligature for the devising the proximal mesentery of proximal 10 centimeter. And once it is divided, now it is whole specimen is now ready to divide. Basically, main things is the pancreatic neck. And here I am demonstrating plane of love, which is just posterior to the pancreas. You can see how this portal vein is formed. It is from the left, it is dividing by the splenic vein and superior mesenteric vein, and portal vein is identified. And this is the how we follow this plane. We have to use pancreas transection, and it is depend on the surgeon expertise. Now whole portal vein has been demonstrated from the porta till the how this portal vein is formed by the uniting with the superior mesenteric vein from the left side, and all the nodal tissue that we have to identify, then ask the assistant surgeon to just retract the distal part of the pancreas, and ask the assistant surgeon roll back the portal vein laterally, left lateral, so that we have to perform the complete unsinate process dissection. This is very important. We have to present our instrument close to the SMA, superior mesenteric artery. So once portal vein is rolled back laterally, left lateral by the assistant surgeons, we have to go complete unsinate and mesopancreas dissection. Once it is finished, we have to retrieve the specimen by giving the small incision. And presently, all the cases that we finish by the open reconstruction method. This is the HJ and hepaticojejunostomy, pancreaticojejunostomy. Routinely, we using a T-seal, and it is just to prevent the leakage. We using in all the cases. The patient was stable in the post-operative periods, and operating time is around 5 to 6 hours. Clear SIP we have to allow to all the patient on the post-operative day 1, and pancreatico-jejunal drain we're removing on the 3rd day and HJ on 5th day. And usually most of the patient we discharge on 7th to 10th day. Okay, thank you so much. If any question, you can ask.
You check the EJ regularly, you do that as a routine, any stenting you do, leaving like
Yes, sir. That is depending entirely on the pancreatic duct diameter. That pancreatic duct diameter, if it is small, that is less than 5 mm, we prefer to put a stent inside the pancreatic duct, and we negotiate into the jejunum, and then we have to take the sutures to put the stent to take a suture as well as prevent the blockage. But if diameter is more than 5 mm, we not prefer the stenting.
You do duct to mucosa, right?
Yes, duct to mucosa, classical duct to mucosa, we don't do the Dunkin method now.
But otherwise, are you following any of the modifications using the?
Sometime we stay between the Dunkin and duct to mucosa. We taking if in high risk case, when we do a scoring preoperatively, high risk case of pancreas, that means pancreas is bulky, pancreas is fatty, and it is chances of leak is more. Then we in high risk case we stay between the Dunkin and duct to mucosa.
Anytime you would, because this question is very asked, anytime that you chose to put it into the stomach.
Previously, sir, in since last 4 years, not to use all case we perform the PZ only, pancreatico-jejunal anastomosis. Before 4 years before, we used to do both PZ versus PZ, but now all cases managed by the PZ only.
You understood what happened to the patient. I don't know about you. Now, you understood the stent I'm talking about? It's a little PD tube. We do it almost always, so I wanted to know. We know what we do. We always leave it, and we cut it short and we automatically pass it on. It's easier because you can see the posterior part of that. And then you use boxing sutures on both sides to put the pancreas together. A lot of modifications. I mean, the modified Bloomberg technique is what we have followed, but this also is a good idea. That's not Dunkin. We use the boxing sutures on both sides and taking pseudomuscular on both sides. That approximates, and then only at the end we connect the two. Excellent demonstration. Doing laparoscopy. Laparoscopy is a challenge. In the last American College of Surgeons meeting, I asked you the same question. Are you still doing open, or you would like to do the anastomosis laparoscopically? Any progress in that direction?
Sir, in the laparoscopy, it is a little bit difficult anastomosis because operating surgeon is usually fatigued. But robotic reconstruction is more better option. Robotic reconstruction because flexibility of instrument is more to perform the PJ.
So the PJ is a very, very wide. How much is the distance you keep between HJ and PJ?
We preferred 12 to 15 centimeter. It is a very good question because pancreatic juice, when mixed with the bile, it becomes aggressive and chances of clinically relevant pancreatico-jejunal fistula is more. So we keeping a distance between PJ with HJ is a 12 to 15 centimeter. We keep a loop longer.
That's what I do exactly, and it's perfect. People's is this, and you've shown the classical way of doing it, so you should have any confusion with that. How often have you tried clamping to find out if there's an aberrant right hepatic or hepatic?
Usually that not get it, sir, aberrant right hepatic artery. But in one case, in my series, that I got a right aberrant hepatic artery, which was originating directly from the SMA. And it is a most important challenge for the surgeon because replace right hepatic artery that is coming in your specimen. So when you're doing the unsinate dissection or head of pancreas dissection, we follow the plane, we follow the entire dissection, we bear whole of the replaced right hepatic artery, we loop it out. separate the specimen completely, then we go behind to perform the unsinate
Good
dissection.
point, very good technical point. And the other thing is, any different approach to the uncinate? We saw this, in open, we of course pull it to, the specimen goes to the right, so you're able to pull it away and the vessels go away. And you showed a very good technique to stay closer to the vessels, you're likely to get more clearance. So, we get some very tiny veins joining, so with this, almost everything looks like a cave. But, what precautions do you take? There's the most common site for a positive margin when it happens.
Yes, sir. We follow the unsinate first dissection in many cases. We follow the SMA first approach. It is a very good question. That SMA first approach means we do a cauterization completely. We reach behind the left renal vein, that is just above the left renal vein originating of SMA. We target the SMA, and then it is easy to perform complete unsinate dissection along with mesopancreas resection. So it prevents the margin positivity.
And any situation where you resorted to putting a patient on prophylactic octreotide?
In high risk case, sir, we using it, but still its role is not proven. But in high risk pancreatic leak suspected, we use 3 days of octreotide. It started on the day one of on the day of surgery in the post-operative period, and up to 3 days we continue it.
How often do you see post-cancer you take up a surgery, and what are the challenges you encountered? Where do you find that the stent was a new stent when you start abusing the endoscopy as usual? So where do you find this a problem in your series?
Most important problem that in our series that I got it, one is replace right hepatic artery. It is a very challenging case. Another is that we getting a BRPC, that is a borderline resectable pancreatic CA. It is a major challenging. We take the NSCT first or we take the surgery first. But okay. In stenting case, it is a challenge for the surgeon. That preoperative biliary drainage, nowadays we preferred for most of the case after when bilirubin is more than 10. And we use a SEMS, short metallic stent. It is a better. And we take the case after 4 weeks of stenting. But problem is, in most of the case in my series, post-stenting patient develop surgical site infection. Even perform the laparoscopically, small incision is given for retrieval. We routinely send all the bile, intraoperative bile for culture, stent for culture, and we getting the same organism which is positive with the culture, with the stent and bile, that is getting on the surgical site infection. We using a prophylactic antibiotics, but we can use only on the post-operative day 2 or 3, once it comes positive. So it is a commonly surgical site infection chance is increasing, and it is a challenge for the surgeon. We can't do without preoperative biliary drainage because it is a high risk case. Once it is a compromised renal as well as biliary, both is compromised in jaundice patient.
And also technically, there is a lot of fibrosis there, which makes sometimes the anastomosis a little bit of a challenge.
Yes, it is a oozy, and it is a adhesion is more. It is a commonly that get it.
Last question for their benefit. When you find a tiny duct, you find the duct is not there. Do you dilate? Do you have a system?
Not dilate, sir, but as you saw that we use a harmonic, so it is commonly that found that duct is obliterated. So in the pre-operative, we doing a workup. When a teeny duct, we in the CT scan or MRCP, that we use a knife. So anterior part of the pancreas, we have to divide with the harmonic. But once it is going towards the posterior side at the duct side, we use a knife to divide it. And we identify the duct after flushing with this saline. We identify the duct, and then we put the infant feeding tube of 6 or 4 size.
We always started with knife. I'm talking about forever I've been doing that. Once the duct is narrow, after you cut it, the duct is narrow for the duct to be mucosa, for PJ. Do you dilate it by something?
We only use sometime Jalok and jelly and with the infant feeding tube, and just we put it the stent to just mild dilate. Yes, but Okay.
The tip goes in easily and you just push it. It's not a very good thing to do. It's not recommended, it's not evidence-based. But very narrow duct is a risk. We realize you can get away by doing the modified, Bloom technique, Bloom guard technique.
Bloom guard.
And you may actually achieve by boxing minimal secretion. How many days your usual case would have the drain? It will go on for how long?
Sir, it is depend on the case to case. We usually on the post-operative day 2, this drain is usually start. And when it is a clinically relevant POPF, that means post-operative pancreatic fistula, and it is a clinically relevant, clinically non-relevant. We divide the patient in 2 groups. When it is a clinically relevant post-operative pancreatic fistula, it is started on the day 2, day 3. Drain amylase we sending routinely on the post-operative day 2 and 3. We have to compare the ratio, and if it is a high, we taking as a high risk case, this patient may go to 2 to 3 weeks sometime, and if it not needed any intervention, it is clinically not relevant. But if needed any, again, pigtail catheter drainage, it is a clinically relevant POPF, post-operative pancreatic fistula.
Right, we did that discussion entirely, so you could have asked him separately also because you know each other too well. But it was essential to make the presentation even better. Thank you very much, Dr. Tiwari.
Thank you so much, sir. Thank you, everyone. Thank you, sir.
And with that, we should close the day, or you're still not done because all of you are still sitting. So, is there something you want to ask these 3 gentlemen that are sitting in front? And 2 of us, yours truly, in any case. Yes, please, pass him the mic.
It's not a question, it's a request.
Yes.
Sir, could the questions for the X-ray and the MRI?
They'll be shared.
Thank you so much.
Everything will be shared because you sat through the whole conference. I'll share it with you personally. Because I'm watching those. They were told last year, only registered delegates would get the recording. So we're watching those who attend all the days, they will get it. Any other question? Some questions from them for us. Silence is deafening. So if there are none, thank you very much. And I would like to thank all 3 of these. Of course, I don't need to thank Dr. Ratna. She's there, the backbone in all that I do, all our academic programs. So a huge round of applause for our faculty. And for all of you. Could have been louder, all of you. So thank you very much. Go back safely. We'll catch up in the morning tomorrow again. Thank you. Thank you very much. Thank you, Dr. Thank you, Dr.